हेलो।
पीछे से ना यहाँ पे रख दीजिए।
जगह थोड़ी।
राकेश मुझे एक गिलास पानी देना। मैं डॉक्टर इंदु भूषण को अभी जो ओनली चैलेंजेस की हमारे बायोज है क्या, क्योंकि मैं उतना टाइम नहीं है बायोज जो हमने बनवाए थे वो भी नहीं आ रहे ज़्यादा। मेरा आ ही नहीं है सर अभी, उसके लिए रुकी हूँ मैं।
हेलो हेलो।
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 नहीं आ रहा है ये
टेनी
भी।
चेक करना।
ये भी आ रहा है आवाज़।
एक सेकंड। बज रहा है। नहीं आ रहा है। हाँ ये
इसमें उसमें ड्यूटी लगी है
किस चीज़ का माइक
वॉलंटियर में।
माइकिंग का।
अब पता नहीं हमारे को अलॉट नहीं कर रखा, बस बता रखा रूम। कल
कोई
वो मैम आई थी।
भूमि में बताइए।
क्या नाम है उनका?
मेरा ये है कि समझ के
हेलो। नमस्ते। अरे यार मैं बिज़ी हूँ अभी। काय का नंबर? अभी मैं बिज़ी हूँ, अभी कुछ नहीं कर सकता। थोड़ी देर में कर दूँगा। यार उसमें तो आ ही नहीं रहा ऑडियो, वो ही नहीं आ रहा।
चेक करो।
स्टार्ट करते हैं। हेलो, आवाज आ रहा है? हेलो, माइक ऑन है? Okay. Good morning, everyone. On behalf of Vital Strategies and our partner, the Impact Investors Council, I'm delighted to welcome you for this session on Outcomes Matter, Health Financing for Impact. I'm truly privileged to be here with a distinguished panelist and audience and a gathering of change makers. Let me begin by thanking the Regional World Health Summit meeting organizers for giving us this platform to bring this conversation to life. Outcomes matter. This conversation could not have been more timely. Today, the world, the global financing landscape is going through a tectonic shift. Development assistance is dwindling. At the same time, the world is contending with a confluence of intersectional challenges, crisis, climate change shocks, increasing disease burdens, emerging and re-emerging diseases. All these placing an unprecedented strain on the already stretched health systems. In countries where the health budget remains declined or constrained, we need more than incremental change. We need a paradigm shift, a shift from inputs to outcomes, from spending to value, and from intent to implementation. Today, India stands at a powerful inflection. We've seen bold initiatives. India is emerging as an innovation hub, not just for the region, but globally. Bold initiatives like the Ayushman Bharat PMJY, the Ayushman Bharat Digital Mission, and many more. These are reshaping the way we are thinking. We're thinking of health. It's redefining health. We've also seen, or we are also witnessing, a lot of promising initiatives enabling reforms, the launch of the social stock exchange, the expansion of impact investing, and also early moves into social impact bonds. And yet, challenges remain. And the big question, how do we scale and sustain these efforts? How do we ensure that these translate into tangible impacts? And this is what our conversation is all about. We are privileged to have a distinguished panel of speakers, experienced practitioners. We've got leaders who will dive into this and demystify some of these questions. Our session today very clearly aims to bring out two outcomes. One is they would delve into the systemic gaps, challenges, lessons learned in adopting and mainstreaming and scaling outcome-based models. We will also look at some of the alternative pathways. We'll look at policy solutions. We'll look at the role the ecosystem players bring in to consolidate these efforts. The session is structured around two parts. We'll shortly begin with a keynote address by a visionary leader who has driven one of the country's largest reforms. And then we move to two fireside chats, candid yet focused. So with this, to open this timely conversation, I'm honored to invite Dr. Indu Bhushan, a leader who does not require an introduction. He's currently the president of the India-led Elimination Action Partnership promoted by Pehle India Foundation. Dr. Bhushan is a respected economist, a former Indian bureaucrat, and the founding CEO of the National Health Authority and Ayushman Bharat. He's been instrumental in leading another flagship program, the National Digital Health Mission. May I now please invite Dr. Indu Bhushan on the stage.
thank you very much. Thank you to Vital Strategies for inviting me, and thank you all for coming and joining early morning. And I'm really glad to be starting the conversation about this very important topic on financing for impact. I work on health financing issues and teach some courses at Johns Hopkins. And most of my talks start with the fact that in India or in most developing countries, we invest too little on health. For example, in India, our investment in health is about 1.5% of GDP, which is one of the lowest in the world. We are about maybe number 20 from bottom in terms of amount of money we invest in health. And as Arpita mentioned, that international development aid also is going through a change, big change. And if we take out the money that was put in for COVID-19, we see in real terms a secular decline in support that we are getting for health. At the same time, as she mentioned, that the need for health is going up, need for health financing is going up almost exponentially as populations are aging and our burden of disease is changing from those led by communicable diseases to non-communicable diseases, and new challenges are coming up where we need more money. So what is the solution now? Because we don't have money, and of course we should have more money, because then we can't have any impact if we don't have any money. So we need more money for health, but at the same time we also need more health for money. We need to have more effective use of money. We need to, whatever money that we have, we need to make sure that we invest in right areas and we get maximum out of it. So we do right things, but we also do things right. So that is the way to go. So one way that I think we need to do work is change the way the financing is done and focus on impact and outcomes and outputs rather than inputs. And as was mentioned, that there are a lot of new innovations and new approaches that we have seen recently where we have emphasized outcomes and outputs rather than inputs. But traditionally, as you can see, we've been financing through line budget items, number of beds, resource people, buildings, and other inputs. So focus has been on financing inputs. And if you look at our government budgets, mostly they are based on inputs. And can we finance based on outputs? We can say that the money will flow only if these outputs and outcomes are achieved. So that's easier said than done in the health sector for many reasons. One is that in health sector, when you provide those inputs, outputs come with some lag. It will not, if you want to improve infant mortality or any other health indicator, it will not happen now. It will happen in 4 or 5 years' time after you put in the money. Second problem is that health is a multi-sectoral issue. It depends not only on inputs in the health sector, but also inputs in other sectors. The health indicators may not improve just because we have better hospitals, but we also need better water sanitation, we need better environment, and many other issues that go with the health. So there's another complication. Third is measurement issues, because we have to measure outputs and outcomes. When I was with Asian Development Bank, we used to provide funding for outputs and outcomes, and it was much easier for us to do that in, say, transport sector, because in transport sector we can measure what is the volume of traffic which the road is carrying, what is the trade, or what is the amount of traffic or freight the road is carrying, and we can measure those and based on that we can provide funding. But in the health sector also, things are possible. And one of the earliest one was done in JSY, Janni Suraksha Yojana, where the incentive was given not for inputs but outputs, whether you've taken services, and that actually has helped. Now it's called Pradhan Mantri Matrutva Vandana Yojana, and here the figures are that in 2005 institutional deliveries were 39%, now they're 80%, and there's been significant reduction in maternal and child mortality using that output-based financing. And the scheme that was mentioned, Pradhan Mantri Jan Arogya Yojana, is also one of the schemes where actually output is where the financing flows. It is only after treatment is provided to a poor person that the money flows to the hospital. Earlier in other schemes, you were supporting hospitals, you were supporting doctors, you were providing salaries for doctors, and assuming that by providing those hospitals and services, poor people will automatically be served. And in most cases, it did not happen. And that's why there was a need for Ayushman Bharat, where the financing was contingent on a person receiving services and the particular persons, the set of persons receiving services. So what I'm saying is that in the health sector also, it is feasible to organize schemes and have schemes which are based on outcomes and outputs rather than inputs. And this is the area I think that we need to go more and more to ensure that we are saving lives, we are protecting lives, we are achieving outputs and outcomes rather than supporting inputs. That provides more flexibility to the implementers, and also, as we know that we have huge variance across states and their needs are different, and if we are providing same kind of inputs everywhere, probably that is not the most efficient way of financing the health needs of those people. But if we have to enable output-based financing or outcome-based financing, our systems have to be strengthened, and they need to have a very strong monitoring system so that outputs and outcomes can be measured. They need to have a very strong capacity to plan locally so that the money that is given can be planned and used in the way it is needed. And finally, there has to be strong partnership between private sector, philanthropies, development agencies, and the government, of course, so that all resources can be used together. So we have two excellent panels that will be providing more specific examples of how private sector and public sector both have done, what kind of innovations they've done to do financing which is focused on outputs and outcomes. And I'm also myself keenly looking forward to that discussion and improving my own knowledge and educate myself on how financing can give greater bang for buck. And with that, I want to thank again for your patience and listening to me, and thank Vital Strategies for inviting me to this important session. Thank you.
Thank you, Dr. Bhushan, for the deeply insightful remarks and reflections. We now move on to the Fireside Chat 1 to build on to this momentum. This conversation will bring together leaders from the government, finance, developments, and many more, all of whom have played a very critical role in shaping policy. So may I please invite Shri Ajit Kesri ji, a formal civil servant, and who has served as the additional Chief Secretary of the Finance Department of Madhya Pradesh government. In the interest of time, unfortunately, I'll not be able to delve into the detailed biographies, but we are hoping to display the biographies for your reference. Second, I would also request Bharat, the Executive Director for India at the British Asian Trust, to please come onto the stage. He brings over 20 years of experience in development and management consulting. We have Dr. Himangi Bharadwaj, who heads the Health Life Sciences Policy Team. Dr. Himangi, please, on the stage. For the British High Commission in India, a public health expert with over 15 years of experience, she is responsible for the UK's overall policy engagement on health and life sciences in India. Dr. Harish Ahuja, he is the head product and strategy development, power and carbon markets. Please, on the stage. Primary market relationship and investor awareness services at the National Stock Exchange, and an ex-civil servant with 25 years of experience. Dr. Santosh Mathew, please, sir, please be invited. Yeah, I'm inviting you to the stage. Who leads the social and public finance policy in India for the Gates Foundation. He previously served as a senior civil servant at additional Chief Secretary for the Government of Bihar and Chair of the National Council for Teacher Education. You're coming? Oh, okay, sorry. Yeah. Dr. Indu Bhushan. Yes, sorry, Dr. Indu Bhushan, again, a leader who requires no introduction. I've introduced him enough. May I please request you to please come onto the stage and be seated, or no? Well, just a request, certain ground rules. May I request you all to please keep your mobile on silent, and yeah, please listen to us. Thank you. I missed the most important person, Mr. L.M. Singh. He's the Managing Director for Vital Strategies India and Head of Global Partnerships. He'll be moderating the session. So, Dr.
Thank you. Am I audible? Do I need a mic? Okay, thank you, Arpita. Dr. Bhushan, thank you very much for setting the stage and the context. I think a lot of points which you brought out and India's journey, as well as the need for focus on outcomes, the long-term, the metrics which are required. We felt that India has made substantial progress on many areas, and one area where both our government, as you rightly said, the donors, the private sector has really come along, has been one around, if I can say, innovations around financing. And a big role has been played by some donors who are actually in the room, who've been here before, been my colleagues in starting this. Gautam, one of them, sitting right here. And then many others. So I think, just to sort of set the context from my side, I would speak less and like to listen more, because we have a community of practitioners here who've really sort of taken this thing forward many fold from where it started when I actually did my journey to build a blended finance program and then do few impact bonds. For those who may not know, social impact bonds or development impact bonds, it's really a financing structure. The idea is really to drive innovation in motion, if I had to really put it in a different way. You're trying to actually shift the risk reward, where you're not really paying as a sort of the outcome financier or the government, that could be the donor, but you're really trying to drive that efficiency in that outcome you're seeking by basically paying if those outputs or outcomes are achieved. Now, as Dr. Bhushan mentioned, these need to be measurable. These outcomes need to be, verifiable. And that evidence which it generates, I think it also helps in policy making. And those policies can then further the goal of, scaling them up. So that's broadly the way these outcome-based financing structures work. There have been close to 250 plus which have been done globally. In health, I think they've been lesser. They're not more than 10 or 15, at least 10 I know of. They've been done in different countries on different areas. So, and I think the big question really in our mind and many people has been the sustainability and scalability of these structures. How do you really take something which is piloted by some donor money, some risk investor money, and how do you really scale this? So my job today is actually to sort of get the best out of a very, a distinguished panel. So let me maybe start with Mr. Kesri from the government of Madhya Pradesh, being a civil servant, a bureaucrat who spent, his life in the public domain. Uh, Mr. Kesri, it's never an easy decision for a government to sort of break status quo, if I may say so, and move towards more innovative ways of doing, business or doing whatever public good you're delivering. What really motivated you to be one of those few early adopters of, if I can say, outcome-based financing? And what help us to understand your journey, and and what do you think is really needed to do more to scale these? So, I'd love to hear your views, and essentially, what motivated you, and where do you see those things which need to be done? Thank you.
Thank you. Hello. Sure. So thank you, LM. So basically, when I started my career and I worked through different, so fortunately I had different innovative positions that I could hold, and I didn't spend much of a time in regular routine postings that happen. But what has always fascinated me since when I was working in a World Bank project nearly 25 years ago is that we needed to focus more on outcomes rather than focusing on the process and other things. And government, in my belief, has always been a largest spender of money in different things which would definitely have outcomes. And I personally recently got involved after this new social stock exchange and the SIB concept came in. So around 2 years ago, as finance head, I did manage to make a budget provision for social impact bonds. We were not very clear when we gave that money, but yes, we developed and started our journey from that time. Fortunately, at the same time, NSE came up with the social stock exchange, other people came up, previous experiences had been gone through, and we then were able to then arrive at certain conclusions and move forward. But definitely I see in the present context, see various opportunities, especially in the health sector, in the skill development sector, in the rural development, especially in the livelihood sectors, and especially in the education and the scholarship sectors, that the government provides a lot of money in these sectors, and these are very, I would say, low hanging fruits for people to get into this outcome based financing. As was mentioned by Mr. Indu Bhushan, that Ayushman Bharat perhaps is one of the largest public health schemes which is actually an outcome based funder. Although technically now that I am also for the last 2.5 years involved in running a hospital in the family, which came to me because of certain contingencies, yes, that we do need to improve from the government side in different aspects. What I would like to mention over here is kind of constraints that I have felt that hamper the movement of outcome based financing. Most of them would be typical, and why it is needed for the government is that, see, one question that has always been asked to the government, to the public representatives especially, is that what has actually been done. The public is actually interested in looking into results. They don't want to see the money that we are spending. See, if I have a budget of 5,000 crores for the health and medical education department in Madhya Pradesh, the voter of the elected representative is not interested in those 5,000 crores. He is interested in what is being done for me. So he doesn't look at budgets, he doesn't look at the institutions that he sets up. His interest might be perhaps that looking into the fact that yes, there's a new medical college that is being opened in my area, some facility is being given, so I can expect something, but ultimately his objective is to get a treatment and be healthy. So what I would say is that the first constraint that I feel, and therefore it is very necessary for the government to adapt this kind of because that is the need of the voter, as simple as that. The basic issue that comes in, that there needs to be a greater exposure and a deeper understanding in the government, and what actually an outcome is, and how do you define it in various sectors. Government always has this inherent resistance to change. That obviously would be a major thing. What we are also, the government has another issue, we look at spending money like doing patronage. We are not willing partners into outcomes. So even in the health department and various sectors, our focus is on giving patronage. I am opening a hospital, I am giving you this. We are not willing partners, and we have never looked at these sectors that there is an outcome that has to be given to the public. The basic problem, the fourth point that I would like to mention in the government is that government always goes by a price discovery mechanism and a procurement mechanism. So how do you procure and how do you discover the price? I would give certain solutions that we have gone through in the last 2 years once. Then the next two is the supply side issue. We do not have willing NPOs and service agencies who would be able to, who would be very comfortable going into the outcome-based financing model. Outcome-based financing model also requires, as rightly mentioned, a measurement or an evaluation methodology. So that also perhaps is missing. We have evaluations as which are social audits, different kinds of audits, but we do not have specific outcome-based analysis. I think the net conclusion of this is that the government would say, why rock the boat? See, things have been going along very smoothly. Let us continue in the same way. All these issues that I have mentioned ultimately require one thing. They require a lot of changes in mindsets, exposures, better understandings, workshops, discussions, like these discussions that we are having. So these are the things that are going to trigger this thought process. In the various exposures that I had in India and abroad and other places, I think the basic problem in the country is that we as a country need to think on certain things, not only the government, but as I mentioned, the last 2 points were also related to the service providers and to the private sector. So nobody is out of this thing. So we need to support these kind of discussions, bring out the benefits, try to educate people, try to have discussions, do pilots, etc. Next thing I would suggest is that what happens typically in the government is that a top-down approach obviously works very well. So if, like in our case, what happened that we simply put in a budget of 100 crores for the social impact bond, and then people started working. There was no demand that came in from a particular department, but literally as finance department, we were forcing departments to work. I think the price discovery mechanism is also very important. It's good that based on our various discussions, the NSE, especially for the social stock exchange process, we have been able to convince SEBI that there has to be a mechanism, and they have now adopted a mechanism for the price discovery, because they are going to be service providers, they are going to be different. So I need not explain the different aspects, but definitely those things will have to come in. So I would suggest that these are the issues that we have been facing. The solutions are also very limited. So I think
Thank you, Mr. Kessis. I think that lot to be thought through, lot to be acted upon. I think you've touched some very important areas around measurement, metrics, and mindset and capacity. But one big, and you mentioned about the social stock exchange. I think this has been one, if I can say, a very innovative, if I can say, intermediary structure which was put together in the budget by the Honorable Finance Minister. And Dr. Ahuja, you've been taking this initiative forward. I know it was set up a while ago, but really the activity started in the last 2 years. And what I understand when I talk to people I know, there's a lot of excitement around the social stock exchange. I understand without going into the details of how one can list and what can be done, I think it's a great medium to sort of match make potential projects to investors. And so love to hear from you, Mr. Ahuja, how do you see the potential for scaling these development impact bonds, working with governments and donors, and really how can this really be scaled up, and how can more people participate so that India's development can actually be taken up not just by the government, but people who are willing to contribute in different forms. So over to you.
Thank you, Alan. Good morning, everyone. First of all, on behalf of National Stock Exchange, SSC specifically, I really like to appreciate the effort of Vital Strategies. I think this topic of outcome-based funding needs more wider discussions, and I think all the right players are in the room right now. So, giving you a perspective around National Stock Exchange SSC platform, SEBI allowed us to uh, launch this product way back in Feb 2023, precisely around 23rd Feb. Post 23rd Feb 2023, we have done almost 124 registration. That means around 124 NGOs have come on our platform and registered themselves for imparting the social services which are related to SDG 16 goals. Second is out of those 124, 12 NGOs have raised 41 crore rupees through an instrument called JETC JETP, zero coupon, zero principal. We have basically two instruments which we'll be using to raise the capital for impact. One is JETC JETP, zero coupon, zero principal, and the other is impact bond. In terms of JETC JETP, we have successfully demonstrated 12 use cases. And these 12 use cases, the last one incidentally is from the health sector. So the 12th issue was by Prashanti Balaji Trust, and they have raised 18 crore, highest in the history of Social Stock Exchange of India, for using that money for creating an ICU unit in one of their hospitals near to Anantapur. So answering Indu Bhushan's question, money is coming to health sector through Bazaar also now. Now I'll come, the second question which you asked is how exactly we are contributing to outcome funding. I think I like to set the context very clear here, and I think Mr. KC is leading by example here. The government is showing the sense of urgency and purpose here. They are committed to make it success. This is one. I think keeping in view the policy directions and vision of the government, a regulator is also very responsible and showing accountability also and sense of urgency also. Now when I see the ecosystem player, I think and this dynamics we need to understand very carefully if we like to understand the challenges. And I think my 2 years experience initially with Madhya Pradesh government and then now Uttaranchal and then Assam government makes two things very clear. One, we have outcome funder in the name of government which are very conservative but like to be innovative. Like he agreed that they like to follow L1. You know, I mean, from government to corporate, we learn one thing: we need quality. Don't see L1. But when we are working in the government, we have to also put in L1 mechanism, the pure transparency in terms of the allocation of the work to the right participants. So this conservatism with innovation, how will we absorb this? This is the first challenge we are facing. In terms of NGOs, which have got the belief that they can deliver the results, but they don't have fund. They have got past experience, they have got past expertise, but they don't have fund. How to bring that in the forum? Third very important thing, and I think these are the basically game changer here, is risk funder. They have got the belief, they show the innovation, but they are realistic also. Because unlike JETC, JETP, where though there is no expectation of getting principal or return back, in case of risk funder, they got their principal like to get back, and they like to get their small return also back. So they like to create impact with churning the money by, churning the money and bringing the money into the flow. Having said so, they have to be realistic that the government which they are relying upon, the instrument they are relying upon, will deliver exactly the impact they expect. So I think as an exchange, now here comes the most important role of exchange. I need to set the expectations of everyone in my mind while create the instrument. And here comes my biggest challenge. As a market, we don't like uncertainties. Any uncertainties we don't like. For us, any unknown is discounted. So in case of impact bond at this stage, we are facing many known unknowns and very unknown unknowns, many unknown unknowns. I think for sorting out the known unknowns, we have set the wheel in motion. In terms of unknown unknowns, and I'll clarify that what I'm talking about that, we are work in the progress. So let me give the example of Madhya Pradesh, a case study here for us, everyone to understand this. There's a clear-cut expectation of Madhya Pradesh on two aspects. One, when we give the outcome funding, I'll clearly define the outcomes, but I need that when the risk funder put the money on the table for the NGO, the risk premium which they expect. So let's say for getting an impact of clearly 2-3 outcome given by them, they expect 7% return on their money put on the table. they like to show how this 7% coupon was arrived. And the very clear ask, they want L1 in terms of risk expectation or premium expectation. And I think that mechanism we are putting in place. And how we are doing it? Basically, we have created a new tool called Social Electronic Bidding Platform. So EBP is already there, but now we are creating Social EBP platform wherein the outcome funder, risk funder, NGOs, and the social venture fund can come and discover the risk premium. For that, the legal framework is in place. To ask your second question, sir, very important thing, in the entire process, we have to see that Samaj and Sarkar remains at arm's length from the Bazaar, because Bazaar works very differently and Samaj Sarkar work very differently. So we think that outcome funder and the NGO should be conscious that Bazaar works in a very specific manner. They need a structured instrument. So to set a context here, very important point I'm sharing. Globally, GSS plus, green, sustainability linked and social bond market is around $1.14 trillion. Social bond itself is a $80 billion market, and India, we are yet to see one single rupee. So it's a huge opportunity for us, exchange also, but I think the difficult job for us is to keep the Samaj and Sarkar beyond a level from Bazaar. So that can trust and transparency can come. Thank you very much.
Thank you, Dr. Uja. I think you very well summarized, and I think looking at my journey of my investing career, I saw the stock exchanges come so clearly. I know there's a lot of good yet to come. I think you brought out a good point around the role of a risk investor and the mindset change, because government needs clear measurable targets, they need a pilot. And, I think the next segue, no one better than Bharat. So Bharat at British Asia Trust has been actually leading a lot of this effort of convening and catalyzing some of these instruments, putting, frameworks and money behind some of them. So Bharat, quickly, I know we are short on time for everyone, but love to hear where do you see and what needs to be done more, which can help us to, my goal is to identify those gaps and see what can be done to scale these instruments. Thank you.
Thanks so much, Mr. Singh, and thanks so much to Vital Strategies for having me here and for part of really a critical discussion as I see it, a vital discussion as it were. So I think maybe just before I get to your question, Mr. Singh, I'll just provide a little bit of context on some of the development impact bonds that BAT has worked on. Because I think of the 5 really large-scale impact bonds that we've had in the country, we've been behind 3 of those. The first of these was the Quality Education India Impact Bond, which benefited about 200,000 children, where we were looking at EdTech primarily, and we were saying, what will it take to help improve learning outcomes from EdTech? Right? So again, a lot of focus had gone into the investments, but what is the actual outcome and how much learning outcomes actually improve? Right? So that was the first one. The second one we did was called the Skill Impact Bond, where we said we've done a lot as a country on skilling people. A lot of investments have gone in, but they're really not translating to jobs. And when you think of what the electorate really wants, as Mr. Kesri was saying earlier, it is jobs. Right? So what would it take to actually provide jobs, make sure that people who are getting skilled take jobs, stay on in those jobs for at least 3 months afterwards? Right? That was the outcome that we went after there. And now we are doing something called LiftEd in the foundational literacy and numeracy space, where we are saying, what will it take to actually change the system within the government itself? So working in partnership with state governments to say, what would it take to change the way a block education officer is doing the supervision of a particular school? Right? So what is it that they should go and look for when they are actually supervising a classroom to make sure that learning then happens in the classroom? So that's sort of the journey that we've been on. And I think to come to your question, Mr. Singh, I think there's probably 2 or 3 big learnings that we've had, right, which I think are crucial here and maybe somewhat underappreciated. So I'll spend a minute on each of those. The first is even the definition of an outcome. I think it's easy to say we'll fund an outcome, but what should that outcome be is often something we spend a good 6 months arguing about in the course of putting together an impact bond. So for example, in the skilling space, what is the right way to say, is someone actually in a job? Right? Is it just the placement? Is that good enough? But then, well, people get placed and then they move on to other jobs soon after. So maybe you want to look at something slightly longer term. So then what length of time do you pick? Right? Should it be 3 months, 6 months, 12 months? You could pick many different time periods. And so there is a long period of negotiation between different people who are looking at the problem slightly differently to arrive at what might be an acceptable metric. Right? And that is more of a challenge than one might appreciate from the outside in. So I just want to sort of clarify that, that is something that is worth spending a fair amount of time on. The second big one that I think a lot of other people have also touched upon is the question of how do you actually verify whether an outcome has actually been met or not. Right? Again, in the skill impact bond, this was a huge problem that we had to sort of spend a lot of time unpacking and trying to figure out. Because again, you can say a placement letter may be good enough, to some people that might be, but that can be fudged, that can be gamed, right? So if that's not good enough, then what is? Do I need to look at, let's say, Provident Fund records? But then there are a lot of jobs that are actually genuinely created, which might not lead to a Provident Fund record. Right? So again, what is the right means of verification, I think is something that is extremely important. And again, in the context of the skill impact bond, this was about 50,000 people that we have trained across 4 years. Right? And this was a significant challenge even at that scale. Now imagine taking that to millions of people that you're skilling. It's a non-trivial problem. And if you don't get that right, you might imagine that you are paying for outcomes, but you actually wouldn't be. You'd be frittering away a lot of public money. Right? So again, that is worth spending a lot of time on actually thinking through how do we verify. We see this in government systems all the time, right? Again, other people have made this point, but I remember my earliest experience in public health was in the field of maternal and childcare. And I was in rural Rajasthan going through a lot of registers in primary health centers. And you never saw a child whose birth weight was recorded at under 2.5 kilos. Because it was very clear that that was the weight that was considered a healthy weight for a newborn. Right? And so you just never see anyone born at less than that weight, because then questions would be asked. Right? So a clear example of how the records can be gamed once the incentive is provided. So I think choosing the right outcome, figuring out means of verification, and then the third, I think, is the processes that go along with it. Right? So we've talked a lot about L1, for example. If the general process is to pay for L1, how do you then shift that mindset and say, I'll instead pay for innovations, I'll pay for new practices, I'll provide the service provider with the freedom that they need, I'll give them all of the independence to make sure that they then hit outcomes. Okay, so those are the three things in a nutshell.
Excellent, thank you. So I think last on this panel, but not the least, Himangi, you play a very important role, representing the CEO of the government of UK, level of insistence here. And you can play a very catalytic role, like, USA in fact was being one of those who actually was instrumental in moving this, so UK again. So you have global experience, right? The NHS has done a lot. My confidence. Am I audible? Yeah, so Himangi, what is your perspective, both as a Catholic funder, donor, and who's done many of these globally? What would you say that needs to be done more, and what has worked, what hasn't?
Thank you so much. So first of all, a huge thanks for having me here. It's great to see many familiar faces, both on the panel and in the audience. So I think just a lot has been said, which is actually extremely relevant. So I'll not repeat, but I think given that I have the benefit of coming at the end, I can possibly summarize a little bit. And I think what we are seeing today is a massive shift in the way health is perceived around the world. I think there are three big shifts happening. One is that there is a very strong move from development to commercialization. Where is the money going in? The question earlier many of us faced was, we have this envelope, what shall we do with this? And the question now is, this is what we want to do, where is the money going to come from? And increasingly, that answer is not government. It's not aid. And the question that is almost always asked, and we were just talking about this, a link question is, why can this not be done by someone else? Why does this money need to come from this spot? So I'll say that commercialization move is very important. The second move is national to global. So where a lot of people were always thinking about what are we doing in our system, it's increasingly becoming very clear that none of the systems can actually work without the others. Whether you look at UK, and I'll be very honest about this, and I'll talk a little bit about this, the innovation that the NHS needs is not coming out of the UK. It's coming out of different parts of the world, and it's very much about is the investment in the right place? Are we finding the right innovators? Are we providing the regulatory pathways that are required so that innovations that are coming from one part of the world but can be groundbreaking for other parts of the world are being taken to the right markets? And this cannot be done by governments alone. Let's be very clear. So I'll come to the second bit in a bit. And the third shift is, this is spoken about a lot, but at least in the fora where funding is decided, the focus is shifting very, very firmly from treatment to prevention. Because treatment is being left more and more to industry. It's being left to who is developing the tools, and they will have a marketing incentive. So can the funding then go towards finding the tools that we require for prevention? And when I say prevention, please don't think only of a center where you have, one doctor setting. No, it's very much about, can we have cutting edge diagnostics that can remove the need for, the 5 extra doctors that we need to train, the nurses that we need to train. So we are in a time which probably people have not seen before, I'll say that. And this gives us a unique opportunity to think about outcomes, I think. So coming to the NHS experience very quickly, and I think where some of the learning lies, I think this has been said really well by Bharat. We need to know what is the outcome. That definition, and I'll say, this is probably one of the biggest challenges. Is the outcome that you have provided the vaccination, or is it that the impact has been seen? And this has been a problem plaguing many health systems, and including the UK. We've gone through a whole, long 10, 15-year problem of us saying we should have an outcome group, and then you see the number of vaccinations suddenly increasing across the country. And is it the administration? And there's a very interesting study which I can share later, maybe online, is that the number of people being vaccinated by some GP surgeries were actually more than the catchment population of the GP surgery. So this is a very important thing. What are you measuring? It's been said, but I think when you are defining that outcome, getting different stakeholders together, that is the first thing I will say. Because clinicians will have a very different view, your administrator will have a very different view, the patient will have a very different view. So the more, and it's actually really good to see this happening quite a lot, I will say. Whether it's through the health technology assessment groups, whether it's DTAB, it's ICMR, it's DBT, everybody's starting to think about this, that are we defining the right outcome? Do we have the right people in the room? And there's a lot of experience of this actually from PMJY, sir. We've spoken about this separately when we were doing the UK-India consultation on this. The second big thing is, do we have the right engagement into industry to leverage them? And I will say this because a lot of times we expect this is a fantastic policy document that has been developed by governments. Why is not a big philanthropist coming ahead and paying for this? Well, because there's nothing in it for them. And I'll give you a quick example. We've just seen a big success. I won't name the company, but there is a UK company that has managed to leverage both UK government money, Indian government money, and a big Indian philanthropist money, big Indian philanthropist group, because the solution that they provide doesn't exist anywhere else, and it needs validation in India. So there is a government of India interest, there is a UK government interest, and the philanthropist has come on board because literally we are talking about solutions that can provide you a diagnosis while a surgery is ongoing. So this was my second point, that I think you need to provide the right solution so industry can be bought in earlier. And like I said, this can't be done alone. I'll finish by saying that the third thing that I think currently is very important, and we are seeing this a lot in, I'll say the word and I know everybody's going to smile, is in the AI space. A lot of people are talking about, can AI replace everything? What is it going to do? So I think there's something to be said about thinking about the outcome that you want rather than the tool that you have in your hand. And nowhere is this more applicable in health, I feel. Because what's happening is, this is a great new test that has been developed. Fantastic, let's test it. Does it actually do something that we were not getting earlier? And does the cost effectiveness or cost benefit actually justify bringing it in? Or are we spending money on doing something that's fancy but doesn't really deliver for us? So I know that I haven't gone a lot into the NHS experience per se, because a lot of that is available online and you can always read the reports. But that's where the UK government is. And the last thing to say is, so in line with all of this, I think the UK government's mandate, and you will see this with the new government that's come in last year, is very much to drive growth through supporting the right innovations, through supporting the right tools, techniques, and making sure that government doesn't kind of get stuck in, we are paying for this, so this hence is the best, because that has traditionally been a problem. And I'll stop with that.
That was fantastic. Thank you. Big applause. So I think, I must compliment this panel. I had budgeted till 9:50 and they've exactly stuck to almost that. So they deserve a big applause, right? I think it's never, when I was asked to moderate this, I said, wow, I'm going to have 8 people and make them, there's so much of knowledge and wealth of experience. So how am I going to get the best out? So I think, thank you very much. You touched upon 2 or 3 areas, which actually is a great segue into our next session. And you talked about national to global, you talked about prevention, you talked about, other ways of looking at it, where, we're just not looking to spend that money, but sort of define the outcome. So may I actually invite the second part of this fire chat, and thank you all. So should we just thank them and maybe take questions in the end? Would that be okay? So yeah, I think I'm a bit conscious of the time before they throw us out at whatever the 10:30. I think is a. So thank you. Is it a photograph? Okay. We can take a joint photograph also later, but Dr. Bhushan, up. Yeah, up. Thank you very much. And we'll all interact here, by the way. I don't think anyone is leaving. It took us a while to get in, so nobody's going to get out so fast, I'm sure. But so may I invite our second fireside chat participants who are actually going to lead into some very important questions. So, Mr. Matthew, may I invite you, sir, first? And Arpita, would you, maybe we'll just display the biodatas and their backgrounds later in the interest of time. But
Dr. Santosh Matthew, I can just invite all of them very quickly.
Yeah, could you do that?
Yeah, please. Yeah. So, Dr. Santosh Matthew, I think I'm inviting you for the second time. Thank you for coming on the dais. He leads the social and public finance policy in India for Gates Foundation, and he's previously served as a senior civil servant, as additional chief secretary for the government of Bihar and chair of the National Council for Teacher Education. May I please invite Bhavani Maurya, who's the technical assistant grants for impact investment funds, climate finance and social stock exchange listings, and advising on blended finance structures covering tax, CSR, ESG, etc. Vaishakhi Malik, may I please invite you onto the stage. She's a public health communication specialist, currently leading vital strategies, tobacco control, road safety, food policy, and alcohol prevention communication projects across South Asia. During her 13-year stint at Vital Strategies alone, she has overseen the execution of 40-plus government-led social and behavior change campaigns. Thank you so much.
Thank you, Arpita. So without much ado, I think I'll sort of take the liberty of diving straight in. I think the stage was set quite well by the opening panel of the Fireside Chat on the outcome-based financing. My question here to the panelists here would be a much wider, much sort of, if I can say, inclusive way of looking at financing. I think outcome-based financing is just one way of financing a tool or a structure to achieve the goal. But there are many others, and I think at the same time there are challenges to do those. So may I actually start with Ms. Matthew? So from your perspective, I think you again have been from the in the bureaucracy. You've seen the government, and quite rightly, there's a tussle between the treasury and any department that how much money do I give you and what do I give it to you for? So in your experience, if you had to look at, if I can say, financing in general, and if you had to look at that, that if I can say the inherent tension between finance and health, what are those gaps which you think need to be looked at before, money is put into, let's say, setting up another hospital, or, you heard a lot about the earlier panelists. So I'd love to hear your views from saying what more can be done to make sure that, we achieve more with less money.
Thank you. This doesn't work, but doesn't matter. Hello. Yes, I have a very strong voice. Thank you. See, I'm going to be a little provocative here. As an expenditure secretary of a state in India, I depended on the health department and the education department to balance my books. Because they wouldn't spend. People say we want more money, but we have a situation where you can't even spend 70% of your allocation. So I'm reminded of this conversation where the health minister of my state used to come and say, Matthew ji, hum log ko zyada paisa chahiye. We need a lot of money. I said, sir, you can take all the money you want. But tell me, what are you going to use it for? So he will say, I want more doctors, more nurses, more medicines, more facilities. I said, fantastic. I can give that to you. But sir, before, I'm not even interested in your plans. Sir, can you please tell me what is your imagination of how you are going to make your existing doctors, existing nurses, and existing facilities actually work? And then he said, Matthew ji, aap mazak kar rahe hain. Basically, you're making a joke out of it. It's not a joke, ladies and gentlemen. A thought experiment. Imagine you are a British Airways pilot who's never flown to India. You've crossed the Arabian Sea. You've lost ATC control. There is no radar. So what do? You see a landmass and then you land the plane at the first airport you see. You stick your neck out of the window and see where is it. Oh, this is Jaipur. No. I'm going to Delhi. So it takes off again. Again, same thing. Agra. Again, same thing. Lucknow. No, I've overshot it. So you come back. This is the story of our health system. 400% inflation on the lines in front of you in an OPD. So what does the doctor say? How can I do anything? 2 minutes for a patient. There is literature, serious literature from some of the best universities in the world, which says that on an average, 2.15% is the rate at which people get appropriate treatment. What kind of a health system are you talking about? You're talking about impacts. You're talking of financing. Financing for what? Why should I as a chief minister or I as a finance secretary put money into a situation where even if my daughter needs to get treated, I have to first get an IOU from a doctor. Doctor Sahab, bhej raha hu beti ko, dekh lena. I'm sending my daughter, please look after her. This entire system is a system of IOUs. Now, the poverty in the literature, I'm sorry to say this, and perhaps is a poverty of our imagination. Because you read all the literature, what does it tell you? It's almost as if this medical college only has a department of pathology. Tells you all the things that are wrong. How are you going to solve for this problem? Antimicrobial resistance. 2.15% accuracy in treatment. How are you going to solve for this problem? That's where I think Dr. Indu Bhushan, the work he did at the National Health Authority, both in digital health and in PMJY, is going to be, according to me, the first instance in the planet where we are going to be able to solve for these problems in a cost-effective and a people-centric fashion. But we need a new imagination for that. What is that imagination? That imagination is one of an 80-year-old woman on the wrong side of the digital divide, does not own a smartphone, does not even own a phone, lives in a village without internet, she's illiterate. Imagine her and imagine somebody like you and me on the right side of the digital divide. For both these people, the beginning of our health journey should be the ability to either use an app to be triaged through an adaptive question engine, or for that 80-year-old woman to call and say, beta, I'm having a headache. The starting point is, I'm having a headache. Then the adaptive question engine takes you through a series of questions. What does it do? It actually produces an entry into an electronic health record of your detailed case history. Today you go, I've stood outside medical colleges, I've stood outside PHCs. What does come out in that parchi? 3 medicines and 4 tests. I mean, if you don't have a case history there, how are you going to even solve this problem? But today, India is going to show the way, but we need a new imagination of actually beginning the journey like this. I know you picked up the mic and therefore I will stop.
No, I'm not going to land in Jaipur, I promise you that. Thank you. A big applause for him. I think my question now, you touched upon a lot of problems, and I think, sometimes we imagine healthcare starts at the hospital. And given the NCD burden, given the amount of, urban lifestyle changing, urbanization happening, whether it's the consumption of all these, whether it's, all kind of food and living habits. So I think one big thing, at least at Vital, we've been focused on, obviously beyond data and evidence, is around that people should not fall unwell. They should be more preventive. I think money has to be saved there as well. And perhaps there are ways to save that money and redirect, rechannelize. So my question actually would be to Vaishakhi. And, she has spent a lot of her life and work on social detriments of health, if I can say broadly, preventive, and how you can unlock more money, perhaps through instruments like, I would say taxation could be one. So why don't you tell us to sort of balance Mr. Matthew's view that the 80-year-old lady and the guy who's going to treat us need the same level of information. Before they reach that, how can we do more preventive? How can we do more control before we think about spending that money? Thank you.
Yeah. Thank you, LM, for the question. And as LM rightly put, we at Vital Strategies focus at non-communicable diseases and mostly at the preventive measures, because prevention is key. And so when it comes to cost effectiveness, and when we are talking about budgets and financing of public health programs, there is a package which WHO provides, which is a cost efficient package, evidence based, which is called WHO Best Buys. And when it comes to NCDs, there are 3 critical risk factors which contribute to NCD. And NCD, as we all know, it's a leading killer, and it targets the youth. We have early deaths because of NCDs. So the 3 risk factors are tobacco use, alcohol consumption, obesity. And the WHO Best Buys say that if we address or tackle these 3 risk factors, and of course physical inactivity is also the 4th one, then we can address NCDs. But when it comes to cost effectiveness of budgets, there are certain simple solutions which are prevalent in our policy framework. And of course they have their challenges and gaps, but those are solutions which, if countries adapt, they can make a huge difference. So health taxes, as LM said, is one simple solution. If we raise taxes and excise, it is a win-win approach for the governments. So on one hand, it increases government revenues, which of course the government revenues then can be diverted to public health programs. And of course, with raising of taxes, it reduces the consumption of harmful products, and therefore brings us public health outcomes. So this is one strategy. And there was a report that came up from the Bloomberg Philanthropies in 2019, and which has also been published in 2024 now, which is on a task force on fiscal policy, on public health, on NCDs. And it clearly highlights that raising taxes or public health taxes is a very efficient, and cost-effective policy measure, but it is also at the same time highly underutilized. So, the report concluded that if countries raise their excise and raise the prices of tobacco products, sugar sweet beverages and alcohol by 50%, then over the next 50 years, there would be reduction of premature deaths by 50%, and it would also have additional revenue for the government. So that's one thing. But apart from raising taxes, there are other cost-effective policy measures also. Like in India, we have the tobacco-free film rule policy. I mean, you can Google about it. It is about in the Cigarettes and Other Tobacco Products Act. And it basically ensures that the cost is borne by the industry. So not only the film rule, but then also the labeling when it comes to tobacco packs, or even on the ultra processed food, the labeling which is done. So it also is a win-win approach, because on one hand, people are they're warned about the harmful effects of these products, and therefore make informed choices. But also it basically, the cost is borne by the industry, and so therefore we can have great public health outcomes without having to spend much on it. In fact, media campaigns Public education through media campaigns is also very cost effective. At Vital Strategies, we have done a cost benefit study where we evaluated a smokeless tobacco campaign which was run by the government of India, and the cost benefit study found that a single media campaign, and we have to note that this single media campaign was message tested and it was on a solid media plan, and it brought about additional 17 million quit attempts at a cost of only $0.6, and it also averted more than 120,000 premature deaths at a cost of only $9.6. So these are certain cost, efficient or effective measures that the government can take, and of course the government should prioritize the WHO best buys, health taxes, but it would also require sustained and committed political will by the governments, because there's an industry and the government has to counter the profiteering industries, and they interfere in the policy making of the country, so that has to be also addressed, and the governments need to create a public health narrative on how why taxes are important and why they are a win-win situation for the government.
Thank you, Vishaki. Lot to be. I think you really brought out the need for prevention, and I think what Dr. Bhushan also mentioned earlier on the insurance side, and I think the payment side clearly before. You can ensure many are going missing. I think the PMJY is a global example of 500 million plus being insured. But how do you bring more preventive strategies? Perhaps that's again an innovation one needs to think through. And how can you bring those claim ratios down rather than put people? So I would like to actually go to you, Bhavani, next. You represent the Asian Venture Philanthropic Network, and we heard the earlier discussion. And even what we heard today, there's a need to pilot, perhaps there's a need to convene these, structures. There's a need to share those learnings. And I think AVPN has been playing a spectacular role, at least in Asia that I know, that bringing philanthropists and private sector and donor, and I think what Himangi said, to bring all these stakeholders together and bring those pilots out and see what more can be done. Would you love to share your experiences on, what has worked and where do you see the opportunities to further this financing gap and bring efficiency into it? Yeah.
Surely. Thank you so much, Alam. And it's great to share the learnings which we have had with these multi-stakeholder coalitions and interactions. So to kick a start, AVPN is a network of 600 plus members which are social investors spread across 33 plus markets within Asia, with the goal of mobilizing capital towards impact. And health is one of the impact platforms which we are working under, where the focus is more on looking at gender responsive health systems to impact of climate change on health, but health on climate change as well. Integrated disease solutions from a financing standpoint, and mental health and well-being too. How do we mobilize resources is via the 4 pillars, and that's where I'll try and share our learning journey in these 4 pillars and the programs which we are activating to bring stakeholders together, specifically looking at various ways of financing for thematic focuses. Our first pillar is Connect, where we are bringing stakeholders together to say forums like this, regional or global forums, which AVPN also organizes, and one of those, and by building multi-stakeholder coalitions. One of those coalitions which we have launched, and we'll be speaking about it at 10:45 in the session at room 19, is more on ET Health Alliance, where we're bringing together government stakeholders, stakeholders from CSO, and also financing is one of the key pillars in those discussions, where we are bringing financing, various financing archetypes from public financing to philanthropists to CSRs to commercial financing also come in. And in our previous panel, we heard that there is a need to build such financing instruments by understanding objectives and outcomes which these financing archetypes expect, and then accordingly formulate those instruments as well. Another examples which I would love to share is we have also so in the recently concluded Nutrition for Growth Summit, where we have committed to build an Asian leadership program where we'll mobilize around 10 million USD in nutrition in coming years, and by building that infrastructure for Asia, from Asia. These are a couple of examples under the Connect spectrum. In the Learn spectrum, the focus is more on how can we capacity build stakeholders, be it from the investor side to the investee side, and to bring those learnings. And somewhere in that, I would also like to highlight that we've kickstarted on a journey of doing this research on innovative financing mechanisms, which looks at late stage R&D and commercialization for infectious diseases. So what are those solutions, and even in the pathway, what all instruments can address each of the different spectrum of that pathway of late stage R&D to commercialization, and what role will each financing archetype would play, and then eventually to build those models and deploy in a pilot mode to create a proof point of those instruments. The other, and we do it via workshops, learning circles, and through consultation by bringing different stakeholders' expertise to the report, and hope, and we'll be looking forward to launching this by September. The other pillar is from learning to act, which is actually mobilization of capital. Here we've had launched collaborative pooled funds in past, looking at maternal, child health and nutrition. Now we've also launched the Climate and Health Lighthouse Fund, where one of the focus areas is infectious diseases, which is climate-induced infectious diseases, where we will be focusing on granting and how philanthropy can be catalytic to bringing other forms of capital to the cause. And not only deployment of capital, but looking at capacity building of solutions to absorb new forms of capital, which is really key for bringing them to the stage of then looking at these innovative or outcome-based financing instruments which can be absorbed by them. Which leads to the fourth spectrum, which is the lead spectrum, where opportunities like this, which is global regional policy forums, where we can have these kind of discussions to bring the social investment spectrum into the forefront, to look at how can we activate policy and to mobilize more capital towards various thematic causes such as health.
Thank you, Bhavani. I think, what resonates is the kind of work you're doing is really the foundational work for a lot of money to flow. Hopefully, the pilots should be done. I think even at Vital, our core fundamental belief is that that data-driven, evidence-based policy should then convert to practice and reach people. So I think that policy to practice to people, the way you kind of try to map out infectious diseases, yeah.
And I just wanted to highlight one more point, that these are conversation starters. These platforms gives us these opportunities to then take these conversations beyond the discussions, and we'd love to have those conversations with everyone sitting in the room and to see how best we can collaborate for a common outcome.
Thank you. So my last fireside chat is with the most difficult part, which is related to a lot of times the legal side. You want to do a lot, but you're restricted by the regulatory constraints. And I think India has made tremendous progress in many accounts. And clearly, I'm seeing a growing pool of philanthropic capital in India. The CSR pool itself is in billions of dollars. So when I look at the interest from foreign organizations to come to India, there are restrictions. You look at the, if I can say, platforms like Mr. Ahuja mentioned, the social stock exchange. Clearly, there's a lot of money which can be directed, but legally there are constraints, right? So, Mahapal, love to hear from you. You've been at the center of a lot of this. Where do you see the, more needs to be done to enable greater flow of capital towards these kind of, financing structures?
Yeah, thanks for having me here today. I've worked with most of the panelists on a lot of the products they spoke about, and they, of course, spoke about some of the successes. I can tell you it's been a pretty painful process. Launching some of this has taken years, and I'm going to give you a snapshot of what I'm seeing across multiple parameters. And this will be, I'll bucket it into, technical, commercial, legal, and policy, because we do advise governments as well. I do work on the transactional side, on the advisory side. So, and a lot of the discussions and transactions is also commercial challenges. So if I start off with some illustrative examples, for instance, and especially in the healthcare space, couple of impact bonds we tried launching. They have not launched yet. But the thing is that, one, the person leading the project at the government side changed during the middle of the transaction. The other challenge was before we even got to that stage, and this was I've done two sort of structurings. In one, the healthcare intervention was with respect to tuberculosis, and this is over a 8 or 10 year period. So everybody has learnings, even on the technical side. All the challenges we are hearing about, how to define outcomes. People have gone through the PRAME process, and now they are adapting better sort of proxies to see how to define outcomes. So initially for TB, I remember there was a lot of discussions on what happens, how do we know the outcome has been achieved? Because based on the patient's sort of behavior post the procedure, they could relapse as well. So then when money is tied to it, so then really then how do you decide whether it's our fault or the service provider's fault or not? The second impact bond, couple of years apart, by the time then the intervention was accreditation of medical healthcare facilities, which was fairly easy to verify. You're not spending a lot of time and cost and money in verifying whether the outcome has been achieved or not. So some of those adaptations happen. Now, when I talk about commercial challenges, right, and this is one thing when we are interacting with governments also to keep in mind, because we are seeing governments getting more interested as outcome funders potentially. In fact, the Oxford Outcomes Funding Lab focuses a lot on government funding being switched to outcome funding just as a matter of, awarding contracts compared to the regular contracting process. But coming to impact bonds and outcomes, I think one thing that we saw during some of these transactions also, considering the nascent stage at which the technical ability is there to assess and verify an outcome, and there's a lot of learnings happen. So you don't know. So in theory, in a impact bond, the risk investor takes the full financial risk, right? And in theory that works great. But if you're not able to, if you're not sure about the outcomes, if you're not sure about how it's defined or verified, then who shares the risk? So what we've seen in some of these impact bonds is commercially what parties agree to is not necessarily outcomes, but maybe intermediate outputs as well. It's not just inputs. You do want to peg some money to intermediate outputs, and then you want to peg a final thing or a heavy weightage to the outcome. But when I look at government getting into this process, yes, it's a huge leap forward across a decade. I think we're talking about outcomes, and it's a significant mindset change. But in terms of capacity building, if we are thinking only about it's a black or white, right, and not the steps in between, there is still a bit of, to launch these products commercially, when you start talking to private sector parties and impact agencies, I think that's going to become, that's one challenge I see coming up. The other thing, when I say legal, see quickly again, with the kind of products we have seen. So 10 years back when we started doing, it was a big learning experience for me. We did a $1 billion education outcomes fund, blended finance. Investors like FCDO were interested in coming in as a impact investor, taking less than market rate returns. Philanthropies were interested. We wanted one platform to do all of this. Now legally, we kind of figured a structure that would work. We were willing to issue an opinion. What was great learning was on the commercial side again was that the philanthropies in the room said, listen, we will take financial risk, we will not take legal or regulatory risk. I don't want to do this on the basis of a legal opinion by a law firm. Let the government say in their own voice that this is legal, right? Because I don't want any reputational risk on this. Show me a Supreme Court ruling, this is done. Now, we are talking about financing structures that have never been attempted before. So, so the policy side in terms of government coming out and saying this is pretty critical, and being a part of this, engaging with these transactions and also clarifying the legal space is quite important. And in that sense, in the last 10 years, yes, I have seen more transactions being attempted, more actually making it through, and the regulations also coming up and keeping up with pace. Because in the last 6 months, I can't tell you the number of regulators who have called us for sort of interventions and inputs and the kind of investments they are making. There is a real intent, as Mr. Harish was saying, that regulators, and SEBI has been driving a lot of this, been at the forefront of some of these changes as well. Now, coming to what are we financing, and just picking up on some of the points that Bhavani made, right? I think it's not just outcomes and impact bonds. We do see a lot of guarantee structures. We do, when we talk about blended finance, we talk about, the instruments are kind of, can be repurposed for other outcomes as well. What we're using for climate outcomes or education outcomes can equally be repurposed as a financial instrument for healthcare outcomes. And we do see a lot of lab to market sort of interventions on the impact investing side as well. None of this, to be fair, I don't think solves the problems that Santoshji has said. I think financing, when I take a overarching problem that we look at it, I think we started out with a key point that there are two problems this can solve. One is, I would not see it always as more financing. I would see it as unlocking a better capital stack, a better quality of financing or different pools of money, which is more impact oriented. And secondly, through these instruments, there is potential to perhaps, if you are able to define the outcome, improve the sort of the spending or the outcomes actually being achieved. So I'll pause there.
I think we can open it to the sort of, we got a very houseful audience. I want to thank them as well for taking time and the interest out here. So there are a lot of practitioners who've actually led this movement. I can see here there's Neelam sitting right in front of me. She was one of the earlier ones. Gautam, you want to stand, Gautam, so people know who you are here? So he's been one of my partners in crime in a lot of this work. So if anyone has any questions, and to anyone directed at this panel or the one earlier, please let us know. I think, beyond just the discussion here, I think, as I said, our difficult job was to make sure that we all come together, which we've done. Now, since you're all here, you make the most out of it and interact with them. So any questions? Shiv, should we, okay. Actually, I'd asked him, so then after that, Shiv, you want to go ahead? And then, ma'am, you behind. It's yeah, right in the front. Shiva is always in the front.
No, thank you. Amazing points. I didn't hear one aspect which I wanted to hear from the panel and also from Indu sir also on this, which is the role of social enterprises. Because social businesses do exactly that, right? Straddles the heart of civil society with the efficiency of the private sector. Is that also one of the answers? I'm not saying that is the answer.
So would you want to direct it to anyone in particular, or I'm happy to give my perspective as well, but anyone who wants to take up? I think Shiv's question is that as much as not-for-profits are important, for-profit or social enterprises with a purpose are equally redefining. My personal take is that if all social development goals have to be met, we all know there's a huge trillions of dollars of gap. And the ability to blend profit with a purpose which is socially relevant, and I think India will become it is becoming the hotbed for such entrepreneurs. I see it around, I see it in my family, my daughter who decided to give up a banking career to move in this. But I think, Shiv, to your point, these enterprises again need to be encouraged. I think they also need sustainable sources of financing. To be able to meet those goals. They don't have big donor funding behind them, but clearly and I think the social stock exchange also permits them, right, Mr. Ahuja? I don't know if he's here. Yeah, they permit them to raise money in different structures. So would you want to add more? What can be done for them, Mr. Ahuja?
So the beauty of social stock exchanges is it allows both not-for-profit and for-profit social enterprises to come and raise the capital. Having said so, the JETC JETP seems to be a purely instrument for not-for-profit, whereas I think impact bond or platform like SME Emerge allows social enterprises with creating impact to come and raise the fund. We can have offside chart on this, but I think a stock exchange offer the avenue to them also.
So very quickly, I'll just add a couple of points. So in the evolution of this that I have seen, social enterprises play a very critical role. One I have seen is, we had a little bit of chat about who's defining the outcomes. And I think the point that was made that, we need all the stakeholders in the room. And if you see practically how this evolved, initially it was the non-profits who cared about outcomes as donors defining the outcomes. cut to the chase. I mean, 5 years we have implemented an impact bond. The non-profits that were social enterprises that were involved, for profit and non-profit at that stage, were not really involved in the process. It was the definition was done between, it was negotiated between the risk investor and the outcome funder. A couple of years back, I'm in a conference and it's the NGO demanding a seat at the table, saying, hey, we should also be defining outcomes. Right, and then so that evolution is kind of going on, and social enterprises is, and the other challenge, and why I see that's critical is we have tried structuring impact funds, impact only funds, outcomes based funds, like a traditional fund structure, and we've struggled in the last year to find fund managers who are comfortable managing funds that have nothing to do with financial returns and just outcomes focused. Right, so that is a capacity deficit which I see that's actually being built in the social enterprise, but I do see these individuals doing the work, they're kind of seeding themselves or growing out into other organizations going forward.
Thank you. Okay, sorry, Bhavani, you have a point to add? Okay, so maybe very quickly then we'll move on to the next question. Maybe we can take one or maximum two questions. So yeah.
Sorry,
Bhavani,
I'll just quickly add this point on social enterprises. So earlier we had looked at collaborative pooled funds from a NGO or a charity standpoint, but going forward we are also looking at social enterprises who can apply for these funds, because scaling capital specifically is very critical for social enterprises as well, and we encourage even social enterprises to apply for funds which will be launching also.
Thank you. Ma'am, please
Thank
go ahead.
you. My name is Sonal Mehta, and I have a question maybe to Mr. Matthew or the panelists earlier, the three panelists from the funding organization. Being a social activist, one of the concerns I have, I'm a big one on impact and M&E and all of that, but you try to define an outcome and prevention becomes vaccines, number of vaccines, health becomes number of treatment given, and nutrition becomes the pills that you have given for. The concern is how do we define empowerment, and which has been there for a long time. A transgender meeting we did, a transgender said, oh, for the first time I entered a mall, for example. How do you define that outcome? And the concern is as we go more and more towards impact-based only, there could be an issue of then this softer skills being left behind, and the focus might just be center-based,
okay.
and especially the government.
Thank you. Now, your question is valid. Yeah, Mr. Casey, you want to take it up? And yeah, so I think I just want to qualify one thing. Outcome-based financing is not a silver bullet. It's not something which can cure all things. But yeah, please go ahead, Mr. Casey, then Mr. Matthew for sure.
So just to add on to our experiences, see, it's not necessary to have health, but like we could also have, we also are planning in Madhya Pradesh on social issues, like when we are talking about self-help groups. So the target is to convert them into Lakhpatis. So that was also one of the social impact bonds. And I had also mentioned initially that, see, we see an opportunity, health is one major sector where outcomes are specific, but especially in the livelihood sectors, let us say in the scholarship sectors and the skill development. So skill development and health are being talked about, but the social impact sectors of livelihoods, of giving scholarships, getting specific teaching results is also being thought about, and that is a doable thing according to us. We have tried it in Madhya Pradesh. Thank you.
Thank you so much. So just on your question, I think very, very relevant. And if you look at the NHS mandate, you would have probably seen that the new government has removed the 10-year plan that was built for the NHS. And something new called NHS mandate has come in. Essentially what is happening is that care was being commissioned by care commissioning groups earlier. So the care commissioning groups became, kind of all powerful. And they were defining everything, and so a lot followed. However, if you look at the new plan, it's very much about an integrated care program in the community. It's actually forcing the NHS a little bit to let go of the upper kind of very powerful structures where the money used to lie, to say build the community networks back in, because that was a strength of the NHS but was lost because of, you have the industrial medicalization, etc. So it's a very fine line, I will say, from the NHS's experience, but is being built into the next 10-year plan. And I think we will see changes. And I would have missed had I not said that about the UK, because obviously that doesn't answer your question about India. But I will say that this is definitely in the mind of kind of like people who are doing the planning. Definitely for the NHS, yes.
Thank you, Mike. Mr. Matthew, is there anything else would you want to add to it? And then we'll have to close. I'm sorry we can't take more questions, but the panelists and others would be here, so do please interact. Yes, sir.
I think the solution lies in being able to run a continuing medical education program to which clinicians are nominated based on their review of the treatment practices that they actually indulge in, number one. And number two, making available information to both care seekers and people who should seek care but don't, so that they can make informed choices. Today, it's like boarding a bus not knowing where this bus is going. I mean, you have no clue. And the problem with health is that the expertise doesn't lie just with you as a care seeker, because there is significant expertise that is required. So that mediation is very, 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 very critical. And the family health register, you know, a pregnant woman not reaching out for antenatal checkups, or a child not being brought for immunization, or a 45-year-old whose health screening has not happened, is as important as people who seek care, and their care journey to be mapped, to be reviewed, and for science to sit in judgment over what's actually happening. It's possible today. This is an imagination that was not possible 10 years ago. And as I repeated, we can show the way as a country. Thank you.
Well, thank you all. I think we had time, and a big applause for panelists on this fireside chat. I think Mr. Matthew concluded it rightly. We have the tools today with the country moving towards rapid, development. So hopefully we can all build. So may I request a photograph and everyone, whoever were on the panel. Thank you all. Thank you for your patience in hearing us.
Hi everyone, thank you so much. But we're just prepping for the next panel discussion in the same room. It's a request for those on the dais to kindly make room for the next panel deliberation, please. Thank you very much. We have the next panel deliberation starting here at 10:45 with, thank you, but you can stay back for the panel. So the panel is scheduled to start at 10:45 is with senior government officials talking about how good governance can help improve universal health coverage for India's poor. Those interested, please, you can continue to stay on in this room to listen to some of the most vibrant, visionary government leaders from India.
Test check.
Requesting everybody to kindly take your seats. We're going to get started in a minute. Thank you so much. I think we are good to get started. There are some, hi, there's a seat in the front. Please make sure you get all the seats occupied. Thank you. Yes, exactly. So you'll have the front row seats open as well very soon. Thank you. All those at the back who don't have a seat, you'll have your front row open. So you feel free, please, to come and take the front row. Thank you. Great, I think we are good to go. Thank you. So good morning, everybody. Really happy to see you all in the room. Welcome, a warm welcome to the World Health Regional Summit. I'm very happy to welcome you all on behalf of KHPT that has curated this panel with the support of Wipro Foundation. I think we're going to talk about something really important. How can good governance and collaboration drive universal health coverage for India's poor? And in this room, we are really fortunate to have very reputed, experienced, and visionary officials from both the central and the state governments of India, both as speakers and moderators. So thank you so much for being here. I would like to take this opportunity to welcome our dignitaries onto the stage and request them to take their seats, please. We have with us Mr. Sanjay Kaul, who's going to be moderating this panel. Welcome, sir. Please take your seat. I request all our esteemed speakers, Shri Vijayanand sir, Urvashi madam, Dr. Jane Ralte, Dr. Vinay Goyal, Mr. Amarjit Sinha, please put your hands together and welcome all our esteemed speakers onto the dais. Thank you very much. I'm going to take this opportunity to offer you all a quick introduction to our moderator for this panel before I hand it over to him, Mr. Sanjay Kaul. Sanjay Kaul is a nationally recognized development policy expert with over 40 years of leadership across government and private sector. A former IAS officer of 28 years, he has shaped key reforms in child development, health, nutrition, education, and livelihoods. He recently authored a book, An Alternative Development Agenda for India, offering bold and sustainable roadmap for inclusive growth. I would like to now hand it over to Mr. Cole to moderate this esteemed panel. A quick announcement before I hand it over to him. We are going to be giving you little pieces of paper to write your questions with the indication to the panelists to whom you'd like to address those questions. When the round one of the questions continues, you may raise your hand. Our volunteers in this room will walk up to you and hand over the paper to you, and we'll collect back your question from you so we can facilitate the Q&A session in a seamless manner. I hope my announcement is clear. Thank you so much. Over to you, Sanjay sir.
Thank you, Madhika. Good morning to all of you, and thank you, Madhika, for the introductions. We are wanting to keep this conversation informal. So in fact, that's why there was an advisory to all our panelists that there will be no PowerPoints, so that we have a better dialogue. I am also suggesting that we were to have 2 rounds of discussions. So to accommodate responses from the participants, we'll merge the second round with the question and answers. Again, to save time, you will be given slips. So at the end of each panelist's intervention, please raise your hands if you have any issue to raise. It could be a comment, it could be a question, and put it down so that in the second round of interventions by the panelists, we can use that, use your comment or the question for them to also respond to that. So that is broadly the format that we have. And in no particular order, we would have started the ball rolling with Uma Mahadevan. She flew in from Bangalore last night, but she's felt very ill, so she's not been able to join us this morning. So we will start the ball rolling with Vijayanand. Vijayanand is a former Chief Secretary of Government of Kerala, and for many, many years being a rural development Panchayati Raj man. And why it is critical is that though we are part and committed to a universal health coverage by 2030, to my mind there are 2-3 areas we've neglected, and that's why I think this session today is very critical. There are 2-3 aspects of good public health system. One would be the preventative and promotive health, where it is critical to have grassroots community level engagement. And that's something which even we as policymakers in hindsight recognize, but when we were practitioners we perhaps neglected. So I'm happy therefore that at least two of our panelists have a lot of experience in grassroots level building up systems. Both Vijayanand and Amarjeet, who will speak to you later. The other part which has remained neglected is a linkage between the grassroots primary health system and its referral to a curative services. And we have with us Vinay, who's part of leading the NHM in a state, and he will be talking to you about this kind of referral between the lower level here and the curative here. And since he is a medical practitioner himself, his expertise and experience will be of great value. So the focus, of course, is on universal health coverage, but within that, how can we get collaborations going? It is nobody's case that the health system alone can lead to UHCs. You have integration of sectors like education, sanitation, rural development which come in. You also have to have a much greater cohesion and convergence with communities, households, and civil society organizations. So with Vijayanand, we had this experience. He spent several years in rural development and local governance, as many as 15 years in building Kerala's people's planning movement. During this period, he nurtured Kudamshri, which is one of the most successful self-help programs, and has been active in molding the Kerala Institute of Administration. He continues to be very active with several NGOs, which he which he leads. And he was, as Secretary Panchayati Raj and Government of India, he was the person who started evolving what are called now fairly evolved Gram Panchayat development plans. So Vijayanand, start with you. How then can decentralized governance become nodal platforms for collaboration within the overall health system and across convergence across departments? And could you therefore, given your Kerala experience, also touch on a few successful collaborations that you've experienced? And also, going forward, what are the multiple challenges that you face in community structures, and what, in your view, therefore, should be done to improve the community interface in the specific context of UHC or universal health coverage? Over to you, Vijay.
How many minutes?
I will stop you when we but say 7 minutes.
Okay, thanks. Anyway, what works in a state like Kerala can work anywhere. So a lot of people think that Kerala cannot be replicated. I can tell you it can be replicated. And GPDP is a classic example. So there are what are called F's of decentralization. Many of you would have heard of it. So what worked is to assign these F's of decentralization to the panchayats, maybe urban local governments. When I say panchayats, a local government, more particularly the Gram Panchayat. So you need to give a health function. In Kerala, health, primary and secondary is a local government function. Government supports it. So this clarity you can't do anywhere, but you can assign something like Karnataka has done recently. Then you need some functionaries to work. All the doctors work in Kerala under the panchayat, with the panchayat having powers of disciplinary action, which of course in Kerala are not used. But very importantly, most important part of it is to have some untied fund with the panchayat, with freedom of application, in which case good number of them will spend it on health, or at least on the social determinants of health, if it is not on directly on health. So these are very simple tips for rest of India. Then of course, I strongly believe that you need a planning framework. And don't think, since I worked as Panchayat Raj Secretary, I know panchayats are very, very weak in most parts of India, maybe 80-90% of India, weakest in the most backward portions of India. That's a tragedy. But if you give a participatory planning framework, Amarjit Sinha, when he was Joint Secretary NHM, had structured a community-based planning, which we forgot after that first 2-3 years. Reviving that, if you can do that, you can plan for health even without any formal power, with the panchayat being in the center place. You need not transfer anything as you have done in Kerala. So a bottom-up planning framework, commonsensical, using simple techniques, but with involvement of a wider thing. Second, of course, the next, of course, will be the freedoms. I'm all using the F word. Freedom means you know what you can do. And willy-nilly, in India, panchayats did best during COVID. I would openly say India was saved by the panchayats, the SHGs and the farmers. Otherwise, I don't know what would have happened during the dark 1 year. So this is very, very important. You give them the freedom. Nowhere the panchayats were empowered. They were the front line of government automatically. So in a crisis, even a disempowered panchayat can be a front line of governance. Then of course, the fraternity. Here is the most important answer to the question raised by Mr. Kaul, that is SHGs. Now we have SHGs, more than 1 crore, 10 million SHGs in India. If they have a partnership with the panchayats, they can work as partners. Now it's the official policy of Government of India, but during COVID they did work together. Huge potential. Community and a community-based institution. We call it institutions of the poor and institutions for the poor. Little exaggerated, but that's how we can position these two, and you can structure a relationship, which in Kerala's Kudumbashree, we started from day one. And the results are positive with hardly any negative results. So this is a great, great future because that will give, you can even have health volunteers among the SHGs, and we have the concept of what is called community resource person, and they are doing phenomenally well. The whole of Andhra natural farming, which in a sense is a health initiative, is also done by this thing. Then nothing is ipso facto. Give all this, nothing will happen. You need a lot of facilitation, not direction. Unfortunately, we in government tend to direct, do this, do this. No. not hands off, but trying to facilitate. As a civil servant, I can tell you most difficult thing is facilitation, and not doing is very easy. Facilitation is very, very difficult. Then to continue with the F word, functionings, to borrow from Amartya Sen, converting the capabilities into action is the capacity building. Mostly learning from doing and learning from best practices. I am sure many of your civil society groups create a beacon, a school of practice. Maybe 10 panchayats in India. Others will learn much faster on a hub and spoke model. Then always a roadmap. Decentralization is never stagnant. That's called, I call it future or forward. I used to have 9 Fs in all my talks. But now there's a 10th F, which is the most important F. It can be placed anywhere. It is called faith. You need to trust local governments. I call it soft devolution. You can devolve functions, functionaries, money, everything, but trusting them, yes, you can do. Kerala had 2 phenomenal examples. That is during the flood. Local governments have no formal powers in disaster management. They managed the front line, the first relief, response, relief, initial rehabilitation, without anybody asking them, and coordinated everybody under the sun, though they had no powers. Same thing in the initial days of COVID, which Kerala experience was hailed as best in the world, or if not, one of the best in the world. So all this partnership, this is the way, if you give it, this can be done anywhere. I call it as is, where is decentralization. I have looked at decentralization in so many states. Even after retirement, I am working in 4 states in a detailed manner. All states, some powers reside with the local governments. They are not activated. So with money coming from the Finance Commission, some from local, with somebody sitting together, you can't bring them together. That's political. And we can do nothing about it. The doctor will never be brought under a local government anywhere in India in the near future. But a doctor can learn to work together with a local government. It's more of positioning. It's not, you're using the word convergence, integration. Integration will never happen. Convergence to some extent, but positioning is possible. I am doing this, you are doing this. Let's see each other what we are doing. If that is the basics of planning, I think we have a lot to go. 1 or 2 minutes? Okay. Then what did Kerala gain? When we started decentralization, 28% of Kerala's population was using a public health facility. In 2013, it became 33%. And just before COVID, it is 47%. Is it due to local governments? Not exactly. Do you think NHM works with local governments? Ask him. No. They don't. But after some time, when they are coordinating willy-nilly, everything will fall into place. So, its government has done a lot, NHM has done a lot, the panchayats have done a lot, they have supplemented. The service delivery quality improves because responsiveness increases. When Karnataka did its big bang decentralization almost 40 years ago, some big people studied decentralization. The biggest benefit was improvement of service delivery through fixing small things. Don't think service delivery requires big infrastructure and big this thing. Small things. A drug which is not available, a thermometer not working, that leaky toilets, these panchayats do better. And something which I have learned from palliative care, care of the disabled, panchayats seem to have a natural strength in what I call care and compassion. So much of health is related to care and compassion, and therein you have something to do. So these are some quick things. And that last point on good governance. Panchayats are natural. There are a lot of corruption, a lot of feudalism, sarpanchpadi. I don't deny any of the negatives. But in terms of what is governance? Ultimately, it is participation. I think that makes it different from government. Panchayats are naturally participatory. Maybe very messy, maybe disorderly, but it is participatory, where everybody mixes with each. So trust, close at hand, and access is better. So my proposition, a decentralization, not the Kerala kind of decentralization, on an as is, where is basis, structure it to the local context, and I can give you an assurance which I think I can honor. If any NGO is trying to nurture a cluster, you can take my help voluntarily. Thank you.
Thank you, Vijay. I'm sure you will have an opportunity to interact with Vijay during the course of the discussion. But I would like to now move from decentralized governance to another aspect of health policy, which I think is also remain neglected, and that is the critical importance of research, especially biomedical research, so far in the specific context of biomedical research. It also, as heading the TB division, we'd also like you to touch on the ambitious NTB goal, the pioneering efforts made by the government to accelerate TB elimination, and what you think have been the lessons that your experience with TB have to other disease areas and other health programs, of what can be replicated or learned from other programs, and this interface between, because at least during my period in the health system, the TB division worked in a silo. To what extent has it been able to integrate with other health systems is something which we'd like to do.
How much time? Thank you. Thank you, the hosts. So I think there are several questions. I'll try to do justice in the 7 minutes that you're rewarding everyone. So let me start with the role of research. So any new question, unless we have evidence, the answers may be absolutely lame, You're guessing, you're wondering, and I also believe that if you're copying research done elsewhere, if it's not your own country, you're just aping a published paper without having evidence generated within your own country with your own constraints. That's true for all of us. We have respective constraints in respective countries, respective geographies. In fact, I would say even the pathogen chooses the geography, or the geography chooses the pathogen. For example, we have a plasmid dealing, there's a KPC plasmid, and then there's this NDM plasmid. Everybody is aware of AMR, where China has another plasmid leading to resistance, which is spread world over and causes resistance in the US as well. India, there was a plasmid which was found and was given the name NDM1, tragically so, we debated, but anyway. The bottom line being that the locale, the geography teaches us how to deal with the disease that is also inherent to that particular geography. So over the past several years, we've looked at the epidemiology of TB, but let me first come to conclude the first question. So research is inherent in poising all answers. So we in India have had the strength of ICMR with us, strength of other research institutes, DBT, DST, who actually poured in all kind of support all across the country, supported several researchers, and we have our own answers. So though the research done globally does give us leads, but then we always believe in our own answers, and that is where we are today. Let me tell you, our research, our innovations are actually contributing to the world. So if I now give examples of TB, because that's where it has in fact strengthened the TB program. We started with the first NAT, which globally was launched, the Gene Expert, and immediately after that launch, India got the Gene Expert machines in 2011, where the TB program went on to procure these machines, spread the network across the country. We parallelly started validating an Indian indigenous test, which was a TrueNat. It went through a rigorous validation, tweaking with the test. We came out with a wonderful, several scientists were contributing to the improvement of the test. 2018, the program adopted it, and today it's being exported to 82 countries and plus. So the point being, it is equally good. We've done several studies. We published from AIIMS Delhi in a collaborative multicentric studies on a pediatric TB, extrapulmonary TB, pulmonary TB, of course. The bottom line being, research and validation done by ICMR paved the way for an economical battery-operated system available at the periphery. Now being available with 82 countries, it's economical, so even the countries which are LMICs can afford to use it, and it can go to the periphery. I honor the hard work of our peers here in the panel at the panchayat level, and that is where we have to reach. So under the TB program, what we have ensured since I took over as the technical lead of the TB program at the center, every of our moves has ensured that each of these is delivered to the last mile. We are trying to work hard to ensure that there are no gaps. Of course, it's a vast country. Several issues are already alluded that there are Panchayati Raj institutions strong in some states and not so strong in some others. But we need all of them strong, and then the program implementation, which means to not only identify all TB patients at the farthest mile, but also give them the due care. So while at the center we take all global evidence, Indian evidence, we relook at the evidence by having initial demonstration studies, or unless we are comfortable that this particular regimen is the best for our population, we do not adopt it. We have a wonderful, so that I take pride that the Indian experts, Indian medical experts, and of course the administrative experts as are with us are the best, and the Indian experts can be several times way ahead of what the global experts recommend. So we have all these experts on our panel guiding us, debating. So I'll give you one example. The BPAL-M regimen, which is a shorter effective regimen for MDR-TB, was recommended a little earlier. But what India did under ICMR's research network, we validated the protocol to ensure that our ethnicity, our program implementation, our feasibility, and the outcomes were first done in a multicentric study. When we were comfortable, we went on to adopt the BPAL-M regimen. And let me also tell you, we took global evidence from studies which are still under publication, but yes, interim data was available. We took NTB results, we took practical TB results to help us design a regimen where we incorporated, we did not take BPAL as was recommended by WHO, we incorporated moxifloxacin along with BPAL, so we have a 4-drug regimen. Why? Because the NTB and TB practical studies showed us this leads to a recurrence-free cure. Several publications, whatever has accumulated, several more are in the pipeline, actually gave us the confidence that if we use this, even in our patients with fluoroquinolone resistance, these patients will not have recurrence. So all shorter regimens always have the fear of leading to recurrence. So we wanted, in case a patient completes the treatment and goes back to the community, he may not come back to the system or ignore his symptoms as, this ignoring of symptoms is another issue which was highlighted by the TB prevalence survey done jointly between ICMR and Central TB Division, our National TB program, which actually brought out in India, patients tend to ignore their symptoms. The health-seeking behavior is not very, good. As a culture, we are taught to, probably not react when their symptoms are subtle and not severe. So COVID and TB spread in the same manner, but COVID would lead to an acute condition while TB leads to a chronic condition. So how we modified, in fact, we've just concluded a 100-day campaign, initiated 7th of December. We made 2 major changes, which globally nobody has done. We wanted to pick disease early, so we expanded the disease spectrum to 10 symptoms, which are early symptoms of TB, while WHO recommends 4 symptoms. So I was questioned, this is not recommended by WHO. So my statement was they can follow us. We are trying to pick early disease, asymptomatic TB, and during the campaign, that was our this thing. So because we wanted to tide over this population, lack of health awareness, number one, and poor health-seeking behavior, we wanted all the population. So another additional point, which led us to design the campaign was the prevalence survey, which actually brought out 80% of our TB is amongst the vulnerable groups. So what we did was, we started reaching out. Our ASHA workers at the Ayushman Arogya Mandirs laid down line lists of vulnerable population, diabetics, HIV, smokers, alcoholics, those who have had TB in the past, those who are low BMI. Low BMI, let me tell you, in India contributes to 46%, which may not be the case in other countries. So every country designs for their own. So we started reaching out to these line lists, painstakingly put together by our ASHA workers. They are our last mile soldiers, and started offering them an X-ray, which now we are going to make kind of all the efforts to screen all our vulnerable population across the country, offer them an X-ray which will detect early TB. In fact, even if the patient is asymptomatic, no symptoms at all, he will possibly have subclinical TB if there's an abnormal X-ray. We test this using the state-of-art, globally recommended NAT technology, which I said we are rich in our own indigenous technology. We have 2 more NAT recommendations from ICMR, again, properly researched. So all the research that's kind of guiding program policy. One more thing, if I may allude to, sir, we have enhanced the nutrition initiative under the program. We recognize it's a undernutrition and TB have a two-way role to play. TB worsens the patient's condition due to anorexia, the wasting due to the disease, and also undernutrition leads to poor immune response and hence could reactivate TB, or could lead to infection because the immune response is poor. So the ministry enhanced the direct benefit transfer, which was being given at 500 per month to all patients since 2018. November 2024, we enhanced that to 1,000 rupees per month to all patients throughout the treatment. We introduced something called as energy-dense nutrition support for patients with low BMI, because these patients we lose because of their very severely compromised immune response. These patients can sometimes go on to worse outcomes, which we wanted to take care of. Also, the Nikshay Mitra baskets, which is a CSR initiative, which is actually the vision of our Honorable Prime Minister, and moves with the support of CSR, where again our peripheral level workers are actually effective in implementing the delivery of food baskets. The food baskets have been designed scientifically using all kinds of research. Within the country, we have 5 or 6 big research outcomes which have guided us in designing food baskets. So I must say the food basket has defined amount of calories, defined amount of protein, as we would like to supplement our TB patient for better treatment outcomes, where our SHGs, our Ayushman Mandir level workers are actually very helpful in, like it was said, during COVID, they were our soldiers who ensured nutrition to our population at the peripheral level. We are working hard to retrain our ASHA workers, our CHOs, along with our district TB officers, so that our peripheral level network can take care not only of TB, but along with that also NCDs, which again is another problem in our community, like I mentioned earlier. So the program has a clear view of our aim, where we want to reach and how we need to do it. So I may have not been able to cover all the initiatives the TB program has taken, but I've tried to touch upon them, but I can take questions. Thank you.
Thank you, Dr. Singh. Dr. Singh is in demand, so she has also to leave. But I thought I'd just like to highlight these 2 or 3 insights which I gathered from what. One is the critical importance of research, and within research, indigenous local research. And in designing health programs, obviously, relevance of research is useful, but it is no substitute for doing the work. So I think that is some insight which I have done. The second is the linkage with certain diseases with other sectors. And linkage of TB with food and nutrition is an aspect that she talked about. And of course, that in the entire sleep burden management need close involvement of the community level ASHA workers. So thank you, Dr. Singh. Before we leave, we'd like to formally thank you and give it over to Malika.
Yes, thank you so much, ma'am, for your time. We are grateful that you still were able to squeeze in some time to be with us. Before you leave, we'd like to, honor you with a small memento. I'd request our trustee, Mr. A.M. Rajshekara, to hand over this book to Dr. Professor Urvashi Singh. Thank you so much for your time. Thank you. Thank you, ma'am. And the session will continue. Over to you, Sanjay sir.
So I think we've had 2 aspects of the health system which we've discussed so far. Now let us get down to brass tacks on actual delivery or the management of health services, including curative services. And I would like to use the experience of a serving civil servant, which is Vinay Goyal, who's here with us this evening. Dr. Goyal is an IS officer of the Kerala cadre. He's himself a medical doctor, and thereafter he pursued a master's in public management from JNU, and he's also a postgraduate degree in public health from Bloomberg Johns Hopkins School of Public Health. He has held several positions at the senior level, at the state level, and he currently works as the State Mission Director of the National Health Mission and Project Director eHealth Kerala Government. So Dr. Goyal, turning to you, what can be done to further strengthen our primary health services, and maybe based on the Kerala experience you could talk about that. Secondly, what would be the way that we can strengthen referral linkages between the primary health system and the curative health facilities? Because at some point the two must become part of an integrated system. There are also new challenges which are emerging. The NCDs, plus India faces still a lot of chronic ailments amongst women, such as anemia. Many of them are preventable. What in your view therefore should be the components in the health system which are missing to tackle these new health challenges? So over to you, Dr. Goyal.
Thank you, sir. Am I audible?
Yes, we can hear you.
Yeah. So very good morning to all of you, and at the outset, I'm very grateful to the organizers for having me here, and it's really an honor to be in this panel. I have 3 of my seniors here. Now, coming back to the question, I think a lot needs to be covered. I'll try to divide it in 2 parts. First, I'll speak briefly regarding the referral services and what Kerala has been doing, and secondly, regarding the emerging health challenges and what is Kerala's stand with respect to those. Firstly, I must thank sir for asking me this question, because you can see Vijay Anand sir answered the basis on which Kerala health system is based: community participation, strengthening of panchayat. Now this question gives me a space where I can bring in an element of innovation, bring in an element of technology, bring in an element of health tech, which Kerala has been introducing slowly. So just to set the context, I'll give you some numbers just to understand where Kerala is right now. So we are a state with a population of around 3.5 crore. And if you see the health setup, so we have our rural health setup and urban health setup. We have around 5,000 odd sub-centers. We call them now health and wellness centers or Ayushman Arogya Mandis. Then we have around 500, 600 odd PHCs, around 300 CHCs. We have a cadre of around 26,000 ASHA workers in Kerala. So this lot is managing the rural health. If you come to the urban side now, there is a good more focus on strengthening the urban health system as well in the public health delivery. So we have around 400 urban PSCs, then around 100 polyclinics. So if you add all these numbers, so it comes to around 7,000. So 7,000 plus institutions and community health cadre of around 26,000 odd ASHA workers. So this is my HR in terms of physical HR and human HR, which is basically responsible for taking care of my public health in Kerala. Now, coming to the first question, when it comes to strengthening my referral system, strengthening my health activities at primary level, I think if we see from a health case perspective, continuum of care becomes very, very important as a patient, as a provider also. And especially from the side of a government, from the side of Department of Health, or me as an administrator. For me, my most important objective is to ensure that I have health centers available, which are accessible, which are affordable, and most importantly, the HR giving the services there, they are of high skilled quality. Now, the problem, if we see this entire continuum of healthcare, what is happening right now, and this is where what Kerala has been doing differently. So you see, we have our field health level surveys going on. So we have ASHA workers going on in the field doing our health surveys. So be it data collection with respect to maternal health, be it data collection with respect to screening of non-communicable diseases, screening of cancer diseases. So this is one set of intervention which I'm doing in the field through my field level health workers. Then I have my health and wellness centers, which are the first point of contact for any person coming into touch with the health system. So I have a set of health officials there. They are again doing their interventions in terms of providing the healthcare delivery. And then I have a set of institutions. So these are my referral institutions, basically from a PHC to a CHC, then to a district hospital, and then higher up to a medical college. The problem here is that all these three systems are now working in silos. So my field is not connected with my subcenter. My subcenter is not connected with my health setup, that referral chain basically. So as simple as like creating a unique health ID or a digital health ID for a patient. So what is happening is multiple times, like when an ASHA worker is going to a field, she has to start from zero, start registering the patients, entering the IDs. Now when the person which is screened is coming as a patient to my any of my health center, then again this registration process is starting. When I'm referring this patient to a health center, maybe a PHC or a CHC, then when the patient is entering into the PHC, then again that registration process starts. So it's like deduplication, same thing doing again and again, which puts a burden on my health HR also, which puts a burden on my financial resources also. So here what Kerala has done is a very robust kind of a system wherein we are bringing technology, where we are bringing innovation. So first thing what we have done is all these three systems are digitized in their own spheres. So I have my screening being entirely done digitally. So we have this health app, we call it Shaili Health App, whereby ASHA workers are doing the survey in the field. Now if you come to the sub-centers, I have the public health app, which is being used in a very big number now. So entire thing is digitized. And then Kerala has a very robust system of hospital management system. So we have our own e-health setup, which started somewhere around 2014-15, and we are progressing at a good pace. And if you see the numbers right now, we've been able to digitize around 700, 800 odd institutions, and this all range from my PHC to my medical college. So we have brought 700 plus institutions. Right now what we are focusing is, so once my health worker is coming in touch with you at the field, so with a single health ID, maybe it can be a universal health ID which Kerala uses, or even the ABHA ID, you must be knowing this Ayushman Bharat health ID. So through that one health ID, I am able to seamlessly move my patient from the field when still the person is not a patient, it's still a person, still a part of population. Once I have done the screening, the mandatory health checkup, and if there is something disturbing and the person from that population turns into a patient and comes into contact with my health setup, there is a seamless movement of this patient right from a sub-center to at the last level, which is my medical college. So this is one intervention. Like we are quite actively involved in this. We have created a large number of UHIDs also, almost covered our entire population. And in terms of rolling out our HMS system also, we are doing quite good. Now having said that, very quickly, just want to bring in another element also. Now from a patient's perspective, I just say like, okay, I have your UHID, I have your all the health record digitized. I think that's not enough. And why this is not enough? So I think there are 2-3 problems if you see closely, if you dwell deep into this continuum of care concept. So once a patient comes to a PHC or CHC, and after this checkup, I'm telling now you have to be referred to a medical college or a district hospital for a higher setting. Now, for a poor patient coming from a very poor background, which is not very well aware, not well versed with the health system, navigating a health setup as big as a medical college, as diverse as a district or a general hospitals becomes very, very difficult. And you know, if you see the kind of crowd reaching the medical colleges, how crowded they are. And then one another problem which we have identified is our health institutions, especially in the referral linkages, they are not talking to each other. So once a patient is referred from a periphery to a central hospital, the story stops there. I mean, a medical officer referring a patient to a higher center. Now after that, I'm not concerned whether the patient has really visited that center, whether the patient has skipped that visit, and whether there is any benefit occurring out of that visit. So if you see, like, we take this pride in telling, okay, the OPD in AIMS is maybe 20,000 per day, 50,000 per day. The OPD in my medical college where I have done my MBBS used to be around 10, 12,000 per day. So have we set and analyzed, like, have we dissected the data? whether these are the patients directly touching a medical college or whether they've been properly referred through a linkage channel. So have I done that kind of dissection? So this is where Kerala has tried to bringing in an innovation. So we are piloting a very wonderful project. We have named it, because you have to give some fancy name. So we name it Integrated Health Project. So we are piloting it in Trivandrum, the capital district. So whereby what we have done is we have established a command center which is entirely manned by volunteers. And what these volunteers are doing, so I mentioned like we have this robust HMS system, health management system, where I'm able to track the journey of my patient. So automatically I'm populating the data and generating a dashboard which my volunteers are able to track. So once a referral is generated from a periphery, volunteer sitting in that command control center is able to track that patient. They are in touch with the patient. They are able to communicate with the patient and they help them navigating. So if I'm a person need to go to a medical college, I can simply dial the number and the volunteer sitting there will guide me. Okay, you have a, for example, ortho OPD or you have a diabetic OPD. So you need to go there. Your slot has been booked for this date. And with this, what positive change it is bringing to my referral system is I'm able to generate data and analyze the data. For example, I can have a condition where, for example, I'm just giving an example. Maybe I'm referring too many patients related to derma to a particular medical college. What I can simply do is post a good doctor there in the periphery so that I can cut off this entire referral chain and the patients can be managed entirely there. So this is another innovation which Kerala is doing and I'm very happy to share. And with respect to providers' perspective, I'll quickly sum up, I guess I'm taking a lot of time. Central government is now coming in a big way with this national accreditation standards. So we have our standards very well mapped out for our health facilities, including for a maternal delivery center, what should be the standards set out, what are the standards for my hospitals, and Kerala is doing quite good. We are progressing in a very rapid way, introducing all these standards into our field. I guess these are few things which are coming to my mind. I'm happy to take any questions further. Thank you. Thank you.
Thank you, Dr. Goyal. I think Dr. Goyal has touched on one part of India's health system which really needs reform, and that is the referral system. And it's a two-way system. One, we do have a shortage of hospitals, but then at least 50% of patients who are going to the tertiary level institution should not have been there at all. So adding or doubling the number of hospitals is not going to reform the health system. There has to be a proper system of referral to a health system. That will of course need a strengthening of the bottom tier, which Dr. Goyal alluded to. The second thing, which I think is something which is replicable across the country, is this e-health concept. If you're coming to AIIMS, the patient should come with a digital record so that the AIIMS doctor doesn't have to start the whole exercise de novo. So I think these are great initiatives, and I think if you can write a policy paper on its replicability, maybe Government of India could look at it, because I do feel this kind of policy reforms would be very cost effective in improving the health system in the state. The theme of today's discussion is also on vulnerable groups. And I think I now therefore want to turn to that aspect, and I'm happy that Dr. Jane Ralte is here. So especially vulnerable groups facing or part in getting infected with diseases which have an element of stigmatization. And we talked about HIV/AIDS, of course, TB, leprosy, and these are again groups which are more vulnerable to these diseases. We are privileged that Dr. Ralte can speak on these issues. She joined the Mizoram Health Services as a medical and health officer at the leprosy hospital in Tabung, and she has served in various community health centers, district hospitals. She has a master's in hospital administration from AIIMS and held several positions in the Directorate of Hospital and Medical Education, state referral hospitals. And one great initiative that she's taken was in the area of tobacco control in 2008, where her proposal was selected as one of very few projects globally under the Bloomberg initiative to reduce tobacco use, and her initiatives have significantly reduced tobacco consumption in Mizoram. Also exposure to second-hand smoke. She's played also a very pivotal role in setting up Mizoram's first medical college, and currently serves as the project director of the Mizoram State AIDS Control Society. Dr. Arte, it's in this context that where cultural perceptions contributing to underreporting of the disease, delayed treatment, social isolation, inadequate addressing mental health and trauma, lack of cultural sensitive awareness programs is something which most states face. And in this context, what has been the experience of the Northeast, especially in Mizoram, in tackling, of course, the stigma associated with HIV/AIDS, drug users, and other vulnerable groups, and what lessons do you feel we can take from the experience for other infections, or the treatment of management of other infectious diseases? Would you also like to speak on the role of NGOs, community groups, say sex workers as their groups, and how important are these collaborations in dealing with vulnerable infectious diseases like HIV/AIDS, and how can we also generate greater consensus and designing programs which are more collaborative in nature? Over to you, Dr. Arte.
Thank you, Chairperson. I'm privileged to be part of the panel today. I come from a state which has two international borders. So Myanmar, Bangladesh. We have Manipur, Tripura, Assam bordering us. So the international borders is something which plays an important role because we're part of the Golden Triangle. So the drug that comes into the state, the borders are very porous. So we have a huge drug problem there. And after the Manipur problem, there's more of the drug is being channeled through my state. So when we talk about HIV/AIDS, of course, one of the biggest vulnerable groups for us is the IDUs, the drug users, injecting drug users. So that number, unfortunately, is high. And for us at present, I would have to talk about Mizoram because that's what I'm familiar with, not the entire Northeast. So in Mizoram, about 30% of the transmission currently is because of injecting drug usage. So for us, we have to work, that is one of our biggest vulnerable groups, the youths, the out-of-school youths, the college students, school students. So basically, for us, we have to focus on the youth. And so the injecting drug users are one of our vulnerable, one of our important typologies. Then also, we have being a very conservative state in a way. It's a Christian state, we're conservative. So it's difficult to talk of important strategies, like for example, condom. It's very difficult to talk about that openly. For the church to really take up action regarding condom promotion and even needle and syringe exchange, which is so important if you're going to be reducing the transmission. So that is a big challenge. But we've been trying to do a lot of things. Unfortunately, I think many people, you all would be knowing that Mizoram currently has the highest prevalence in the country at 2.7%. But the incidence, fortunately, has been going down over the years. Since 2017, when we peaked, the incidence has been going down. But the prevalence still remains high because I would say one reason is because we're giving good ART services, we're giving good services, we're doing our testings, we're doing our follow-up, viral load testing, the whole gamut of the NACO, the NACP interventions, that has been taken up very well in Mizoram. I think the last time we ranked at 9th in the country. So we are doing well, but the gap is there. So in order to address the gap, we have been working with a number of organizations one of the biggest NGOs for us. It's a community-based organization. We call them the Young Mizo Association. So the Young Mizo Association is spread throughout the state, and their presence is there, very strong, down to every village. So besides the Panchayati Raj, or for us is the village council, so besides that we have this presence of very strong CBO, the Young Mizo Association, and they have been doing a lot in terms of drug demand reduction, supply reduction, also even for de-addiction for the current users. In fact, there's one village, there are a number of villages, but one village stands out because they decided, along with the village council, the Panchayat Raj, they decided to do a 24/7 duty. I mean, the people from the community. It is not done by it has not been taken up by the government. So they have a 24/7 vigil to guard their village, protect the children so that drugs don't come in. And also they do recognize that there are people who are already affected. So they also have this very positive attitude, and they've been taking care of the injecting drug users and giving them OST, or helping us in giving them OST. So such type of initiatives have been taken up throughout the state. And we also work with another big CBO, which is the MHIP, which is a women's group. In fact, during the tobacco control program also, when we had implemented the program, the MHIP had helped in banning gutka. So those days for us, Tiranga was the main gutka product, which was very famous in Mizoram. So MHIP helped. So in Mizoram, we have the strength of these big CBOs, and they are spread throughout the state. So we're taking their help. We're working with them in different ways. Also, we're getting a lot of external help, from, like, for example, the AIDS Healthcare Foundation. They have been helping us, especially on the touchy subject of condoms. So we just had a Gen Z campaign on International Condoms Day, and that was, throughout the state, it has been taken up in a big way. We're trying to promote condom awareness, safe sex, things like that, which are a little bit touchy for the church or the society on the whole to take up, but we're doing that. And also, we have the Love Brigade. Love Brigade, I don't know whether you all have heard of it. That's where we provide jackets to the two-wheeler taxi drivers. We have a lot of two-wheeler taxis there. So the two-wheeler taxi drivers have been given jacket, and there's a pouch at the back where we put the condoms. And we have been supplied very good condoms, love condoms. So the love condoms are put in the pouch at the back, and so passengers can just take it discreetly. There's also hesitancy for people to actually go to the condom outlets, the conventional condom outlets. So we're trying to think out of the box and see what we can do to provide services in packaging it in a slightly different way. So I think the Love Brigade, also the auto rickshaw drivers, we have a lot of those. So they've given them pouches where we have the condoms that can be easily picked up. So we are doing all those things. Also at the end, if we talk about HIV/AIDS, we need to work with the community. When I say community, here is the typology. That would be the IDUs, or the MSM, or the female sex workers. This type of these type of communities are very important. We need to hear their voice, and I think every state is different. Like Dr. Singh talked about it, country to country. Even in India, state to state, we are so different. Many people don't think I'm Indian. I don't look, probably don't look very Indian. So people from my state are very, very different from mainland India. So we need to have different strategies based on our geographical location and our culture, our religion. And I think it's very important that we work with the different typologies so that we're able to kind of streamline, package it in a way which would be hard-hitting and very effective for the targeted groups. So I think for now that that I can share about the HIV/AIDS intervention in Mizoram.
Thank you, Dr. Alte. So obviously, we have seen the wide divergence in structures, cultural environments that exist in our country, and that's why we are called a continent and not a country in many ways. I now would like to turn to Amarjeet, and rather than the moderator bringing it all together, I'm giving this role to Amarjeet because he's straddled across sectors, across different levels. So Amarjeet, of course, I've known him for many, many years. It's a lifetime commitment to and passion on different aspects of development, decentralized governance. And he has been a senior fellow at the Center, currently a senior fellow at the CSP, the Center for Economics and Social Progress. He's also served till recently as member of the Public Enterprise Selection Board, and before that he was for a few years as advisor to the Prime Minister looking after the social sector and rural initiatives. He's been an IS officer of the Bihar cadre, and his last assignment in government was Secretary, Department of Rural Development. So he brings to this table that kind of expertise and experience. There's much more about it. But you know, bulk of his career has been in the rural domain. He's especially in two sectors, he's contributed immensely. One is designing the Sarva Shiksha Abhiyan, the school education program, and in the designing of the National Rural Health Mission, the new Christian National Health Mission. He's also been very instrumental in introducing governance reforms, and he's been able to make a great transit from being a civil servant to a social civil activist today. So given your rich experience in setting up the Rural Health Mission, could you perhaps, of course, round up this entire discussion and also speak on the critical role, especially of the frontline workers? He was one of the authors of setting up the ASHA system in India. And how can we further empower and build on this great workforce that we have to promote better linkages with the household? Because there's still gaps. And in many parts of India, the first port of call is still the quack and not the ASHA worker. So what can we do to bridge that gap between the household and the community? And how can we also collaborate with your experience in rural development in several sectors which impinge on health systems like sanitation, education, livelihoods? And how can we therefore identify scalable models through this government collaboration? So you have a large agenda in front of you, but 7 minutes. Can I also request the audience that we will have about 15-20 minutes for interaction with the panelists. So who will be? You will be giving out slips, Malika? Yeah, so just raise your hands. So while Amarjeet is speaking, just jot down what you want more from the panelists so that Malika can collect it and give it to me.
Thanks KHPT for this opportunity. It was great to connect with the health sector again after some time, because for many years I have been working in other sectors. So as normally happens, you go back to your drawing board. And my drawing board is the framework for implementation of the National Rural Health Mission. Each of the provisions there, I started looking at from the lens of governance and collaboration, because that is what the focus of this session was. And I realized that in terms of its formulation, there was a large number of people. Dr. Sundar Raman is not here today. Somebody many of you would know about, who contributed immensely. Many others did. In fact, it was a fascinating way in which a lot of the ideas for the health mission came. There were about 14 different groups with the finest of minds from academics, from government, from private sector, from corporate sector, all sitting together on different themes of health. Somebody looking at community health, somebody looking at preventive health, somebody looking at non-communicable diseases, somebody looking at health financing. And the distilled wisdom of all these experts is what the framework document was. And very clearly, a lot of what has been said by Vijayanand sir, Sanjay sir, a lot of that does find a place here. In the sense that if you look at the health mission, if I were to describe it in just one line or 1 minute, what it was, why it was designed like that, there were those 5 balloons. If some of you who've seen the document would remember the 5 balloons. The balloon of communitization, the balloon of flexible financing, the balloon of innovations in human resource engagement, the balloon of improved management through building capacity, and the last one, monitoring against Indian public health standards. Whatever we were doing all these years, we had these 5 balloons in our mind that our system ought to be responsive enough. Today when the discussions were on about the Young Mizo Association, for example, Jane was mentioning, I've had the privilege of knowing some of their work and understanding some of that work. We learnt a lot from them. The YMA is almost like an institution which looks after household families and their needs all their life. Health is one of them. So clearly, the biggest challenge with health is, as Dr. Srinath Reddy puts it very well, every minister in a cabinet is a health minister. If there's an environmental problem, you need the health minister. If there's a development problem, you need a health, so all functions actually come together. Now, given this context, that's why what Vijayanand sir talked about in the beginning, the partnerships at the local level with the community. When you have too many determinants of health, and there are, from drinking water, so many things, when that is the case, you need to converge where it is most needed. And that is at the level of households and communities. Because convergence from above with vertical empires never works. What ultimately delivers, and that one of the very strong evidence-based reason why we need to decentralize, why we need to collaborate, is the fact that all the wider determinants of health in isolation and silos will not give you the same outcome. And there is evidence for this. The Reserve Bank of India 2023, they did a study on devolution in the different provinces of India and their performance on health and sanitation. And you will find that those who have devolved more have also done better in terms of outcomes. So there is good evidence to go for collaborative action. Many of the experiment, untied funding came, as was mentioned by 2 of the speakers, that nothing will happen without untied funding. If I want a medical officer of a primary health center or the auxiliary nurse and midwife of a health sub-center to maintain her premises well, to ensure proper care, it's not going to happen without untied funds. If for everything she used to look up to the Directorate of Health for some resources, no results will ever flow from it. NRHM provided for it on a very, very large scale, and that's why the transformation of many of the primary units could happen. When Dr. Urvashi Singh was talking about TB and the partnerships with the community at the local level, I was reminded how we wanted to be very clear not to make the mistake of doing only supply side and not the demand side. In the case of education and Sarva Shiksha Abhiyan, we realized we made it into a supply side Abhiyan. Far too much on supply side, more teachers, more this thing, more that. All that was needed. But on the demand side, so on the demand side, in the health side, we went in for the accredited social health activist, the ASHA worker. If her incentives and performance-based payments are determined on the basis of her ability to reach services to the people, it will put pressure on public systems. This was a conscious policy decision that, say, the JSY program, the Janani Suraksha Abhiyan, under which you wanted to ensure institutional deliveries. The incentive worked in such a way, both for the family, the ASHA, for everyone, that the woman was brought to the facility for her deliveries. The preparedness of facilities was a challenge, and that's where a lot of work had to be done. But over time, following those 5 balloons that I mentioned in the beginning, some change surely has happened. Otherwise, maternal mortality would not have come down from more than 301 to where it is today. infant mortality wouldn't have come down from where it was 58, 60. It was just stagnating there 2005 to where it is today. So what the lessons are, and to this if I could add, wherever you have the human interface, it becomes very important to subject yourself to scrutiny by civil society organizations on a large scale. A hospital or a health facility is a human interface with a system. Poor people seeking health in a public system. It's an unequal relationship. Where you have unequal relationships, you need the agency of community, community organizations, local governments, and civil society. One of the initiatives under the National Rural Health Mission was what is referred to as the Advisory Group on Community Action, under which the Population Foundation of India worked as the secretariat of the Advisory Group on Community Action. The topmost NGOs and civil society organizations working in health, all of them were engaged for visiting government facilities, pointing out what was not working well, putting their reports in the public, being as transparent as possible, throwing up the points which needed action. Now, unless and until you subject yourself, your public infrastructure for health, to that scrutiny by civil society, you will never be able to ensure the quality of services that you want at the last mile. So, friends, very clearly, collaboration and governance is a subject given today. One could go on and on. But as Vijayanand sir mentioned, what happened in Kerala is actually possible in the whole of the country today on a much faster speed. And the reason for it is, if you look at the southern Indian states, the fact that poverty rates have been much lower in Tamil Nadu, in Kerala, in Andhra Pradesh, in Telangana, in Karnataka, I used to wonder why that is the case. And that took me to some deep dive research, and my book which came out last year, The Last Mile, Turning Public Policy Upside Down. What I found, there were 6 factors, and you really have to turn it upside down. Unfortunately, not much rigorous academic work had happened on the subject to explain why is it that in the southern states, the levels of poverty were lower. When I delved deep into it, I could find adolescent girls in higher secondary schools and higher education is a very, very important factor, but that alone is not enough. When you have adolescent girls in higher education and higher secondary education, the first thing along with it, what changes is the fertility rates go down because age at marriage also goes up. The third factor which is related with it, women have confidence to go out of the house only if maternal and child health is well taken care of, because unfortunately, given the gender stereotyping of responsibilities, if a child falls ill in this room, how many men can raise their hands to say that they took leave because the child was unwell? It's always the mother. Not the right thing, but that's the reality. And because of which, if you don't focus on primary health simultaneously, the southern states had a better primary health system. The fourth factor, which is very important, when you have studied up to class 10th and 12th and gone into colleges, you have access to vocational education as well. You have access to becoming a nurse, you have an access to becoming an IT person, you have an access to join ITIs, polytechnics, many different places. It opens a new window. The fifth factor, which seemed quite important in all these states, is the formation of women's self-help groups. When adolescent girls go to colleges, go to higher secondary schools, cycle together or on public transport, it creates a new identity for them. Nobody's wife, nobody's daughter, nobody's sister, but a woman unto her own. And that really makes a difference. The sixth factor, and the last factor, along with this, Dr. C. Rangarajan, as the governor of RBI, 30 years ago, took a very, very progressive decision. And that decision was that women's self-help groups will get credit up to rupees 10 lakhs, 1 million, without any collaterals, no mortgage needed. That has been raised now to 20 lakhs, 2 million. These 6 factors together seem to explain to me why poverty was lower in the southern states. The good news is the secondary completion in almost all the states of India, or secondary enrollments at least, have gone up considerably. almost near universal in many states now. The women's self-help groups are a reality under the Rural Livelihood Mission in all the parts of the country now, almost all. Some pockets still left in Rajasthan, Madhya Pradesh, UP, but otherwise Bihar, Jharkhand, Odisha, Assam, all the states, the women's collectives is a reality, which means it provides that window for a PRI-SHG partnership, the Panchayati Raj institution and the self-help group. The collaboration can go much faster, much speedier. If the health unit is seen as a horizontal platform of services and communities are seen are the enablers, we now need to connect households to health facilities. The NHS model of UK should work in every village of this country, where the household knows where. Yeah.
We have another event.
Yeah, I'll just close.
So you know, you will need to respond. I have about 20 questions.
Yeah. The last point I wanted to make was connecting households to health facilities. More than anything else, technology is only a means to an end. It is not an end in itself. So while technology is useful, if we are not able to connect the household to the health facility, I should know if there is anybody unwell who I should get in touch with. That has not happened yet. That is more powerful than any ID that you give me. That ID is useful only if I can do that with full confidence. Thank you.
Thank you. So I think Amarjeet could have kept you actively engaged for the entire day, but unfortunately we have another event starting immediately, so we have to just close out at 12:15. I have a lot of issues which are raised, and in the set of issues raised, Vinay is the most popular guy, so there are a lot of issues on the working of the referral system and whether HMIS is really working, what needs to be done to strengthen it. The issues of surveillance have been raised. Then the other questions which have been asked of Vinay relate to I'm losing track now. You mentioned too many apps. Is it actually being managed by how do the local level functionaries deal with all these apps? And you've got apps at different levels. So basically rounding up of the practicality of what you're trying to do and its replicability to other states. So that is a question for Vinay. For Vijay, I think if you could, based on your experience, Kerala has been a great model for decentralization. What should be done for states like UP, Bihar, Jharkhand and Bihar, and states which don't have such strong Panchayati Raj institutions? So how can you address community level engagement in those states? That is for Dr. Ralte. There are a couple of questions. Where is Dr. Ralte? There's some more details they want about your tobacco consumption Bloomberg initiative. Something about on that, and I think there's Amarjeet. There's one question relating to Bihar, which is on alcohol and perhaps the impact of prohibition, which is good or bad. So if there's time, if you could address that. There are several others which I don't know. Two more have come into Vijay. So good governance and linkage to sustainable development goals is the question to Vinay. So maybe I think since we have to close out the next 7 minutes, Vinay, if you could spend just a minute each.
Yeah, so very quickly, just to sum up, I think all the questions raised is basically the Kerala e-health system and all the health tech we have been bringing in Kerala. Are all these sustainable? So I must frankly admit we encountered a lot of challenges. So we started with our mission somewhere around 2014-15, and as I mentioned, we have already digitized around 750 odd institutions. But now when we are going to scale it up further, obviously there are challenges. We have 700 more institutions left, which needs to be brought into this domain of e-health. Like when it comes to technology, there's a standard saying every 2-3 years your technology changes. So you need to stay upfront with that. All this comes at a cost basically, and managing such a big health tech system at such a large scale, serving a population of around 3.5 crore, that's a challenge in itself. Just to give a small example, so I was contacted by one of my medical colleges, and they were planning to bring in this PAC system for their radiology. Now, when it comes to PACs, the question which comes in front of us is whether we need to go individually with each medical college. Each district in Kerala has a medical college, or we need to have a system which takes care of like the entire state integrated system. So I think herein comes the role of setting the standards and interoperability. You ensure that all your systems are integrated, and the National Digital Health Mission, which has come up, I mean, they're working a lot on this field, and they are in a close liaising with the state, helping us to follow all these standards, as simple as the health ID. So Kerala is going with that UHID, but now we have to set our systems in a way that the UHID for a citizen of Kerala is ultimately integrated with the ABA Health ID. So patient even going outside Kerala, all the records, all the medical records, all the medical history is seamlessly carried outside Kerala also. So yes, just to sum up, challenges are there, but with proper guidance from the national missions, we are doing quite good in this. Thank you.
So Vijay, if you could speak 1 minute on how you can, what kind of structures would be applicable to other parts of the country.
Exactly 1 minute. Do an assess various powers of the local government in the state. Second, find out the resources available to them, including voluntary effort. Third, what is called responsibility mapping. Who will do what? Sitting together. You can't transfer anybody to anybody currently. So the doctor, some key persons can sit together. And there are a lot of low cost, no cost activities, most of which are related to health, which can be carried out by the SHGs and the panchayats, of course doctors facilitating. Human resources is the biggest problem, and the capacity, which of course CBOs, CSOs can supplement, and the community resource persons from the SHGs can supplement. Putting all together, develop a local planning methodology, which is participatory, commonsensical data, local prioritization, local involvement, and this the SHGs can do, this the panchayats can do, and we have two instruments officially there, the GPDP for panchayats and the VPRP, Village Prosperity and Resilience Plan for SHGs. You can make it happen. All the best. And again, reassuring, if anybody wants continuous assistance and willing to take the lead in creating a cluster of practice, I am willing. Thank you.
So, thank you, Vijay. Dr. Dalte, there's of course a question of tobacco, your initiative. There's also a question from the AIDS Healthcare Foundation of Nepal, who wants to know what you can recommend for replicating the successful targeted programs focused on vulnerable populations, is relevance to a country like Nepal.
Thank you. Quickly. So the NFHS highlighted that Mizoram has the highest tobacco use prevalence in the country. So we applied for the BI grant, Bloomberg Initiative to Reduce Tobacco Use. We got it. And the GATS, subsequently, the Global Adult Tobacco Survey, again showed that we're #1. But after the intervention, we focused mainly on smoking, so as to reduce the second-hand smoke, and also sale of tobacco products to minors, around educational institutions and advertisements, all those things which are there in Kotpa. So we focused on those, and I'm very happy to see that with the intervention which were taken up throughout this state, 3 grants were implemented, and after that the prevalence went down, actually then we became #2. So we were very happy to lose our first position quickly. Then the second part about AHF Nepal. What we have done in Mizoram is we have come up with certain projects like Project Homecoming, where we wanted to reduce the proxy pill pickup, because because of the stigma and discrimination, the patients are, the HIV positive people, PHI, are not coming to our service centers. So we have the project Homecoming. So we're trying to reduce the proxy pill and get them back. So we're giving them medicines like vitamins and PPI and other things. So that has been bringing them back. Also Project Revival, because there are people who have LFU left to follow up. So we have been able to get these people back by interacting with them, by sending through the YMA. We talked about the YMA. So we help track these people through the YMA and through the village, the Panchayati Raj there. And we're trying to get as many people back into the system so that we're able to reach our 95 goals.
What is your recommendation for Nepal?
So so if you can do like the Project Homecoming, the Project Revival, so these are things which are targeted especially for the vulnerable groups. I think that really helps. And getting the viral load tested, so we sent out, like for example, we have bike outreach workers. So very, simply these bike, they can go into all the, even the very isolated villages. I think at a geographical, the thing would be almost the same, lots of mountains and hills. So we have about bike outreach programs which go, and we're able to, another good thing that we're doing is through the bike outreach, we also go to the pregnant women who are not able to come to our facilities because of the distance. So they go and do their testing, and if they become positive, they go and give them ART, and we follow up through the mobile bikes.
Thank you, Jane. Amarjeet, of course, there are two questions relating to you. One is this dilemma that I think government also faces of ASHA workers. Should they be given a fair wage and remuneration, or should it be incentive based? Your take. And now you've on both sides, so maybe a balanced approach would be the right thing. And of course, this whole issue of alcohol, over alcohol consumption of Bihar. And you will have the last word, but not a very long word.
Kerala also had a strike recently, right? Yeah. No, I think the ASHA worker, the idea of her being a performance-based payment person was, as the name suggested, she was an activist and not the last rung of the government system. It was never ever thought that she should be underpaid. In fact, if at all, performance-based payments ambit should keep expanding to be able to provide her even higher than wages, higher than salaries. But the intent was to make her be of the community. Unfortunately, the performance-based payments have not kept pace with the ambit of work expansion. Her skilling was also an important responsibility. There was a vertical movement or a upward movement which had been thought of. ASHA workers becoming ANMs, and thereafter becoming GNMs or staff nurses. The career progression for ASHAs, the skills with them, good enough for them to be able to get other work and so on. On the Bihar alcohol prohibition, the Jivika Didis, the self-help groups of Bihar, the Chief Minister had to bring out the prohibition policy because of the women from rural Bihar. They insisted that women's self-help groups that we will not have anything other than this. In terms of the impact, if you move in rural areas, you do see that a lot of things have changed. The patterns of family living have changed on account of this. But obviously, the challenge of enforcement of regulation is always there. In the urban areas, less so. The easy accessibility and availability continues in many pockets. So those are challenges. But clearly, the demand came from the women of Bihar, rural women in the Jivika movement, that we must have prohibition, and their lives are much better ever since this has happened. Thanks.
So I'm very happy Sena sir answered that question on ASHA workers, because I'm the one facing the heat in Kerala for last 70 days being in NHM.
So I'd like to thank all the panelists for this wonderful insights experience. Also for adhering to the time, and may have sounded a little harsh, but unfortunately there was no other option because there's another event which has to take place. And over to you, Malika.
Thank you so much. Really appreciate all the conversations and the active engagement, I think, from everybody in the room. Really, it was a very insightful panel deliberation. Thank you so much for all of you to have made time to be here. I would like to now request Praveen Bichagondanahali as a representative from Wipro Foundation to hand over the token of appreciation from our behalf from KHPT to all of our esteemed speakers and moderator. Sanjay Kaul, thank you so much to moderate this event, and you managed to really keep time. Really, I think it deserves a big round of applause, and also being extremely inclusive in taking everybody's questions and putting it all together to the speakers. I would like to now request Praveen to hand over the memento to Sri Vijayanand sir, please. Yeah, sorry, there is really no order. I'm sorry, I'm making you do back and forth. We can do one after one. Yeah. Thank you so much, Vijayanand sir, for flying in all the way from Kerala just for these few hours to be here with us. Thank you. And I think you must consider taking his offer very seriously. Those of you who are interested in decentralization and some sort of guidance in terms of conceptualizing it and seeing how it works in your regions, geographies, you must reach out to him. Thank you so much, Dr. Jane Ralte, for being with us. I think we were very keen to bring in the Northeastern perspective to the table, and it was very intentional to have her here as part of this panel. Thank you so much, ma'am. Dr. Vinay Goyal, thank you so much for being with us. Mr. Amarjit Sinha, thank you, sir. We hope to connect with you again to hear more. Sincere appreciation to all the panel members to be here, and also want to make a quick announcement that we have a very interesting community charcha. Perhaps you're not going to find a panel like this in the World Health Regional Summit. It's a conversation with grassroots leaders from varied, diverse, vulnerable communities who are going to be speaking about their journeys from 12:30 to 1:30, room number 20. Thank you so much. May we all have a photograph, please, with the panelists. Yeah, thank you. Dr. Jain.
You share my number.
I would like to make a quick announcement. Somebody's dropped your official ID with us here. Somebody's Aadhaar card we found it on the floor. Mr. Parmar, Trushar Kumar, Dashrath Bhai. Are you here in this room? Okay, clearly no. Okay, we'll figure out a way to get this across to you. Thank you. Hi. Yes, yes, yes. Most certainly.
going there in room number
20 वाला भागना है अभी मुझे संभालना है.
अभी इसका टेबल साइड
Mic. Hello, hello. Yes.
रख दिया ना आपने?
हाँ आप करो
नहीं हो रहा है।
एक सेकंड
ऑन कर दो। भूल गया।
एक सेकंड एक सेकंड सब अलग अलग फाइलें खुली है ना पर कौन सी थी ये वाली थी ना प्रोजेक्टर
स्लाइड ही थी।
कुछ नहीं होगा हाँ हाँ 3-4 स्लाइड खुली है ना उसमें हैंग करो सर ये पेन ड्राइव
रख दो।
हाँ रख दो फिर हेलो
On behalf of WHO India, I'm honored to welcome you to this session, Advancing Health Equity Through Midwifery, Strengthening Education, Practice, and Respectful Care. As you are aware, the Ministry of Health and Family Welfare has undertaken a significant milestone to integrate midwifery practice within existing maternity care systems. This initiative aims to promote a positive birth experience, reduce unnecessary interventions, support natural childbirth with empathetic care, and enhance the overall pregnancy and childbirth experience for women and family. Over the past 7 years, the program has made substantial progress, including the establishment of national and state midwifery training institutes, development of curricula, and the implementation of training and mentoring programs. This summit has given us the opportunity to reflect on best practices, facilitate cross-learning, and strengthening the implementation of the midwifery initiative in addressing health inequalities and ensuring respectful care for all mothers and newborns. So today's session is both a celebration to our progress and a call to action to do more. Let this dialogue spark new partnerships, inform policy, and continue our collective journey toward building a resilient, respectful maternal health system in India. This session aims to bring together key stakeholders from government, international organizations, academic institutions, philanthropies, and healthcare foundations to share insights and collaborative strategies for advancing midwifery education as well as practice in country. So the first session will be keynotes from Dr. Rodrigo offering WHO representative to India, Dr. Pavan Kumar, Additional Commissioner in charge, Maternal Health and Immunization, and Dr. Janvi Nilkani, founder and chairperson of the Ostrika Foundation. And this will be followed by a panel session of experts, and our panelists are Dr. Savita from Bani Bilas Hospital, Ms. Indrajit Kaur from Fernandez Foundation, and Dr. K. Aparna Sharma from AIMS, Delhi. So I'm very happy and would like to invite Dr. Rodrigo for setting the context and setting WHO's vision and support to the midwifery initiative. Thank you. So Dr. Rodrigo is the WR since July 2020. He comes with a rich experience of over 25 years in public health. Before taking up this current position, he was the regional emergency director for WHO CRO, providing strategic technical guidance and operational leadership for response and recovery from emergencies, including not limited to India Ocean tsunami, Cyclone Nargis in Myanmar, and so many others you can see in slides. He leads a team of over 3,000 personnel in India, providing technical and field assistance to the Government of India for optimization of services across several public health programs. We are proud to share that he is a recipient of WHO Director General's Reward on several occasions, including Excellence for leading the WHO Country Office India response to COVID-19, leading the team in Nepal earthquake response and recovery 2017, and is team member for India's integrated health information platform. So please, WR.
Thank you. This is the second time you've seen it. Next time, please just say my name. Thank you so much. Well, first, our chair from the Ministry of Health and Family Welfare, Dr. Pavan Kumar, our additional commissioner for immunization, maternal child health. Our esteemed panelists, Dr. Janavi Nilikani from Ostrika Foundation. Of course, we'll call our other partners and panelists later. But thank you, all of you. It's a full house. I guess that's the whole ethos of the importance of this event. The health of mothers and babies is the cornerstone of healthy societies. And the theme for this World Health Day, if some of you know that, I don't know if some of you know, but it is Healthy Beginnings, Hopeful Futures. We mark that beginning of a year-long campaign to urge governments and the health workforce to ramp up efforts to end preventable maternal and newborn deaths and to prioritize women's health. So even if there's a larger piece in the health of women that has been neglected for long, but it's not limited to pregnancy and delivery. And to prioritize that. Now, at the heart of all of this, midwifery is at the heart of this transformation. A robust midwifery education and training program produces qualified midwives, equipped with the competencies and skills needed to promote maternal and newborn health. That we all know, but that's not happening everywhere. The successful implementation of the National Midwifery Initiative needs effective state-level coordination supported by midwifery leaders and champions such as yourselves, partners such as Astrika, as Fernandez Foundation, and many of you in your own health services, health facilities. It is important for midwifery professionals to acquire high-level skills, but also leadership skills. You are leaders also in your communities, in your health facilities. In my country, the Philippines, if you want to know what's going on in a village, you look for the midwife. The midwife will know who is pregnant. The midwife will know who's giving birth. The midwife knows who had a difficult pregnancy or will have a difficult pregnancy. She's a good source of information for the village. Today's session is catalytic in advancing the national and global agenda for ending preventable maternal and newborn deaths. The idea being that, of course, India is at the heart of this. If things move in India to achieve global health goals, the world achieves it. Let's face that. This forum enables us to, and that is also a responsibility. It is an achievement, but a responsibility. This forum enables us to reflect on the achievements, success stories, experiences, challenges, and the way forward in education, regulation, and establishment of a midwifery model of care across the country. Globally, we still lose one woman or baby every 7 seconds to preventable causes. That is unacceptable. Every life lost is precious. India has made remarkable strides as per the UN Maternal Mortality Estimation Interagency Group. The report that was published this year, maternal mortality ratio has declined to 80 per 100,000 live births. That's a big, big achievement. I think as the last time, as I said in the other forum, when I came to this job, it was at 140 plus. Now it's 80 in 5 years. We are really on track for achieving SDG 3.1, possibly ahead of schedule. This reflects the powerful synergy between political commitment, public health innovation, and global collaboration. But the things we need to do more is just strengthen what's there, strengthen the investment in primary health care, strengthen all the initiatives under the National Health Mission, including Suman and Lakshya, and the midwifery program. Demonstrate that a comprehensive and an integrated approach actually works. It's difficult to do, but when it works, it works. Now is the moment to further strengthen all of these schemes, and these have shown results, including implementing a roadmap to effective midwifery-led care. The latest State of World Midwifery report of 2021 highlights the critical need to invest in midwives to enhance leadership, models of care and research, safe working environments, and policy design and implementation. Continued and accelerated investment to create a skilled and an empowered midwifery workforce is key to achieve every woman, every newborn, everywhere targets, as well as the survive, thrive, and transform agenda. India's midwifery model is collaborative, where midwives work effectively alongside obstetricians, pediatricians, and nurses, and all support staff. It optimizes all the work and also the results. Our collective action is very critical as of this moment. We must work closely with communities too. Communities as partners, communities not as recipients just of services, but communities as sources of information for us to improve our work, so that families understand and embrace and actually provide us feedback to improve our service. I think let us use this session to strengthen our partnerships, listen to our midwives, and invest in dignified, high-quality care for every woman and every newborn. Together, we can realize a future where every mother survives, every baby thrives, and every birth is a respectful experience. Thank you.
Thank you, WR, for highlighting the achievements that India has made in improving maternal and newborn health and reinforcing that midwifery model of care, collaborative care is really, to ensure that women and newborn gets positive pregnancy and childbirth experience to ensure that inequalities are addressed. And, we really promote this collaborative care. And the next speaker, I would like to invite Dr. Pawan Kumar from Ministry. And I would like to share his bio first. So he's in charge of maternal health and immunization, Ministry of Health and Family Welfare, Government of India. He has over 25 years of experience in public health and healthcare management. And he has published and presented more than 75 research papers in national and international journals and conferences, or written chapters in books in public health. He's associate editor of Journal of Advanced Research in Medicine. He's treasurer of Indian Society of Hospital Waste Management, life member of many professional organizations, and he's the recipient of more than 19 awards at national and state level, including Excellence in Public Health Award in 2017. He was awarded Ambassador for Peace, Universal Peace Federation by Social Council of United Nations in year 2021. So thank you, Dr. Pawan. Please share with us the progress that has made by the Government of India. Please welcome.
Change it.
Thank you. A very good afternoon to all of you, and welcome back after lunch session. And it is important, and I'm very happy that hall is full, and all my colleagues from different stakeholders, different organizations, they are here to listen this important session. And at the outset, I'm very thankful to this summit, World Health Summit, where that a platform has been given to all of us to come together and discuss about midwifery, especially the midwifery more specifically. In the morning also we were having a session for 90 minutes for maternal health in India. So this is in continuation of that also, that specifically we'll discuss about the midwifery initiative, which is a very flagship program for the Government of India. I appreciate that this opportunity is given to all of us, so that in coming 90 minutes we deliberate, discuss, see the constraints, difficulties, what can be the way forward, how this system can mature in our country, which is prevalent in other countries for last 30, 40, 50 years. How the progress and the learning of those countries that can be translated into action into our country. So with this background, I'll be discussing about what the Government of India has done and where we stand today and how we have a plan to progress further. So my talk will evolve around what is midwifery, how it has brought into the action in country, and what is respectful maternity care, because that is also a buzzword in midwifery. Once we talk about demedicalization, respectful maternity care, and giving choice to our mothers. And we as a country, we are having a very big cohort where we have 29 million pregnant mothers every year in the country, and we have 26 million newborns which are there in the country every year. So this maternal and child health program, and more per se with the midwifery, how it can transform the healthcare services in our country, that is an important part of for all of us. And Dr. Rodrigo, as we appreciate that number and figure of 80 per 100,000 live births. Remarkable achievement in terms of a global versus India. If we this line diagram where we see how the global fall of MMR has happened and how the country's MMR has fallen, and the difference you can see almost double the steep which the MMR of the country is falling to achieve sustainable development goals by 2030, to achieve a figure of 70. We are pretty confident, and with the whole support of everyone in this country, will be able to achieve before 2030. The trajectory by which it is falling, if you see the trajectory by which it is falling, as Dr. Rodrigo was saying that when he joined, he was at 130, that MMR of our country, and how it has fallen down. So, and many states, they have already achieved the SDG targets, and National Health Policy target of 100 has already been achieved. So that is a progress which is being done by all the program initiative which has happened in the country, and things they are moving in a right direction. Coming back to concept of physiological pregnancy, basically. All of us know that pregnancy is a physiological phenomenon, and that experience should be enjoyed by each mother, whosoever is there in that phase of 9 months. It should be a joyful period for all of us. Let it be a lady who is pregnant, for her husband, for mother-in-law, father-in-law, daughter-in-law, whosoever is in connection with the pregnancy. It should be a joyful feature, and where the newborn in this society is coming. And that feeling of 9 months should be enjoyable. So we call it a respectful maternity care. And whenever I speak about midwifery and the experience of giving a birth to any child in the country, I myself get back to those 30 years back when I was in a medical college. When I was in the third year of a medical college, I have seen the labor room conditions, how the mother is being treated by our healthcare providers, let it be a staff nurse, auxiliary nurse and midwife, junior residents, gynecologists, obstetricians. At that time, it appears that becoming a pregnant is a crime actually. The way the mother was dealt 30 years, 40 years. And now how the progress has happened between the behavior, interpersonal communication, respect to the mother, and how the things they have changed, being from a medical condition to a physiological condition to a respectful maternity care. So all of us have experience, whether I am a male or a female, or I am an adolescent, or now I am a mother-in-law or a father-in-law, whatever. Everybody has gone through that experience while waiting outside the labor rooms. What is happening inside those first phase, second phase, third phase labor stages, and also on. So with this concept, Government of India has taken a conscious decision. Why we have so many schemes in the program, let it be JSY, JSSK, PMSMA, Extended PMSMA, Suman, respectful maternity care, where it is lagging in between. So this concept of midwifery initiative, which is basically a Western concept. I know Dr. Indu, we met in Indonesia, where almost 5,000 plus midwives, the leaders, the champions in midwife are there. When initially I joined this maternal health in the country, so that was a very joyful period, how the experience of almost 50, 60 countries we have enjoyed there. And then this concept of establishing midwifery units, then respectful maternity care, and then expanding the pool of nurses that has expanded. So this is a transformation into healthcare system of the country, and taking a concept of 2018 in PMNCH, where the guidance has come from the Western world. Let us inaugurate this program. Let us establish this structure in our country itself. So this is how the journey of midwifery has started into our country. So what was the need actually? At that time, once it was a discussions one going on in 2017, 28, what was the need actually? Is a access, is a quality, is a respect, is a newborn healthcare services, or is a healthy outcome at the 9 numbers? Because we are a very huge country. So because the cohort is very large and we stay in villages, we stay at the sub-center, PSC, sub-district hospital, district hospital, and giving access to CMOC, BMOC doctor or obstetrician gynecologist may not be practically applicable. So let us bring a new pool of people who are being trained as per the International Confederation of Midwifery. The competency skill is brought into the existing cohort of nurses, existing cohort of auxiliary nurse or midwife, whosoever is eligible, having a GNM course or a BSF, and train them for 18 months. Means a kind of a specialization into having a good birthing experience and how it can be done, and then promote naturality into that. Don't make it as a pathological, physiology to pathological, and bring more number of medicines to bring a newborn into the world of this country. So this is how the transformation has started. Give respect to the mother and then maintain, stabilize or refer newborns or mothers. If there is an imbalance between the MLCU, midwifery-led care units, and obstetrical led care units, if there is a demarcation, if you need from a physiological normal birthing position, if or she needs a kind of intervention by a specialist, let us move to the ops led care unit and then decongest. Basically we have to decongest the facilities where the high-end services are required. Maybe where the high case load is there, maybe 50% of deliveries they are happening normally and we require normal physiology. So we decongest those specialists, those gynecologists from the normal labor, and we have a separate pool of people who can look after this. So how this progress has started, starting from NPM, which is existing staff nurse, GNM or a BSc nursing personnel, who have a leadership quality, who have an enthusiasm for a normal birthing position, have an interest into that, because even the staff nurse GNM may have an interest in physiotherapy, may have an interest in CTVS, they want to go assist big surgery. But here we bring those people which have an inclination for a normal birthing and they want to work into this area of field, and then giving a quality services certified with the SOP guidance document, what is being needs to be taught to all those people. Then down to the line, establishing state midwifery training institutes, then midwifery-led care units at the ground level where actually the action will happen, and then impart International Confederation of Midwifery, the competency skill which is required at this level. Then selection has happened, the guidance has been given. Now they were needing a document to read, to refer. So Government of India had brought series of documents in last 4 or 5 years. Whatever was required, many documents they were released last year only. Let it be a scope of services or a financial guidelines, how to sustain and maintain that model, then NPM curriculum, learning packages for the midwifery educators, then the mentoring guidelines, learning resource package, whatever was required has been imparted, given guidance to the NMTIs, the SMTIs and the midwifery-led care units. So midwifery-led care units, they are beautiful places where you enjoy actually, where the mother has a feeling that yes, it's a normal physiological phenomena and I am being treated with respect. And these are few live pictures of those MLCUs which are working in the country in different regions vis-a-vis the obstetrical led care units in the country. Then we teach, we preach and we motivate. And we give learning and awareness to our future mothers also. What can be the different options, positions available, and how those phases they can be taken care of. And these are the live picture of those MLCUs which are working in our country. And just I want to appraise to the house that it is a kind of a demand generation also, because many people, many states, many our healthcare functionaries may not be knowing, even our well-read people may not be knowing. Sometime I have to brief, midwife is not that thy which happens to be in the village. The midwife is a properly trained as per the ICM, as per the INC. So sometime I have to do advocacy at different levels for the midwives also. But these are live pictures which are within the system in our country, how they are working and how they are performing. And something about the respectful maternity care. Whether it is our Suman program, whether it is a PMSMA, our JSSK, the respectful maternity care program, those wording, those words, they have been added, and whenever the training program they happen at the government of India level, we take care that sensitization, counseling of our healthcare workers needs to be done. I ask them, you put yourself into that situation of a labor room, how you will feel about that and how you treat the other people which are across the table. I think that is a kind of a feeling, empathy and sympathy which come into our healthcare system, how the things can change. And then counseling is required not for our clients or our caretakers. I think counseling is required for everybody for a respectful maternity care. And then birth companionship is another important feature which has been added in last 1 decade, to have an assistant, whomsoever you like, let it be husband, mother-in-law, sister-in-law, who can accompany you during that phase. Sometimes husbands, they come and they want to accompany their wives to have that process needs to be completed, and that 3 decades back this option was not available. These are the key pillars of mentoring which provide competency and confidence, because this is a hands-on training program. Theoretically you can't learn, you have to perform into those MLCUs, SMTIs, you have to do hands-on. So that kind of a confidence building is there in our SMTIs and NPMs which are working in those places. Then advocacy not at my level. I think everybody is advocate. I need advocacy by each one of you once you talk about the midwifery into the country, wherever, whatever platform, because our clients, they also need kind of a awareness generation about the midwife and how they work and what is the respectful maternity care. Then last pillar is with our obstetricians and gynecologists. Should not be any conflict of interest. Everybody has their scope of work actually, because you are meant for high-end surgeries, difficulties, the HRPs, high-risk pregnancy, how to handle them. But normally the 50% they can be taken care by this specialized pool of people which are part of our system. I think this kind of advocacy is also required at all platforms. At least I am being a national program manager, I take care of this part to handle this piece of work, whether I talk to the FOXY, I talk to the IAP, IMN, any platform that this part of is well taken care of. So I think I'll stop here only, because this is just to set the context for future discussions. So way forward, how will we move? We will listen to our esteemed other speakers and colleagues also, and we'll just wind up and end. And thank you very much, and I end here only. Thank you.
Thank you, Dr. Pavan, for really sharing the milestones and journey so far of midwifery program in India. So we look forward to hear from you more towards the end of the session. I would like to invite our guest speaker, Dr. Janvi Nilekani, founder and chairperson of the Astika Foundation, whose contributions to respectful maternity care and innovations in midwifery education is of great inspiration to all of us. She is public policy professional, specializing in maternal health, and holds a PhD in public policy from Harvard University. She was graduated with a BA in economics and international studies from Yale University. Her personal experience with childbirth in India actually moved her when she found systematic gaps in maternity care and motivated her to drive this reform. And she founded this Astika Foundation to be focused on enhancing maternal and healthcare quality through capacity building initiatives and professional midwifery education and training. So she established this Astika Midwifery Center in 2021, a state-of-the-art birth center in Bangalore, offering ethical, respectful, and evidence-based maternity care together with interdisciplinary support for women throughout the childbirth journey. So I would like to invite you, Janvi, and share your experience.
Thank you. I think Dr. Pavan has given, Dr. Pavan Kumar has given a very thorough overview of the midwifery program. But just to pick up from where he left off, as he was mentioning, it's a program, the government of India launched it in end of 2018, and it is currently rolled out in much of the country through National Midwifery Training Institutes and State Midwifery Training Institutes. So Astika Foundation's role in the midwifery program is that we partner with the government of Karnataka
to run a National Midwifery Training Institute in Vanivilas Hospital in Bangalore. Dr. Savita from Vanivilas will be speaking later on, so I don't want to talk about it too much, but the gist of it is that we are training right now one batch, possibly more, of midwifery educators in Bengaluru at Vanivilas. We have state midwifery training institutes along with Government of Karnataka in partnership with GOK in Mysuru, in Belgavi and in Bengaluru. There are all of these four either have or are in the process of having their affiliated midwifery-led care units, and midwifery-led care units, MLCUs, are also starting in district hospitals such as Hassan, where midwives who were trained in the state midwifery institutes are now almost at graduation stage and ready to go and run an MLCU in a district hospital. And of course, over 5 years, 10 years, the hope would be that at least every district in Karnataka has access to midwives, if not every woman, and as many people as possible have that access. So we really back midwifery as an organization for all the, I think Dr. Pawan has already touched on a lot of it, but just to re-emphasize, if you look at the challenges India has in maternal health, one is there is still what in public health is sometimes called too little too late, inadequate access to care. Certainly, especially in South India now, institutional delivery rates are high. Most people have access to care, but access to quality care is something which is still not 100% coverage across the country. And exactly as Sir was saying, when it comes to decongestion, reducing some of the load in high caseload facilities, it not only enables low-risk women to get better care from midwives, more personalized and one-on-one support, it enables high-risk women to get far more time of an obstetrician than is otherwise feasible. So, increasing the pool of skilled healthcare providers providing for maternity and newborn care itself will help in further reducing infant and maternal mortality rates, both of which are on a very positive trend in India thanks to the work everybody from the government partners and others have been doing for all these decades. Secondly, I think, as touched upon earlier, that the rates of over-intervention in India are actually very high. I think, maybe in this room everyone may be familiar, but still, just to touch on it, as far back as NHFS, the last NHFS, which is now 6 or 7 years ago's data, the private sector C-section rate countrywide was 48%, which is much higher than sort of that 10 to 15, 10 to 30, I would say, even as a 10, 20, 25% benchmarks. You're talking about double of that in the private sector at a nationwide level. States like West Bengal, Telangana, Jammu and Kashmir, they had private sector C-section rates above 80%. And I think from what we all know anecdotally, it's quite possible that the up-to-date stats are substantially worse. Government actually has data, I think, from many hospitals, which does show the trend continuing to head towards heavy over-intervention. And what over-intervention does is generate a lot of morbidity. Preventable, yes, you have, by and large, I think we've made real headway on preventable mortality, and that continues to progress. But preventable morbidity also, should be prevented since it's possible. So, a culture of a midwifery-centric approach where birth is considered physiological unless and until something is going wrong will inherently bring down a lot of the over-intervention, which will bring down morbidity. Not only for mothers who have less to recover from, be it surgery and so forth, but also for infants. I think there was an earlier session where I gave the example of how there's good quality data out of, say, Bihar and Uttar Pradesh, actually, the study was on how high the oxytocin augmentation rates are in PHCs, that fetal distress rates came down quite a bit once in an intervention which tried to control oxytocin augmentation. So the current standard of care, which is often prevalent, certainly isn't what is ideal, and that, I think, the midwifery cadre is an effort from government and partners to try to work towards that more low morbidity future where we're concerned not only about survival but also about physical well-being. Finally, I think the disrespect and abuse in labour rooms has much improved. As I was saying 30 years ago, I have no doubt it was much worse. Nonetheless, I don't think we can say we are where we need to be in terms of every woman having access to respectful care, to informed consent, to being treated in an ethical fashion. There are still lacunae there, and midwifery is founded on a principle of respectful maternity care. That informed consent and similar rights are very core to how midwives are trained and what they believe in. So midwifery inherently helps us to establish respectful maternity care across the country. So we're very proud to be part of the midwifery initiatives in Karnataka and in partnership, of course, with Government of India and all the other partners. So that is one major thing that we do at Astika Foundation is the professional midwifery cadre program, the nurse practitioner program. But a lot of our capacity building work is also in increasing access to, say, what we could call the midwifery model of care. Training existing nursing cadres, existing obstetricians, existing healthcare professionals to provide services a bit more in tune with both best practices and with the midwifery approach. Because of course, while professional midwives are a key part of the future, I don't think we will have more than a few hundred now, and it will take a very long time for that to be a substantial portion of healthcare providers. So ensuring that the current healthcare cadres also have the opportunity for capacity building, for upskilling, remains another key area for us to focus on. So we actually do capacity building in a lot of things, not only midwifery, but midwifery is a priority area for us. So both online and content-related courses for knowledge. We do a lot of in-person courses through simulation, through role play, and through other techniques to improve skills. So these are going on in many institutions in the country, and we're very happy to also be able to collaborate with WHO on the Interprofessional Midwifery Education Toolkit. And we really believe in that approach, because not only is it focused on ensuring that all the different healthcare professionals in the institution can contribute to enhancing quality of care, but at the same time, I think the effort that has gone into using best practices when it comes to andrology, in terms of how do adults learn, be it things like their treasure hunt method, so that people learn how to go seek out evidence, or role playing, or there's a list of techniques which have been very carefully thought through. And I think even the user feedback we've had from the ground and what we've heard from others is that it is a very successful approach to upskilling adult healthcare practitioners in an in-service capacity. So these are some of our big picture efforts to contribute towards the establishment of midwifery in India. Thank you, Dr. Pushpa, and all of you all for having me on this panel.
Thank you, Janvi, for your wonderful deliberation and highlighting that progress has been made, but there are existing inequalities, existing disrespect, and existing lack of quality care across the country that needs further, new approaches and strategies to address. And I really admire personally your passion of, translating your observation into something which is sustainable solution by establishing a foundation that supports all individuals and institutions, whoever working with for, ensuring their respectful maternity and newborn care. So thank you so much. With this, we have finished 3 keynote speeches, and now I will invite Dr. Priyanka to start the panel session of experts, followed by Q&As from audience. Thank you.
Thank you so much, Pushpa ma'am. And after this power-packed, insightful opening session from our dignitaries, we move to the next session. So this session has 3 sections. First, we will hear from our experts, their experiences throughout their journey in midwifery from government institute, private institutes, and the medical colleges. And then we have a Q&A round where I'm sure you must be having many questions, so you can put it to our dignitaries. And after the question and answer, we will request Dr. Pawan to give us a way forward, and then we will close this. So we move to our expert presentation section, and it is my proud privilege to invite our 3 expert presenters today. So I would request So it's my proud privilege. So we have here with us, and these speakers don't need any introduction. We have Dr. Savita with us. Dr. Savita, please come to the dais. Dr. Savita is Medical Superintendent Vani Vilas and Professor Obstetric and Gynae, Bangalore Medical College and Research Institute. So ma'am has over 20 years of experience in obstetric and gynae, serving in various academic and administrative capacities. She has actively participated in numerous national and medical conferences, and she has been co-convener of NDVH during AIOCG, successfully conducted many conferences and CMEs, and she has authored and published over 10 research articles in peer-reviewed index journals and guided more than 50 postgraduates' theses, contributing significantly to academic mentorship and research training. Currently, she heads the very important topic of current time, which is a high-risk pregnancy at Department of Vani Vilas. And she is also the recipient of prestigious NIHR grant for the PREVENT study, reflecting excellence in collaborative research. Welcome to DIAS, ma'am. So now I'll call the next speakers and then we will start the presentations, ma'am. So I would request our next expert, who is again a flag torch bearer, I would say, for midwifery. And so I would request Ms. Indrajit Kaur. And with love, we call her Indy. So Indy, please come on the dais. And all of us are very much aware of Indy. So Indy is our midwife here today. And Indy is director of midwifery at Fernandes Foundation. And she's her notable achievements include launching of the world's first maternity clinic at the Royal London Hospital for women who have experienced sexual violence. In her 6 years in India, Indy has been instrumental in training professional midwives and providing clinical leadership at Fernandes Foundation, as well as for Government of India and Telangana. Her focus on reducing maternal mortality through midwifery training and humanized care for Indian mothers is evident in her work. And India has also extensively, along with the Fernandes Foundation, contributed to the methodology of learning, which is Essential Childbirth Care course, supported by Astika Foundation and Dr. Janvi Nilekani, which supports amplification of the Government of India guidelines by adding new learning methodologies, which is a requirement of this era. And India is currently doing PhD at University of Liverpool, UK, with a research focus on optimizing maternal perinatal outcome throughout the safe cesarean sections in low and middle income countries like India and Tanzania. So welcome, Indy. Now I would like to welcome Dr. Aparna Sharma. So Dr. Aparna Sharma is also known to all of us. Her enthusiasm is, I would say, infectious. Whenever we have something, we just call Dr. Aparna Sharma and she is there. So her interest is truly, it's notable. And so Dr. Aparna Sharma is professor and unit head of obstetric and gynae, All India of Medical Sciences, New Delhi, fetal medicine specialist with expertise in fetal interventions. Her area of interest is high-risk pregnancy, fetal therapy, simulation-based teaching, respectful maternity care, AI and digital innovations, and she has received various awards. Noteworthy of them are CL Javeri Award 2025, Rajat Ray Award in Fetal Medicine, Sun IAAC International Traveling Fellowship 2019, Foxy Imaging Science Committee Award 2019, Foxy Junior Korean Award 2018, Kamini Roy Orator Awards 2017, and more than 100 publications in peer-reviewed journals. And I would like to add to this, which Dr. Aparna has not mentioned, is the extensive work she does on respectful care and quality of care for maternal health. So welcome on dais, Dr. Aparna. So a huge round of applause. Now we have all the dignitaries and speakers on the dais. We will start this session. So to start with, we will request Dr. Savita. So Dr. Savita, your focus area is experience for government midwifery training institutes, and the question is best practices on respectful care from your National Midwifery Training Institute. So over to you, ma'am. Ma'am, you will put the presentations.
Good afternoon, everyone. I'm a professor of OBG. So I work in Vani Vilas Hospital. It is a government hospital, mother and child hospital, which is affiliated to Bangalore Medical College. So in Karnataka, we are the Vani Vilas Hospital delivers the highest number of deliveries. So we had in 2019, we had 19,000 deliveries, and now it has come down to around 12 to 14,000 per year. This one. So I'll be sharing my experience of establishing the MLCU, NMTI and SMTIs in our hospital. So the background is Government of India has launched the Midwifery initiative to improve the quality of service provision for strengthening the reproductive, maternal and neonatal health. This initiative will create a new cadre of nurse practitioner midwife. So these midwifery services will primarily be provided through MLCUs. One of the key components of establishing the NPM cadre and embedding them in the health system is a clear scope of practice. So these midwifery led care, which runs on the tenets of primary, promotive and preventive care, if given with adequate dignity, privacy and compassion for women, can become the most vital way of organizing maternity care so that all women, mothers and newborns continue to receive respectful maternal care. A Cochrane review provides the evidence that midwife-led care, led continuity of care can result in 24% reduction in preterm birth, a significant reduction in episiotomy, instrumental birth or use of pain relief, while increasing the psychological support for women. So this is a paper statement when the Vanivilla was selected to start the NMTI. So this came in the newspaper. So the objective of starting the NMTA was, this institute is uniquely positioned to establish professional midwifery through imparting high quality education to this new cadre. With the strengthening of midwifery care in Karnataka, we aim to provide access to quality maternal and newborn health services and promote natural birthing by promoting positive child birthing experience and promote respectful maternity care. So, and to provide competent, safe and culturally sensitive care, utilizing the midwifery management process to independently manage the care of women throughout the lifespan of mother and newborn till 28 days. So, NMTI, that is the National Midwifery Training Institute, this was established in January 2023. So, we had the first batch 25 NMEs. Out of them there were 2 male NMEs also. So we during the NMTI, we have successfully implemented the antenatal parent craft classes and antenatal OPD and intrapartum care, and so that the women were made to understand their rights to autonomy over their body, birth choices, reproductive health choices, and their right of respectful care. So these are some of the photographs of the parent craft classes, and the Midwifery Center has established a midwifery-led care antenatal clinic for low-risk women, where the NMEs and SMEs provide antenatal care. This has continuously gained popularity among the pregnant women who are visiting the Vanivilas Hospital OPD. So most of our mothers, they come in search of their uniform, that is the pink dress uniform which the midwives has that. So they are recognized like that. So the first batch of NMTA was started on 12th January 2023. And there were 25 students, 7 of them were from Andhra Pradesh and 18 from Karnataka. Out of those 25, there were 2 male midwifery students also. So this is the glimpse of the first NMTI batch. And after this NMTI batch, 3 centers, the SMT have started. The first to start was in Mysore, and the second is in Bangalore, which started in our hospital on 1st July 2024. And the third one is in Belgaum, it's Belgaum Institute of Medical Science. So here 26 students have joined the first batch of SMTI in Vanivilas Hospital. So these NPMs, the nurse practitioner midwives, they conduct birth in MLCU under the supervision of NMEs, and they are posted in OLCU, that is the obstetric led care units also, where they conduct the deliveries or births under the supervision of the obstetricians, and they also see the antenatal cases and follow them up. So this is our first SMTI batch. And just a few words about the midwifery led care unit establishment. So we had a very big hall. I mean, it was an emergency OT which got converted into MLCU. So this was before the renovation and converting into MLCU. Now this is the existing MLCU where the births are conducted. And we have a three birthing rooms, and there is a big hall for exercise, there is a receiving, triage, so many things are there in that. So after renovation, many of the officials have visited this and they have appreciated the MLCU. So this is about the antenatal care, where our midwives are giving the antenatal care and they are teaching the exercise and all. And this is our antenatal OPD, I mean exclusively for the midwives. So these are the photographs of childbirth classes and admission. These are some of the feedback letters which are pasted in the MLCU. Their feedback of the birth companions, and we are allowing the husband or whoever is the choice of the mother, they are allowed in the MLCU for delivery. So we are also practicing the alternate birthing positions, and most of our even postgraduates are fascinated by the way the midwives are conducting delivery in the MLCUs, and even in the OLCUs, alternate birthing positions are encouraged. So most of the mothers, they deliver in either propped up position or squatting position. So this is about the statistics. Total number of antenatal checkups since the starting, that is 2023, done by the midwives is 2,463, and total childbirth class conducted 204, and number of mothers attended the classes is 2,040. Total number of intrapartum care given 1,040, and total number of births done by the midwives is 1,066, and total episiotomy performed is 11%. So talking about the birthing positions, most of the births were in propped up position, and the second is the side lying positions, and the third being the sitting upright position. And regarding the perineal tear, so we had around intact perineum. The mothers who delivered with intact perineum were 290. In that, many of them were also primigravidas. And the first degree tear was around 265, and second degree tear was 183. And we didn't have any third or fourth degree perineal tears who delivered with the midwives. So coming to the key challenges and learnings. So the first point is addressing the policy gaps. We need to have a formation of the central or state midwifery task force, and provide appropriate direction to the medical education department to carry out the NME and NPM affiliation and examination. Though there is INC guidelines are there, still as personally I am still in the process of getting it affiliated and getting it into the Karnataka Nursing Council. That process is still going on, and midwifery cadre creation has to be done in the healthcare system. And about the NPM incentives and the age flexibility to improve the human resources. Still, even now also, it is the nurses, they are not too much motivated to join the course. They need lot of push-ups the influence and all to get into this. And the second thing, bridging the gap between the obstetricians and midwives, I think it's really challenge. What I have experienced being a gynecologist, I am supporting midwifery so much, so everyone thinks why she is supporting so much, but I have seen something positive in that, and I have experienced how they, I mean, communicate to the mothers and how they are conducting the deliveries and all. So I mean, like maybe our future postgraduates who are in a medical college, I think they get exposed, and I mean, we are able to change the scenario. That's the only thing. So for that, I had to struggle a lot. I had to hold meetings between the obstetricians, our staff, postgraduates, and the midwives, so that this is repeatedly happening. I mean, change doesn't happen overnight or anything. So every time they come out with some problems, then call them, sort out. So if there is I mean, like they don't give episiotomy regularly. Our PGs will give episiotomy. So if there is a small tear also, they'll come and complain, midwives conducted delivery and there is a tear. So these are some of the things which need to sort out. And being a administration, I think it is in a way it's helping me, like so I can deal with the situation maybe. And for this program to become success, actually the administrator or the person who is highest in the position in a hospital, that person should be motivated. Otherwise it is very difficult. That's what I feel. So, and active involvement of the obstetricians to provide where and when the intervention is necessary, that is very important. And the midwives have to, I mean, strictly adhere to the, I mean, which is the low risk and what are the cases they are going to take and what are the cases they are not going to take. Those things has to be decided. And involvement of the pediatrician in teaching them for the neonatal care also is important. And something fear of new. See, it is new for even the patients and for the doctor, I mean, for the midwives and the doctors also. So for the midwives, it is something new, like they are interacting with the obstetricians and the patients. They have a fear that whether the patient, the mothers will accept them or not. The other thing is whether I mean, our doctors are very apprehensive to accept the midwives. These are some of the issues. And from the government side, there is a lot of publicity is needed, so that every mother or in the country, they comes to know that there is something like that. Many of the people, they don't know about the midwifery. They think doctor only should see them or something like that. So publicity is very, very important. And establishing MLCU to provide privacy, one-to-one care and the safe childbirth experience to the mothers. That's very important. And this just I want to quote one of our IAS officer who delivered her second child in our MLCU, and she shared her experience in the media and newspaper and all, and she was very much fascinated about the about her birth. This is the photograph. I would just want to put that. So these are some of the feedbacks which are taken by the mothers who delivered. So way forward, now we have in our hospital, we have 3 labor rooms. One is the low risk, or we call it as a clean labor room. The other one is the septic labor room, and the third is the high risk labor room. So now this MLCU is adjacent to the clean labor room or the low risk labor room. So there is an interchange of mothers in between. So usually the lowest risk mother will go to the MLCU. Whenever there is the obstetrician to pitch in or something, like they are facing difficulties, the midwives, they shift the mothers to the OLCU, that is the clean labor room. And they come and conduct the delivery under the supervision of the OLCU, the obstetricians. So now they have taken over a little bit of burden of our postgraduates or obstetricians also. And we have started sending our midwives into the high risk pregnancy labor room also, so that though they are not delivering or directly involved, at least they will give that supportive care to the mothers, so that every mother gets that respectful maternity care. See, as a doctor, as an obstetrician, when I am talking, like I know that sir, Dr. Pavan Kumar was telling like how was the labor room, and it was like the mother felt like it is a crime to become pregnant. So I have seen that and I have experienced those things also. But we try to we become little more maybe as an obstetrician, but the empathetic way of looking at the patient is with the midwives. That's why I am supporting more the way they care for the mother and they interact with the mother. I think all of our postgraduates also should get exposed to that. So I usually tell our postgraduates also to visit the MLCU. They go and see them, like how they are doing the midwifery over there. So these are some of the things, and as I said, sensitization of more obstetricians has to be done, and many of the midwifery centers, I mean MLCUs, have to be opened. Thank you very much. Thank you for giving me this opportunity to share my experience. Thank you.
Thank you so much, Savita ma'am, for sharing the journey of National Midwifery Training Institute Vanivilas with us. And the 4 words LAMC: leadership, advocacy, motivation, and collaboration. That will take us way ahead. And with this note, we move to the focus area of public-private collaborations. So I would request Ms. Indy Kaur to please come to the dais and share with us the public-private collaboration for strengthening midwifery initiative with focus on the strengthening of NMTIs and SMTI. Over to you, Ms. Indy.
Thank you. And you press this, yeah?
Yeah.
Perfect. Thank you and good afternoon, everybody. Thank you, Dr. Savita. We need champions like you for midwifery. Thank you and good afternoon. I would like to thank everybody and for having this opportunity and giving me the privilege to share my reflections. I've just realized this is my 8th year here when it came up to 6 years. I initially came on a sabbatical, but so much has happened that I couldn't leave. So I'm a midwife. I've worked in the UK all my life, and I had an opportunity to come to India when Dr. Avita Fernandez invited me to speak in a RCOG conference on a midwifery subject, which was birth positions in labor. The room was huge, and I was the only midwife, and all the obstetricians were looking at me, and I was scared. But I'm still here, and thank you for this. So my topic was to share the decade's experience, and I felt this was important because it started in 2016. And if you look at that, it was because of a national consultation on high cesarean section rates. That's how the evolvement began. And then through the years, each year, the launch of midwifery initiative in Telangana, launch of guidelines, partnerships that started National Midwifery Training Institutes, scaling up midwifery in Telangana, launch in Andhra Pradesh after the training, and then the government of Telangana won the award. And then in Karnataka with Ashrika Foundation, they started their journey with midwifery, and it's not stopped then. So that's the start. Now, how did it begin for us? I think you might have the old slides, but I'll just go through. Just a little background on the hospital, because it's important to say what happened and how midwifery began in 2011. And why, and because of the maternal mortality rates, the question was, could we pilot a midwifery program? It was really important. Countries that had professional midwives trained to international standards had lowered their MMR rates. So that was the first bit. So if you look at a hospital with over 2 million births and doctors birthing every woman in 63 years, to try to bring in a subject like this caused fear, because it's something that no one was aware of. You don't have such role models, because in India, when the training happens, they qualify as a nurse and also a midwife. So the professional midwifery in-house program started, and the main fact was to aim to develop and test a model to improve the quality of care for women, and the ability to learn from this training actually helped us to translate it across India. In 2019, the start of our midwifery-led unit. And this happened after 8 years of setting midwifery up, because the doctors needed to understand what midwifery was all about. They needed to understand the scope of practice. So when the midwifery-led unit opened, it wasn't easy, because I challenged Dr. Vita. I says, now we have to walk the talk and start a midwifery-led unit. The midwives are doing clinics, and this is the overall of what a midwife can do, and that's taken away the doctors that are doing healthy women. And that's a lot of women, if you look at it. Midwives started bridge clinics, midwives started VBAC clinics, and we know that our cesarean sections are high, and if you get midwifery inputs into it, it'll actually lower it. And the births, if you look at the total births, we have 27 midwives in Fernandes. We have 3 sites. We have midwives only in two of the sites. The midwives are birthing at least over 40% of the total births, and this includes the collaboration, not just in the midwifery-led unit, but as what Dr. Savita says, into the high-risk units, the only thing the midwives will not do is an instrumental birth and a cesarean section. But when she's in the high-risk unit, a doctor is there, but she births, unless if she needs any other procedure. So that's our midwifery-led unit stats. We started in 2019. COVID hit. So again, it's something that advocacy is very much needed, because women need to know what it is. The word midwife, as we said earlier, and our respectful Dr. Pavan had said, it was associated to the traditional dye. They did a good job, but also it's important to know that it's a professional standards, and women need to know that. Women want to also see that. Most of our transfers from the midwifery-led unit to the obstetric unit was more for pain relief during labor. And even then, when they were transferred, the most important thing to look at is the outcome. And we know the Lancet says the outcome in midwifery, you reduce unnecessary cesarean sections, and it was only 6.3%. And that is really the midwifery model of care. Impact on the epidural rates came down. Women were birthing in positions of the choice. We introduced birthing, hydrotherapy, and water births, and women loved that. And key performance indicators. It's not just about birthing, it's also about the quality of care that a woman receives, the woman and her newborn. And thank you, Dr. Pawan, and to the government, because you've put midwifery on the agenda, and it's so important because we are now endorsing midwifery. First opportunity was Telangana State in 2017, when they pioneered an 18-month residential midwifery program. And the difference in this program was you had professional midwives training and educating other midwives, and that was the big shift. Obstetricians are excellent, but obstetricians treat, and we see birth differently. The word midwife means with women. So it's totally different. We are cohesive, we work together, and we complement each other. And as my colleague had rightly said, you can't live without midwives once you have midwives, because your workload, and you can concentrate on the women that need you more. So this was the first group, and again, it was a partnership with UNICEF and government of Telangana. The most important thing in this partnership was the commissioner said to us, and of all our speakers have also mentioned, yes, she said, Dr. Vita, I know you can do midwifery, but I want the respectful care as well in the public institutions. And that is so key, and this is what happened. Birth companions were there, but they were not allowed, and this was the first time a man came into the room with his wife. And if you look at the respectful care, childbirth classes were introduced, women were empowered, and these are the women in the public institutions knowing their rights, and when they went into the labor room, they said, I know I can walk, don't make me lie down. So the women were actually asking for it. The impact in the public hospitals, it did bring down the cesarean section rates slightly, but it also brought up the normal births. How did we do it? We had a Promise app because we had a huge training site. How else could we evaluate and perform to monitor the performance, because the last thing we want to do is realize somebody didn't have enough of an experience towards the end of the training. So this data helped us to see who needed more help and individualize the training according to each person. And very important as well, it's not just about mother, the newborn is equally important. And this morning in the keynote, we spoke about neonates and the babies. And what Dr. Genevieve said was totally amazing, because the midwives were there, the midwives reduced interventions, the oxytocin rate went down, and they listened to the fetal heart and transferred appropriately, and that saw a reduction in NICU admissions in one of our hospitals in Telangana. So the current status of Telangana. So the pilot became the first role models for the nurses, and the strong leadership in the state where meetings were held with district collectors, and the government also opened up for nurses in the states who were working in the private sector to be rectified on a contractual basis. But we still need a lot of midwives. And the overview of the impact of the training as well. And if you look at that, 5,607 neonates were resuscitated. Now that is an amazing, because midwifery is there. Midwifery learns how to look after women, identify, escalate appropriately, and the same with babies. And there was an increase in the footfall in the Telangana state. Word of mouth went around, as what Dr. Savita said, that those ladies in pants and suits, go to them, they will give you a lovely experience. And that is so important. And the midwifery-led unit in the public hospitals in Telangana, women were happy, mothers were happy. And it's so important to note that change is coming, and women are going to be asking for more midwives, so be ready. We're all here to help you, and we've got partners here as well. So the NMTI then was established after being endorsed by the government of Telangana with the training. So this is the programs that we do, and as we said, we need to be upskilling programs and other nurses. So enhanced maternity care of nurses is a program that we do for 6 months. So midwifery implementations, we've got most of our partners here today, UNICEF, UNFPA, WHO, JAPIGO, Astrika, and all of us are towards one goal, to improve overall maternal care for women, newborn, and families. This was the first inauguration of the NMTI in 2019. WHO funded the programs, and to date, we've done 41 midwifery educators in the first cohort, 38 in the second, and in the Telangana government, we've got 22 midwifery educators. And this is where we are today, in 10 states, the midwifery training for India. In Tirupati, in Andhra Pradesh, the midwives that have gone back to the areas, and they have trained now 60 NPMs, and that's how the ripple effect is going to happen. And in Orissa, again, the midwives are now doing antenatal clinics. They're being mentored, and it's not just about birth, but the antenatal care is equally important, and with the midwifery-led units. And women are birthing in positions of the choice. We still have a small amount of lithotomy, but change is not going to happen overnight. The publications is really important. We are doing a lot, and now the research needs to come from India, because most of the research out there is from the Western world. All of you are doing amazing work, and it's time to now convert this into publications, and I thank you. I'm not going to go through the challenges, because my colleague has eloquently spoken about the challenges, but I do say that we need to have a definite career progression so you get more people coming into the profession. Thank you.
Thank you so much, Indy, for taking us back when midwifery started, and all the dignitaries on the dais, off the dais, all of us have been part of it. And it's heartening to see. And many thanks to Government of India, the kind of leadership and where midwifery is currently. And with, as Dr. Pavan mentioned, that we are at 80. And this figure of 80, so efforts beyond that is even more steeper, and more concentrated efforts are required. The two key efforts which needs to be addressed is the midwifery and the respectful care. Respectful care which involves all the healthcare providers, because all the services we provide is centered to mothers and baby. So for that, I would request on this note our next speaker, Dr. Aparna, to address on the focus area of interprofessional collaboration for respectful care for strengthening midwifery services in India, the collaboration between obstetricians, nurses, and all the support staff in the hospital. Over to you, Dr. Aparna.
Change with this now.
So a very good afternoon to all of you, respected dignitaries on the dais, respected audience. First of all, thank you Pushpa ma'am, Priyanka for having me here today. And before I actually go on to talk about a little bit about my experience with respectful maternity care, I would like to mention just two things. Dr. Pawan Kumar sir, you mentioned about the experience of doctors in the labor room, right? When they were posted in labor room. So what can we really talk about the experience of the mother who's actually going through that? And I think that is something that has always been a question for me. And to begin with, I'd say that I'm a pure clinician, I'm an obstetrician, and my field of work is fetal medicine, which is a complete super specialization. But what really bothers me is the kind of treatment that women get in labor rooms. And beautifully how brilliantly Janvi talked about, the need for midwifery, and Indy talked about the progress, and we are really proud of the efforts of Government of India which is happening. But the cornerstone is that while we are progressing towards midwifery, we also have to look into what is happening now and how we can change the current scenario. And that's what we are talking about here, right? So when I started this initiative, the question first is, why would I, who's working in AIIMS, which is a completely super specialty hospital, even bother about respectful maternity care? Now, and what we've talked about today is that when we actually look into the experience of a woman in labor room, there is no talk of consent. There is some amount of physical abuse. Verbal abuse is rampant. That's not even counted probably. And 59%, more than half of the vaginal examinations are done without consent. And before coming to AIIMS, I have trained in all of the government medical colleges, at least three government medical colleges of the country. And I do realize that what a woman undergoes during labor can really leave an impact on her mind. It can either empower her, make her feel safe that our government hospitals are okay, our hospitals are okay, or it may actually leave a trauma for life, so that the next time her child is sick, she will say, oh my God, I'm not going to go to the hospital, I'll rather go to a quack, because at least he'll talk to me properly. And that's where the impact of respectful maternity care lies. So while, and we do understand that the doctors are under tremendous, stress, or they're overwhelmed, especially in the public facility, the doctors are overwhelmed by numbers. And while we do understand that the midwives coming in can, really reduce the numbers or maybe the burden on the doctors. But do we also realize that respect is a matter of culture? You generally, even if you're not busy, 1 out of 100 times you are busy, you are shouting because you are busy, but 99 times you are shouting because it's become a habit. And I think that is what we need to address. We introduce midwives, we change our systems, we talk about respectful maternity care, but unless we talk about that change in culture right here, right now, nothing will change. And I think that's the reason behind the journey that we started, and I have to really thank WHO team, WHO country team here, led by Pushpa ma'am, where we talked about, this passion or the need to do this. Somewhere we have to make a beginning. So in association with Pronto International, which is an organization which has been working in the area of respectful maternity care, with the support from WHO and We also had team leaders from the, I took the AOGD, which is an Association of Obstetricians and Gynecologists of Delhi, and had a lot of support from the Delhi government. So how we started is that we started with an agreement, developed a learning toolkit, and most importantly, we identified champions who would be willing to give time to this particular initiative. And we took a platform for dissemination through the Obstetricians and Gynecology Societies of Delhi and also from the Delhi government. So how we started is that, the first one was a very unique kind of a workshop, and for the first time, it may not be very unique for the country as a whole, but for Delhi state and for, core clinicians practicing obstetrics, we did something which was an interprofessional workshop on respectful maternity care. So we called the nurses and doctors from 9 public and private hospitals of Delhi, and we did a workshop which was a full-day workshop which talked not about the subject, but we talked about the birth needs of the mother, communication, and we also included a simulation protocol. So this was a very, very interesting workshop which was spread over 2 days, and before that we had 3 days of online training also. The strengths were that it was a multi-professional, we had nurses coming in, and it was an open communication. We had like a very interesting, interactions, and it ended up with a simulation for RMC. And as an obstetrician, we are very well trained in simulation. You talk about cord prolapse, you talk about eclampsia, you talk about PPH, we all very excited to do drills. But when you talk about simulation for RMC, people will say, are you crazy? Why should I learn simulation for RMC? But I think that's what it is. Now, respect has to be hardwired into the system. Respect has to be a muscle memory that even when the woman is collapsing, we can be respectful and ask for help, not shout for help. And I think as obstetricians, we've always been trained, shout for help. And now we say, ask for help. And I think that's the biggest change which has come, and it has to be percolated even to the smallest level. And this is like one of the YouTube videos which has been uploaded for the simulation, and we use it very, at all places that we do workshops. And the game changer has been the involvement of the government of NCT of Delhi, and I must really acknowledge Dr. Jyoti Sachdev, in the association of whom we did 15 workshops, covered 11 districts, 42 delivery points, more than 6,000 deliveries per month, covering 72,000 deliveries per year. So over a period of 1 year, we did more than 15 workshops. And this was started by a pre-test questionnaire where what is your knowledge about RMC? Do you know about your 7 categories of respect and the consequent disrespect? And interesting observations that came out that is it okay to get angry at women when they do not follow instructions? And 45% were okay with it. So the culture of disrespect is so ingrained that we don't even realize that it is wrong. It's okay. We are so, I heard somebody saying it, that we've normalized it, right? So it's absolute truth. And this is coming on from, so many people who are actually working on the ground, and they're saying, no, it's okay, I'm not hitting, I'm just saying, she's not listening to me. So I think that's something that we've really worked on these trainings. But after, these things and doing more than 15 workshops, it is challenging. And people ask me, what have you done at your own place, right? I cannot speak if I don't do it at my own place. So currently, we have a lot of things going on at AIIMS, and I must thank the Astrika Foundation. We had a beautiful, a 3-day multi-professional workshop, and I think it was the first time one whole day was dedicated to security guards, and morning and evening. And the second day was dedicated to the hospital support, the HASA staff. And truly, it is so true that a woman who walks into the labor room, the doctors and the nurses are all geared up for respectful maternity care, and the guard at the gate says, go away. There's no doctor, don't come now, this is not the time, come later. And she shooed away from the respect dies there itself. So she has to be coming to the labor room too. So everybody is a part of that. And we had the complete support from our director and the chief security officer who said, okay, we will not change the trained people at least. And I think that was our first condition, that let them be there for some time so that this practice takes in. So this was a huge 5-day workshop where we actually covered the whole of the gynae department, whoever is involved in providing care to the pregnant woman. That was the workshop that we did last year in November. But that's really not enough, and I completely agree with Indy when she says that, there is no data from AIMS, from India. And I think that's, sorry. So that's something that we have to talk about. So here what we are actually doing is running a quality improvement initiative where we talk about how we can strengthen respectful maternity care by an objective method of measurement. So what we've done is it's a systematic quality improvement, and I've worked in point of care quality improvement, again, thanks to WHO, and we've done a lot of quality improvement initiatives on various topics, but first time for respectful maternity care. So this is a very organized method in which we collect baseline data. We've made a questionnaire translated into Hindi. In the implementation phase, we have started various PDSA cycles. The first is to structured RMC training, which started in November to all the workers of AIMS. And then in the second, we have various infographics, and third is integrated simulation teaching. And going on, we are daily collecting data. We see how we go about it. There are various other initiatives, which we call the respect in daily practice. We try to have a huddle in the morning in the labor room. This is our SOP, which has a complete chapter on respectful maternity care, and we talk about it for all newly inducted PGs, and we do that. Privacy and comfort of patients as much as possible. We do in a public setup, sometimes it becomes difficult, but we do try to have, activities that will help improve the experience of the mother in labor. And we do have some daily reflections and RMC goals right outside our labor room so that it's there in the mind. So today, any person who's working in our setup would be aware of respectful maternity care. We don't let them forget it. Like, we keep talking about it every time. And this is something that we have also incorporated, is that we take a feedback from every woman who has delivered at AIMS. And this is a Google form, so it is not a very difficult thing to do. And this is a PCMC. This is a patient-centered maternity care feedback form, which I had discussed, and it has been validated in India. So this has 16 questions. We've translated that into Hindi, and we take a feedback, and we do a feedback analysis. So say, for example, jitna samay intezar kiya, how was it? So what was your waiting time? So what was your experience? So pre-intervention, post-intervention, was there any improvement? So there was some improvement, but interestingly, the question that doctor nurseon ne bataya ki aapko dawa kyun de rahe hain? What medicine are you taking? Are you getting information? No improvement. So that's another thing that we have to work on. So essentially, these things are so challenging. They're so challenging. And it's not easy. I know today I'm standing here, I'm saying that for the past 2 years I've been working on RMC. Has there been a difference? Probably something, but I think it's such a long way to go. And definitely we need RMC champions who are passionate about working towards this. Frequently changing providers, you train a team of people and everybody changes, and then somebody new comes in. Interprofessional erosion of trust and demarking of responsibilities. And I think that is something, ye to mera kaam nahi hai. The sister will say, this is not my calm. The doctor will say, this is not my work, right? But the patient is everybody's work. And I think that is something that we really need to realize. And definitely, the data has to come in. And I think that is the role of funding opportunities, to generate evidence from interventions. If I stand here and say, I did so many 15 workshops, did you bring about a change? I don't know. But if I do it at AIMS, and I know in last 1 year I have brought about this change, but that intervention takes so much of an effort to really generate that data. And I think that is where we have to move on and move forward, that from here to the next point where respect is ingrained into each and every provider who's providing care for mother, or in general healthcare provider, I would say. So I think respectful maternity care is just one way of saying respectful medical care, because respect is really required for each and every person who's really visiting a healthcare facility. So thank you very much, and I think it's a long, long way to go, but I think we need to make a start. Thank you very much.
Thank you so much, Dr. Aparna. As Dr. Aparna mentioned, that the culture of respect has to be hard-coded, so that the doctors, nurses, midwives, and all the support staff come together for the respectful care of mothers and newborn. So I would request Dr. Pavan sir, Additional Commissioner, Maternal Health and Immunization. Sir, we will move to the question round after your guidance and way forward. Sorry to change the order because of time, sir. So over to you, sir.
People there. after this, some session is there. So thank you very much. We have, I think time is also a constraint. Maybe a next session will start after that. We have heard aims about the respectful maternity care. We have experience of Vani Villas, beautiful experience of a government setup, how they are working. We have experience of Madam Janvi from Astirika, Miss Inderjit Indi, which we call from Fernandez. We heard WR for the country. We have heard everybody and the experience. And my opening sentence for my 30 years back experience means 3 decades back, what was the condition of labor room, how we have treated, and all my colleagues, they ditto with me actually. And once we talk about respectful maternity care, there's a respect for the care for everything actually. And so what can be the way forward after discussion? One thing which has emerged is basically a demand generation, awareness, demand generation. Second is career progression, how to sustain and maintain for future, career progression. We have already given a guidance from the Government of India to all stakeholders. What can be the career progression? Once I was a staff nurse, I've been trained as an NPM. What next then? Unless until there is a career progression, unless until your designation changes in your visiting card, you don't have a kind of a motivation. Everybody has a motivation in a private setup, in a government setup, from medical officer to senior medical officer to the chief medical officer and so on. For nursing officers to the chief nursing officer and so on. So what about the NPMs? I think that is an area where all of us to work together. Third is own internal capacity building of MEs, midwifery educators, as par excellence with IMEs, international midwifery educators. This is a high time. We have to develop our own midwifery educators, and as per the competency of ICM. There should not be any compromise for the competency and the confidence which we have, because that is a practical hands-on job. So we have to develop our own MEs who can run those national midwifery training institutes, and then further to SMTIs, and so those people at MLCUs, they can be trained and they are fully confident how to handle our pregnant mothers in different positions, whatever they want as per the demedicalization, less use. Another important thing which has been touched about is a cesarean section. Yes, that is a problem for the country. More in a private sector, also in a tertiary care institute. Some of the states, they are called as a factory of cesarean section. People come by flight in the morning, do their job in the daytime. By evening flight, they go back to their respective states. Cesarean rate 80%, 90%. Every mother wants cesarean section. Why? What are the ramifications? At the momentarily you are relieved for your pain and everything, agony and all those disrespectful care and so on. But what are the long-term effect of that? I think that is also a point of advocacy. Once we talk about the respectful maternity care, the midwifery, how we can take care of that part also. Regular training programs, standardization of training programs, hands-on, that is another way forward actually for all of us, how to maintain and sustain. And wherever, whichever platform we talk about actually, so we have to a demand generation and career progression. Both these are the keywords from our side. And MLCUs, establishing of those MLCUs, whenever I review states, I ask them, we have given a funding from Government of India to establish SMTIs and midwifery-led care units. Means where the caseload is high, at least good quantum of delivery must be happening at those centers, so that everybody gets a chunk of a work for them, so that everybody has a learning, all of us. And then is about Aparna Sharma madam from AIMS, actually good job done from AIMS. Being from Delhi, I have worked in the Delhi government also, how to take care of the respectful maternity. Starting from our outsourced staff. Once the mother is coming on a stretcher or a wheelchair, how she is being treated once she enters into the hospital till she actually delivers. Each step demands respect actually. Each step, not at the final delivery point only. So I think all these points, once we talk about an NPMs, I think all those points needs to be taken care of. As per the time constraint, I stop here only. I can speak more about, but I think we can take few questions if the time permits, so that we can listen to the audience also. I stop here only. Thank you very much.
so much, Pawan sir, and we look forward for more discussions and meetings under your guidance to work in a collaborative way. And in respect of time, we can take two audience questions. So I would request Dr. Aarti Maria ma'am for your question, please. And then Dr. Manju Chugani ma'am. Yes, so we have to be respectful to our next speakers. So over to you, Aarti Maria ma'am. Yes, sure, ma'am. So, Mike.
This is to just bring home the point that while we are talking, and it's a very, very topic close to my heart, respectful maternal care, I think we need to be seamless. What I see missing here is the newborn component. Of course, it was, in a passé, it was mentioned, the respectful newborn care must be a part of it, seamless, because it comes naturally, the mother-baby diet being considered one. And it's obviously physical and emotional and physiologically they're so deeply dependent. So with midwifery, I see that the respectful nurturing care can be absolutely be delivered because it's an opportunity. The midwife is the first one who will actually give a gentle, humane touch to the baby who's making a remarkable transition from the in-womb to the external world. And this touch, if it was not gentle, this immediate skin-to-skin contact, if it was denied, if the immediate breastfeeding, early breastfeeding was denied, if this visit or the entry into the world was not in a calm place, it was in a chaotic labor room, I think the whole experience and the bonding, attachment, all this lifetime experience, which is a foundation, this experience will be a foundational to the long-term survival and even the development of this baby. So that is one opportunity. Secondly, I see that zero separation, essential newborn care, and early skin to skin, all these are part of the respectful newborn care, and this, I think, the midwifery has a lot to provide. Thirdly, I would say that, even the maternal mental health, by virtue of providing respectful maternal care, we're actually delivering or giving better well-being to the newborn by virtue of a downstreaming effect of the respectful maternal care to the newborn by way of, giving the RFC. And another thing, I just want to give one more thing, that, the marginalized people who come to the government hospitals, I think there is an opportunity to provide a special care through this respectful ring. And also that we need to have parallel care models we should be doing away with, and we should be giving a collaborative way.
Thanks, ma'am, for bringing this up. And we'll have more discussion, and Government of India has this flagship program, Suban, which Dr. Pawan will guide us further on. And Manju ma'am, and all of us can have a discussion out of this room. Thank you so much for the dignitaries on the dais, off the dais, for your patient listening and this keen interest in midwifery and respectful care. Thank you so much.
I'm a studious boy. I keep on writing the things actually.
But good to meet you again.
Yeah, yeah, absolutely.
November workshop. Yeah, it was very good, and I think people are already from our team, but I'm very
Number and that's your name.
Global Development Center.
Good afternoon. Good afternoon. My name is Hariharan. I head Siemens Health Innovations for Zone India, which includes India and other countries. Very, very happy to be here. Very relevant topic. And we have a very big association with World Health Summit. And this is the first time we are doing this in India. And I think it's been a great session since morning and looking forward, like Simran said, for an engaging discussion. Thank you.
Hello, everyone. I'm Resham. I'm working with Path. I'm leading their AI efforts for South Asia. We're very closely aligned with WHS. We are one of their, the only principal partner. And it's a pleasure to be here today. Thank you for joining us.
Hi, my name is Prashant Puaria. I'm the co-founder and CEO of Cure.ai. At Cure, we build AI solutions to automatically interpret radiology images and be able to diagnose disease early. We focus on multiple disease areas, tuberculosis, lung cancer, heart failure, COPD, and stroke. And today, our products are FDA cleared. We have about 200 plus publications backing our products, and we deployed in about 4,200 sites across about 100 countries.
Hi, Tisha Boatman. I'm heading up Global External Affairs, which is government affairs and partnerships reimbursement, so some of the multi-sectoral types of topics for Siemens Healthineers, as well as healthcare access. Happy to be here. Thank you.
Hi, I'm Ashwini. I work as a director in the PwC healthcare practice. By training, I'm a physician and then I did my master's. I work a lot on the health system design space. So working on sort of policy matters, implementation, and the healthcare design. So happy to be here and look forward to speaking with all of you. Thank you.
Thank you so much. As you see, we have a very diverse panel, so we get really good diverse perspectives. So I'll bring up maybe we'll talk around a couple of areas. So the first one, as the topic of the panel itself says, right, there's a huge opportunity today for India and countries like India, the emerging economies, to really leapfrog, right? There need not be to copy or to imitate the models of the Western world or the more developed economies. Many of them might be more inefficient or just might not work well, right? And in the whole thing, when we talk about leapfrogging, right, we look at innovation and partnerships, which you also spoke about innovation. We also talk about there's a huge opportunity, what we can do, leveraging both innovation as well as partnerships, right, to leapfrog. So maybe coming here, Prashant, over to you. Okay. Would you like to share anything around leapfrogging and how Cure is doing it and what you all are doing to do so?
Yeah, I think several things I want to talk about here, right? I mean, we started in 2016, and one of the things we thought when we started Cure was that the market would be in the US and UK and continental Europe. But the reality was that AI became autonomous in the rest of the world. I mean, WHO in 2021 said that AI can detect TB autonomously in the absence of a human reader. And this is the only place in healthcare AI where AI has become fully autonomous. We read about 10 to 12 million scans across the world where AI is the only reader of the X-ray. There is no human reading that X-ray, right? And this is because you don't have enough people to read those X-rays. And if you look at a country like Malawi, you have 2 or 3 radiologists in the whole country. If you go to Liberia, there is no radiologist at all. You go to Kenya, they have the same number of radiologists as all of Mass General Hospital. So for a whole country, right, 16 to 17 million people. So this is where AI is really useful because it can actually close that scale gap. It can ensure that if you don't have enough trained physicians, trained radiologists, AI can fill that gap and it can do a bunch of different things, right? And that's one way to think about it. The other way to think about it is when you look at screening, for example, X-ray based screening, right? The way that the TB programs around the world are approached is very different. Typically, you go to the hospital when you fall sick and you go to the fixed facility to do an X-ray, but now the X-ray is going to those communities. We have so many of our customers who are taking X-rays on horseback or on boats or on vans or motorcycles, and you are basically going to really remote communities who have no access to healthcare. You are doing X-ray screening there. Also, X-ray is taken, ultra-portable X-ray, backpack X-ray systems can now go into the community. You can take an X-ray, and within a minute you can interpret that with AI, and you basically have a full report within that minute, right? So something that was very hard, and that's something if you look at the Western world, I mean, or if you look at US or Europe, I mean, typically it's more of fixed facilities that are doing these things. What we are seeing in LMICs now is that you are actually bringing those communities, bringing access to those communities, bringing healthcare to those communities, which is not available earlier. So again, this is something which I feel is like a leapfrogging of that, where you did not have to have a fixed facility. You can think differently now because you had nothing. And just like we heard about the mobile phones, right, in India, for example, I never had a phone at home growing up, but then directly went to mobile phones. So I think that the reality is you don't need to have the older systems. You can actually directly, especially with AI, there's a bigger leapfrog opportunity now. You can really rethink how healthcare is delivered to the masses with AI.
Thank you. I think I also forgot to show the data. So this was quite interesting. I mean, maybe just if you leave China, look at it on the left. So most of the emerging economies, you see there's much more excitement when you talk about AI. Yeah? So there's much more skepticism on the right in the developed world, and there's much more excitement. Could also be for the demographics, but generally countries like ours are much more open to try it out. And examples like Prashant just shared. Disha, would you like to add a bit on?
Sure. I think, to expand the topic even further, I mean, there are even more traditional areas that in a Western context, breast cancer would be one of those, but cancers in general, as in the world, as we start to really conquer NCDs and non-communicable diseases with universal health coverage, no matter where it is, the burden of NCDs is so significant that you're not going to solve that with traditional approaches. Prashant alluded to this a little bit. It's not about having many more radiologists, many more clinicians. I mean, of course, training and education is a topic, but when you look at NCDs, and today more people die from non-communicable disease, also in low resource countries or LMIC countries, more people die from non-communicable disease than communicable disease. And when you look at how to solve that problem, it is going to be about leapfrogging, and it is going to be about applications, AI and digital type of applications. And you can look at AI in breast screening as a great example, but you can also look at just digitalization of the patient pathway. So one topic we haven't touched on yet, but is connecting that patient when they have a diagnosis or they have a presumptive diagnosis, connecting them to care, making sure they actually show up and receive care, and that there's adequate follow-up for it. We were discussing earlier today that the pathway is quite complicated. It's not a screen and treat disease where there's, you diagnose and you have a medicine, and as long as that person follows through with the medicine, you've pretty much solved the problem. Cancer, most non-communicable diseases require years, if not a decade worth of treatment and follow-up. So ensuring that pathway patient is connected to care over time, and doing so digitally is a critical topic, I think, to really leapfrog and deal with the good news that people are living longer, but that they're dying more from these lifestyle and non-communicable diseases.
We were speaking yesterday and really enjoyed the conversation we had. You were talking about really the ground realities and the work that you're doing in Telangana with Path. Do you want to talk about that?
Yes. But before I talk about that, I want to ask a question to the audience. How many of you all have been to a primary health care center or a CHC in rural areas, in tribal areas of India? Great. So you all know what the realities are. So when people talk about realities, the question is about what reality are they even talking about? Earlier this week, I went to Telangana. Path works very closely with the government of Telangana. We've established a center of excellence on AI in public health with them. And we are exploring synergies with global institutions, academic institutions, tech innovators to reach the grassroots and last mile communities and bridge the gaps that exist in accessibility and delivery of services, including NCDs, and others. The problem here is that when we're talking about digital health and when we're talking about AI, and then we go and do field work, they don't even have any digital records or infrastructure in which they can collect data. That's the reality of 60 to 70% primary health centers in India, and I'm sure it is so in various LMICs. So the question here is, how are we to bridge this gap? It's not about talking at a very superficial level that this is something fancy, this is happening, and we need to trend this, and we need to really use some technologies to achieve certain things. But it's about how can we improve the health outcomes of 60 to 70 people, of those Indians. I mean, I'm talking in India for specific reasons, of those rural and tribal communities that are living in India but don't have access to health services. So what PATH is doing and what we are aiming to do is reach the last mile communities using digital technologies and artificial intelligence, where we are improving their health outcomes holistically. So we're trying to create a healthcare ecology in such a way that it's not just bridging that particular gap, but also improving their comfortability of working with technology. I think that's very important when we are talking about frontline workers. They are not comfortable in inserting data in desktops, and that is because they're not comfortable working with them. So if you're really looking at improving health outcomes and bringing different innovations to the last mile communities, it's also about empowering them holistically. That's all. Thanks.
Thank you, Dr. Vishnu. I think it was good to start with a question and really talk about the reality that exists. Maybe, Hari, do you want to talk about some of the work that you and your team are doing in terms of innovations, where we could say you're contributing to this?
Yeah, I think access is part of our purpose, and like Resham said, and Prashant talked about AI applications. But as somebody who's also working on the infrastructure side, you need, for early detection and diagnosis, the core acquisition of data, right? And you need modalities starting from X-rays to as complex as MR and CTs. These acquisition also matters. And our innovation is how to make this less complex. How can it be easier, and you don't have skilled people like primary healthcare center and community healthcare centers. So if you look at it, one is you can always get access to, we can innovate affordable technology, but how do you get the best out of it? So some of the innovation which we are working on, and there's a real case in India, is we have several hub and spoke setups. I can name few of them, HCG and Aarti, where you sitting at a central place, you can remotely have video, audio interaction and control the entire patient positioning, scanning, and reporting process. Then comes the applications, which Prashant talked about. We also build applications. They are very important. But to operate, to get the core acquisition of images to interpret and diagnose, you need this infrastructure. And our work is more around how to make it simple and how to centrally operate them remote, and their digital plays a big role. And that is really the last mile what Resham was talking about. Yeah, that's one part of it. Of course, the challenge is also to get most of these modalities at a physical level to be more mobile, and then also make the acquisition easier.
Thank you, very interesting. I think when we talk about innovations, maybe the next one, we were discussing about this yesterday. I also work in R&D in the technology center. So there's always the whole talk around, do we invest in increasing access in the short term, the conversation we are having now, or do we invest in long-term innovation? How do you plan, and how do you invest in that? And we'd be happy to hear.
So, no, I mean, that's a great question actually. But just coming back to the leapfrogging one, see, one thing we ought to be cognizant is that the healthcare models are changing actually. The cataract is practically daycare surgery. Delivery is also a daycare surgery, and probably you can expect that the lady is going to be discharged tomorrow. So the models are changing a lot. What it means for us is that some of the matrices that we have been traditionally gauging, they ought to get changed.
our metric has been number of beds per 1,000 population for any country. Now that metric has lost relevance right now. If you track for many of the countries, the bed density has actually been falling because the care is moving from the hospital to a high complexity OPD center. The care is moving from the hospital to at home or maybe remote care actually. What it means for India is that maybe we ought to reconsider whether we want to reconstruct the hospitals, build more hospitals, achieve that number of 2.5 or 3 beds per 1,000 population or not, or maybe we start investing in new models of care. Like Bhushan mentioned, we need not have to lay those physical telephone cables and all that because now it's the era of mobile phones or a satellite phone, things like that. Same thing is going to happen to the healthcare also. So I think when we talk about where do we want to invest right now, it has to be very strategically allocated, looking at what the trend is happening in the country right now, or maybe at a global level. In the past 5 years, we have seen 3 disruptions. One was COVID, then was Gen AI, and now it's the trade barriers actually, trade wars which are happening globally. Now, these are going to disrupt everything. People are saying that, like, for example, the funding in the TV space is going to come down or may get change in the future. The pharma supply chains, they're going to be reorganized a lot. The digital healthcare, it's going to go a complete transformation. The DPDP Act has been there, the rules have been defined now, still at the draft stages, but it's going to have implications. So again, I think for me, if you want to allocate your resources for the current problems in the future, it has to be strategically allocated. You need to have a long-term view. You can't put all the eggs in one basket. Again, those traditional levers, the public-private partnership, things like equitable governance, things like, for example, democratizing the data, they all ought to come in picture.
Thank you. It's a question that we also often ask with our purpose, and then of course you want to innovate and then also not forget your purpose, all well aligned. Maybe we move to the next part, and Nivisha, you showed this also in the morning. Women's health. I know there are quite a few sessions also happening on it. A huge gap, huge disparity. I feel very passionate about it. Many of us in the room, I'm sure, personally associate with this. There's a huge disparity across how late women are diagnosed, right? So if you see the data, a heart attack, 50% more likely to be misdiagnosed, right? And we were, I think I was talking to somebody, one of our senior leaders, that even how you see the symptoms that are shown, say, in Hollywood or in cinema or in Bollywood, right? It's the symptoms are also very much how a man would get a heart attack. You don't really show symptoms how women would get a heart attack. So all of it, the biases that you see, very, very, I mean, it's a very simple example, but generally if you look at the data also, the investment in this one lady, sometimes I talk to it also about my daughter, only 1% of the healthcare R&D goes into female-specific conditions, right? So, and there was very interesting, which says that women in the household, pretty much more than 70% on the right, if you see, take the household healthcare related decisions, especially when it's coming out of pocket. A lot of decisions at home around healthcare are being made by women. Still, the industry doesn't cater much to them. So, of course, this is a topic. Maybe I'll start with Isha. I know you strongly feel about it. And you're on the Women in Alliance, and that's Isha.
Yeah, I mean, at Siemens Healthineers, we play a big role in the World Economic Forum's Global Alliance for Women's Health. One of our board members is representing MedTech globally on that alliance, and I'm the deputy board member, where a lot of this data comes from. But I think, in women's health, there are all of the topics you see there, and then, and I think one of the most poignant for me is the fact that women do take the majority of health decisions for the family. They're, the center of a family, and yet they often don't take care of their own health, right? They're the last person to go get their own screening exams. I've personally been around women who say, yeah, but maybe I don't want to know if I have breast cancer. I'm a breast cancer survivor myself, but maybe I don't want to know if I have breast cancer because I can't afford treatment. Or if I go for treatment, if the family pays for my treatment, we won't be able to send my son to college, right, to school. So these kinds of really tough decisions that women are making where they're placing family members ahead of each other. I think one thing that's not up there that's very interesting for us to all think about, when you look at health systems around the world, a lot of work is done by community health workers. A lot of very good work is done by community health workers. We're getting better at enabling them with digital technologies and AI to really kind of leverage that work. But 70% of health workers are women, and yet women hold less than 25% leadership positions, even in well-developed health systems and in hospitals, right? There's a real lack of mobility career-wise for women leadership in health. And it's something that also needs to be addressed as part of the full system to really empower women to take those decisions they've been making at home, also be part of leading health systems. There's also data out there that shows that when you have a more balanced health system leadership, when you have better diversity and not only gender diversity, but also looking at underrepresented populations, rural communities, et cetera, that you have much better results in your health system, right? You're more likely to understand the topics of advocacy, of patient education, of really getting people into the system. And then digital tools are so important for helping people connect to the system and really get the most out of it. So I think it's a quite interesting topic. Women's health is an area where we absolutely need leapfrogging.
Absolutely, and I mean, even if you look at India, you see every year, the entrance exams for medical schools, you see mostly women are the toppers, right? So it's not that there's a lack of capability or anything. Definitely, as you rise up, there is a gap. So thanks for bringing that topic in. Resham, would you like to add something? And I, of course, don't want only the women to answer this. So please chime in. We need the men on the table to contribute to this, right? So,
I'm sure men have been contributing for a very long time. That's why we are here. But I think the problem is in the mindset. As women, we are so conditioned to consider ourselves always last in our families, and last in relationships, last in healthcare. That has ingrained and become intergenerational cycles that it takes ages to break those cycles and traumas. I think it's not, when we're talking about the health gap or the gender gap, it's not just about access. I think it's also about equity, it's about research, and it's about representation. Not having a bunch of men making decisions for women about what should happen and how it should happen, but it's about involving women in designing the systems that works for them. For example, during one of my field works in one of the state, I don't want to mention states because if the government representations are here, then my relationship gets spoiled with them. But most of the states, if you go to the labor rooms in primary healthcare centers, you'll understand that the bed that's there for women to give birth is in a very deplorable state. I cannot even imagine myself sit there, even though I'm not pregnant. But for a 9-month pregnant woman to give birth without having the necessary instruments is difficult. And that particular PHC on an average gets about 20 deliveries done every month. So you can imagine the state in which there are births given. And I always go to the last mile communities and the underserved and underrepresentation because it's important to talk about them. While it's important to talk about trends, I think it's very important that we have need-based, demand-driven, contextualized innovations made for women that bridges the gaps and have women involved in the entire design processes so that it caters to them at the right time and at the right place. Thank you.
thank you, Reshma. I think what's really good that's happening is, at least in, you see, we know that globally, very few women-led startups are funded, 2%, 3%. The number always hovers around that. You see more and more women go into investing in finance. And actually then they build solutions which are solving these problems. So that's, at the end, finance world also runs a lot of these things. So you see a lot of transformation happening there. Over to you. Would you like to share?
Yeah, I think it's a journey. We need to definitely, the gap exists. We have to build better healthcare for women. I think we have started in a smaller way. We have about 30% of women. We have a large team in India and 1,000 people in the technology team, almost 30% are women. So one is having diversity in the team. The whole idea is to build it in the outcome side, right? So it's a journey, I would say, and one smaller other step we have taken is to broaden the whole AI community for women. And we recently ran a global healthcare innovation challenge uh, within the system, but it's a good start. But clearly the focus is not, I mean, if you do innovation without inclusion, it definitely misses the mark. So the idea is we start with the teams, and probably over the few years, it's relatively easier to build diversity in technology roles, but we have also done this in the field roles, what Rishma said, what she faces. And I can give you examples where today, what we think is typically the, let's say, man-engineer challenge. I mean, we have field service engineers, field sales people who are women who deal and operate with this equipment. So I think the change is happening, but long way to go. But we have started in a small way.
Thank you, Hari. I think this is a big strength India has. I mean, I returned after 20 years, and I remember going to Bangalore and interviewing, and I said, I've never seen so many women like in STEM under one roof. So this is a great strength that we have, and it really gives us the ability to build innovations and solutions for us. Moving, would you like to add? Yes, please.
Yeah, so I think the issue is underplaying the problem. It's not actually one lady on one bed. If you go to some of the hospitals, you'll find three ladies on one bed actually. And it's not three ladies, actually three ladies plus three babies plus the mother-in-law plus the father. So you have the entire meal around that one bed. That's a hard problem that we see in India. But having said that, what we have also seen is that after COVID, when many of the consultations went online and the number of teleconsultations went through the roof, almost in all the specialties, the number have come down. It has come down to the baseline of the marginal improvement over there, barring two specialties. One is psychiatry and second is the women. Because of the privacy issue, because of other factors, at least in those two specialties, we still see a significant jump from the baseline in the number of teleconsultations happening because women have adopted this in a much better manner than what men have actually. So I think from the topic perspective, digital and AI, women, I mean, they have great role to play to inform the women healthcare considerations.
Thank you. Feel free if anyone wants to chime in. Maybe just moving on to the next, I think the number we've seen it this morning on a couple of talks. The biggest problem that our industry faces today is the shortage of workforce, right? Skilled workforce, general, and globally numbers are quite. So it's 11 million shortage by 2030. And of course, more on the positive side now with the whole, many of you are very young also in the room, generative AI, I'm guessing you all are playing around with the tools. There's a whole talk that Gen AI, the biggest potential an industry which has is healthcare. Mike will just again show some number here. So you see that Gen AI is projected to grow faster in healthcare than in any other industry. Now, so okay, there's a huge gap. Can we use this technology which is supposed to automate, do a lot of work? We were talking about AI agents outside. Right, so what can we do? How can we leverage this? And maybe Prashant, you can start since you were talking about this outside the room, yeah? What you all are doing.
I want to ask a question about Gen AI. How many of the audience have used ChatGPT to diagnose a condition for either themselves or their family members or friends? How many have not done it? I think, see, today, I mean, if you look at AI, and this is generic AI that is available, right? I mean, ChatGPT, take it, Anthropic, or any of them, right? They have, AI is able to really understand conditions. And think about it, I mean, it's seen all the publications out there, it's seen all the medical books out there, right? It can store all of that in its mind, and it can make inferences based on that. And so, from a medical perspective, I really believe that we are not, I mean, future of medicine, especially primary care, can be run by AI. What does primary care do? It is collecting symptoms, doing some primary initial testing, what kind of investigation you should perform, providing some primary diagnosis. A lot of that can be done by AI. Maybe not right now, again, it has to be super accurate. We cannot make mistakes there. False positives, false negatives are a problem. But I think in 10, 15 years, that is a possibility. But even today, the reality is that at Cure, we are launching this product at WHO, just talking to Disha about it, where there are 4 things that the algorithm will do. This is basically a tool that is available on your phone. And firstly, it will listen to a healthcare worker-patient conversation. So if the healthcare worker or a doctor is talking to a patient in any language, could be Yoruba, could be Hindi, could be Malayalam. It will transcribe that, understand that, transcribe that. It will provide recommendations to the healthcare worker. They're collecting symptoms, for example, of the patient or history of the patient. It will ask them the right questions, that this is what you should ask the patient. It will give them those suggestions on what they should ask the patient. It will provide investigation recommendations, what investigation you should do, chest X-ray, blood test, malaria test, TB test, right? It will tell you what tests you should do. It will also give you diagnostic recommendations. And all of this is based on Gen AI, LLMs that are available, including translation, the voice to text, summarization, recommendations. And these are capabilities that AI has now. The main thing is that how do you build guardrails around it to ensure that you are empowering the healthcare worker to make the right decisions, or the physician to make the right decisions. Because you don't want to end up in a situation where they make the wrong decision because AI recommended them something. Right? And with this kind of technology now, I mean, I think the number of healthcare workers was the previous slide. Right? Every healthcare worker is now empowered to potentially become equivalent to a primary care doctor because they have the power of AI behind them. With an AI plus a healthcare worker, they can be equivalent to a primary care physician. And that is where AI can really take healthcare. I think the real opportunity is very, very big. If you look at US venture capital, for example, almost, I would say 40-50% of the investment in US VC AI is going to healthcare AI. So basically everybody, I mean, all the venture capital, everybody believes that the biggest opportunity for AI is in healthcare. And there is a huge opportunity to upskill healthcare workers. And like I said earlier, right, when we started Cure, we thought the opportunity was only in the developed countries, but there is a bigger need in the developing, in the LMICs, low and middle income countries. And this is where you'll see that AI will be adopted quickly, and people will start using AI to diagnose disease. And this can be done either directly by the patients themselves, it's probably likely to happen, which is a little bit risky. But definitely healthcare workers and primary care patients should start using AI to really upskill themselves so that they can provide better care to their patients.
Bhushan, going back to ground realities, how optimistic are you here? Or?
And I'm just surprised by the stark remarks that you're making, that with the power of AI, health workers can become doctors. What was that? Yes? Well, I don't quite agree with that. Because, see, AI is great, and it's great to strengthen healthcare workers' skill sets, but I don't think they can become doctors with that. What I do feel is, so during my interactions with ANMs and ASHA workers, you know what they do? So when they go, they in terms of NCDs, they go to different household surveys to do surveys. And so they do the surveys and hard copy records. So they have a huge register. Then the ASHA workers go to ANMs, and then the data is translated to the ANMs, and then the ANMs collect the data again in their hard copy register. Then a data analyst or a data interpreter takes the data and then puts it into the computer. There's no use of digital tools there. So when we're talking about AI at the grassroots, there's a lot of work to be done, right? So there are a lot of people who say that AI can transform a lot of things, and there's definitely no deniability in that. The question is about how. The question is about who's going to implement it. PATH is one of the largest implementation agencies, and we know what it takes to implement things at the grassroots levels to have sustainability and last mile coverage there. So it's about collaborations with innovators like Cure AI, with CareMother, or with somebody else. It's collaborations with the governments. It's only through these partnerships can we reach the last mile communities. And then with the power of AI, support the health workers in empowering them in different holistic aspects. So I think that's something that's very important.
Yeah, I think that's happening, and even not only just rural, right, data, building the foundation data, connectivity, the training.
I just want to add something there, right? See, I think the reality is that with AI now, you on a phone, on a simple phone or a tablet, you can provide AI to the healthcare worker, and they can be empowered much more. I mean, so, and the point about taking notes, right, putting it on a computer, all of that can be done automatically by AI. And
I totally agree.
the point is, I mean, I think the opportunity is large. The question
Agreed.
is how do you change the process to enable that to happen?
That is through.
And again, process change is always hard.
See, process, I agree with that. That's the problem. There are, in India, there's such a stark disparity that if we can get access to high quality services in private sector institutions, why can't we get it in a district hospital? Because people don't want to get there.
It's hard. I mean, the government is so hard. I mean, getting something for us, I mean, we work with private hospitals across the world. We work with so many NGOs. Getting anything to
I agree.
Cure is so hard, right?
I'm on the same page with you. What I'm getting at is we can definitely do that through a set of collaborative approaches to reach the last mile community. So the tech is there, the implementation agencies are there, the government buy-in is there. Only then we can approach that.
I think I love this conversation, and that's exactly what we need, right? We need people to come together and collaborate, because I think the technology has the potential. I'm with you there, and the ground reality is something, but we need to come together to actually really cover it.
And I think to what you said, right? I think it's about people coming together to solve that problem.
Yeah.
I think, and we've seen that with Siemens and Cure coming together in Philippines. I don't know if Tisha you want to talk about that, but.
Yeah, I would actually, I mean, we could talk about that, but I want to shift the conversation a little bit. When you talk about a different perspective on looking at the shortage of healthcare workers and the use of technology, is a little bit what Hari was talking about before. You can sometimes help healthcare workers remotely. They don't have to be physically there. You don't have to have your highest level specialist in every geographic location, right? You can bring in the specialists through telemedicine type of solutions, through remote type of capabilities. And there's a big opportunity to train and upskill healthcare workers with AI as well, right? And if you look at just like technicians to repair equipment, right? So one of my big nightmares out there, and it ties to both what Prashant and Hari were talking about. Hari was talking about having the modality and acquiring the images and acquiring the data. And then Prashant's talking about, okay, you process that data and you make a diagnosis. But what if nobody serviced the equipment, right? What if the stuff is not working? And unfortunately, if you look around at under-resourced environments around the world, you have a lot of what we call orphaned equipment. You have equipment that worked in the beginning, that people were trained on, and is now left. It doesn't have the assays anymore to run the lab tests. The maintenance wasn't done. The hard drive's not been cleaned, and there's these different issues. But when you look at well-trained technicians, and I'm a big believer that somebody who repairs a copy machine can repair a piece of medical equipment with the right training. When you look at even well-trained technicians, they probably only do that particular task once or twice a month, right? Even somebody who's full-time servicing medical equipment, there are some routine tasks that happen all the time. Those are the very simple tasks. And then there's the more tricky things that they've only done it one time, or they haven't done it for the last 2 months. In the meantime, the technology has changed slightly. The software's a little bit different. The spare part that was sent to them was different. But Gen AI is a great example of where allowing kind of a large language model type of training where an engineer on the ground can ask a question in Gen AI and get the latest technical document on their phone very quickly, right? And these are technologies that we're investing in, others are investing in. Super important to keep equipment running, right? Healthcare is super complicated. It's a huge ecosystem. And I think too often we leave out the aspect of keeping that equipment running and helping staff, to maintain serviceable equipment, because boy, is it a tragedy when you have equipment and you have staff, but none of it's working, right? It's a lot of good intent, but unfortunately, abandon good intent. So for me, it's part of this topic of really keeping a health system working.
Thank you. That's a great point, because customer service is the area where at least the application of Gen AI across industries, healthcare or not, has been most successful, and very rightly. You see here of so many equipment just lying around within Africa and no service engineer to service. Thanks, Disha. Kali, you wanted to chime in?
Yeah, maybe I don't know how to join issue on this, but I guess I think the progress is so dramatic. I don't think we are far away from the day when ASHA worker, what Reshma mentioned, can really operate an MRI or a CT scanner. It's getting autonomous push button, and in my view, it's not really far-fetched, and there are real use cases already emerging. So I understand the challenges in the field and how it works in primary, but I think we're not far from the date where a nursing team can operate a system, and that's the challenge for us, how we build that, how we make it easier. But I think what we want to achieve is make it faster, make it error-free, and I think AI will be a big play on this. We often talk about applications, which is because we're used to them, but I think in medicine there is also the other side which is not seen, which is what Tisha also talked about. Service, autonomous, self-diagnosis, these are happening, and it's not too far away.
Absolutely, and even if there are, especially in our part of the world. We had the discussion
Sure. So, I mean, if you look at the digital revolution that has happened in India post 91, is that it has actually happened in different waves actually. The first wave was the telecom revolution when the entire telecom sector got digitalized. The second was the financial services, and the third has been the largest part of the e-governance reforms. So you see this, all the digital public goods, Aadhaar, UPI, DigiYatra and all that. By all consensus, healthcare is going to be the fourth wave actually. There is massive evidence of the kind of revolution which the healthcare or the digital healthcare can bring in, making the healthcare more accessible, more affordable. And this is going to be throughout the life journey of the patient. Like we were discussing yesterday, from womb to tomb actually. Your data, while we are still inside the mother's womb, that data is going to be captured. It's going to be part of our longitudinal medical history. The time we come out, the vaccination records, school records, what you call that, our entire adult, and then to the death actually. All those records are going to be digitized and they're going to form a part of the digital health summary per se. Now, and again, AI is going to play a big role over there. And I think we can debate, like for example, whether it's going to be the manpower capability or the infrastructure strengthening and all that, but the digital part is going to stay. That's the reality actually we have to live with. I would just like to modify what Prashant said actually. I don't know, like for example, if the AI will replace the doctor or not, but definitely a doctor with AI will replace a doctor without AI. That's a hard reality. The way we are taught medicine in the curriculum right now, and I'm talking about 20 years back, we were supposed to rely on inspection, palpitation, percussion, auscultation, the four classical ways on how you diagnose a disease per se. I think now they would have added a fifth one also, which is the digital care. The Medical Council of India, now they have added a digital curriculum in the MBBS curriculum. We are seeing universities like, for example, Maharashtra University of Health Sciences. They are having those HIS, EMR, HR training given to all the doctors as part of the medical curriculum per se. But these are all piecemeal effects. These are all piecemeal initiatives. What we need to do is we need to bring them all together on a single platform, maybe standardize them a bit, and make it more contemporary, make it more actual. The way the ecosystem is changing, what may be taught today might become absolutely irrelevant 3 or 4 years down the line. So that ought to be standardized, and probably that is how we can make a much bigger impact than what we are inspiring right now for. Yeah.
Thank you. I mean, you're the physician in the room, so good to get your perspective on
That is why I was a bit biased.
That's also true. So maybe this is the last piece on AI. I mean, we can't close it here without talking the whole ethics. We spoke about women's health, but the whole bias discussion, that's not a hot topic that's always discussed and needs to be discussed. I just wanted to share the story I read of a couple who had similar income, expense and debt, but a credit card company, when they did their credit limits, which was done by an AI algorithm, they set the woman's limit to half. Yeah? So, and you have these, I think it was Amazon that had issues right in the hiring, there was a bias in the algorithm. So there's a lot of learning all the companies are having, as you said, Hari. Technology is moving way faster than we as organizations are ready to adopt to it, right? So there's just every day new models that come out and so much needs to be relooked at. So how do we do this? How do we shape it more responsibly, ethically? And I'll open it up, maybe whoever wants to go first. Yeah, Isha, please.
I mean, maybe I'll just give quickly a health example. I mean, again, I'm a breast cancer survivor. I was diagnosed in a public health system in Denmark, found a lump, was in the middle of COVID, so was immediately able to get a diagnostic mammogram and had the works, right? Had lumpectomy, mastectomy, chemo, radiation therapy, took like a year. I've met so many women around the world who didn't have access to breast cancer screening, right? And one of the biggest reasons that still today, where you have mammography systems and you have educated people, very often radiologists don't read mammo. It's a very complicated scan to read. It's one of the most difficult ones. Everybody's trained on it in school. It's part of the standard training. But if you don't practice it, it's a great example of if you're not doing it regularly, it's very difficult to do. And so you find many, many programs where we find hospitals who have, I'm aware of one in Indonesia that has 11 mammography systems and 3 of them are regularly used. Why? Because that's how much they can read in any given week. So AI for breast cancer is a great example, but the women's breast is not the same around the world. Dense breasts look much differently. The Asian dense breast is quite different in Vietnam as it is in China, as it is in Indonesia. The software that we use for AI for breast imaging We've run pilots now in Vietnam and in Indonesia to, essentially test out and ensure that that AI and that algorithm and that data set is detecting in that particular body type, which very substantially, I mean, there are other parts of the body that are similar, but the breast is extremely complicated in terms of the biology and the way that can be read in imaging. It's just one example where, a AI algorithm that hasn't been properly changed, say for the Vietnamese woman, will not find the cancer, right? And then you have a significant issue there. And diversity in our data sets globally is an issue. There is no doubt about it. We all in the companies in the industry seek out actively to build diversity into our data sets, but it's very hard to acquire a high quality patient. You really want complex patient data, right? You want all of the different pieces in order. It's really hard to acquire those high quality data sets in places like Africa, right? There are sources and everybody's getting a little bit better at it. But breast cancer is a great example where you have a significant risk in using AI that has not been properly trained for the particular population you're addressing.
How is it that, we've seen it in Europe, regulation, you want to regulate, be ethical but not stifle innovation, right? So how is it, I don't know, any experience there, any of you want to talk about it?
So I actually want to draw more on what Tisha was saying. So there are a lot of innovations that have been deployed in high-income countries, or let me narrow that down to an urban setting. It may not necessarily work in a tribal setting because the lighting is different, the instrument quality is different, the entire ambience is very different. So in order for a particular product to be used at different health settings, it's very important that we test them at those particular health settings. So it's more contextualized, by contextualized, I don't just mean those contextualization based on certain rural or tribal health settings, but also within the demographics or within different geographies, which are very important because, like you said, women's breasts are different. In similar way, their conditions can be very different. The health conditions that are experienced in the West may not be experienced by our demographics in India. So having contextualized and localized innovations is very important. That's the first thing. The second thing is when we talk about AI ethics, I think it's also very important that, so India currently is balancing between not stifling innovation, but also it's pro-innovation, but not hampering human rights as well. Whereas the EU Act is more so, they're trying to change the GDPR, all of that. I think it's important that we keep in mind the human rights that we need to safeguard, and keep in mind that not all of us are digitally literate. So when people go to the grassroots and then they want to deploy their solutions, they know those people are not digitally literate, and that can be misused. So I think voluntary guardrails is very important that companies should have, and a lot of companies have voluntary guardrails that they usually follow. So I think that's something that's very important.
Maybe I'll just move to the last topic. I see the room is quiet. I want to give some time for maybe some conversation with everyone. So just the last topic on the agenda, medtech, healthcare in general is a big contributor in terms of greenhouse gases. So climate crisis is a health crisis now. We start hearing more and more the conversation that the climate crisis will also lead to, of course, issues which will be faced by all of us, also with healthcare providers, how do you build resilient systems. You had the conversation in the morning with Dr. Rana. And what are we doing as well as a company, generally what everyone is doing to reduce emissions. Maybe Hari, do you want to share something here, what you're doing in India, you and your team?
Yeah, I think while we have larger goals to reduce carbon footprint, scope 1, 2, specific to our setting, and like Reshmam said, what works for us, we do build systems which work in the humidity and the temperature that is here. Second is when we talk about sustainability, and since we build physical hardware, so I have to talk about it. And these involve a lot of power consumption, and one of our goal is to reduce, and it also makes it affordable, right? The running cost of power is not. So our goal is we are building something here which is relevant for India and which consumes less power, less space, and there's also resource constraint setting, like what Reshma mentioned in terms of temperature, humidity, weight, where can you make it accessible? So some of our innovations are about breaking this barrier and making it, and also make it environmentally sustainable. And some of the technologies do consume very rare resources like helium, and our own vision and ambition is over the years that we completely reduce dependency on helium, which is a very rare. So I talked about products, and I think what is interesting is some of this is definitely being built out of India.
Prashant, do you want to, I mean, I can't call you a startup anymore, but what have you all been experienced? Have you all built in sustainability from the beginning, or is it now that you're looking at it? Or?
So I think for us, I mean, we don't have any production, any facilities, right? The only carbon emissions is travel, and that is something we're definitely trying to control. I've seen, for example, AstraZeneca is a customer of ours, and I've seen them be super tight on travel. They don't allow any of their, I mean, so every person gets a certain amount of travel based on their role, and they travel much lesser than any other company that I've seen. But that's something that we're trying to implement in our organization as well. But nothing more than that yet. I mean, I think it's
I mean, I will call out AI again. I did not discussion. They say some of the models are going to take a city worth of energy as they built, but that's the other giant. Do you want to?
I mean, again, given a larger viewpoint, so climate change is a reality actually what's going to happen. As per the recent reports, we may have tipped the ballpark of 1.6 degrees Celsius, which is going to be catastrophic. By catastrophic, I mean, especially for the LMIC countries, the coastal areas and all kind of things, it's going to be catastrophic. And we may have tipped that point, that's going to be rather irreversible going forward. The problem is that when we talk about the climate change and the response to that, we typically talk in terms of the mitigation. Like for example, what we can do to reduce the greenhouse gas emissions. And that has been a global phenomenon. You'll be surprised to know that 90% funding that comes with the climate change goes on the mitigation side of it. How do you reduce the climate, greenhouse gas emission, things like that. Very simple reason. It's more tangible, it's universal, you can cost it better, it has a carbon trade offsets, economics behind it, multiple reasons behind that. The problem is that only 10% funding or maybe only 10% discussion goes on the adaptation side of it. In fact, Ministry of Environment, Forest and Climate Change, yesterday only, I think the day before, they announced a plan on the National Adaptation Plan. Reasons are many. Adaptation needs to have a local relevance. If the Switzerland industry is losing the tourism sector because of the snow melting, they will develop a technology solution which will increase the snowfall density over there, or maybe have an artificial snow, which may not have a relevance in the sub-Saharan Africa. So that's one primary reason why we don't talk about adaptation so much. The good opportunity for India is that India in a way is a microcosm of all the geographical climate that we see. We talk about the Köppen classification, Thorndike classification, India would have probably all of those in some parts of the country. So India can in more ways than one become the hotbed of innovations on the adaptation side of it. You want to develop a locally adaptable solution which may have a global relevance, India can become that factory, that fulcrum, that innovation lab. So that's my take on it. When you look at the climate change, please look at the mitigation as well as the adaptation side. Adaptation is going to be much more crucial. We are talking about, like for example, this oxytocin. Oxytocin is an injection given to every pregnant woman to stimulate the uterine contractions during delivery. Now this oxytocin, the traditional one, has been extremely heat labile. And you know the facilities in the PACs and CSCs, the oxytocin does get damaged over there. Now there's a discussion that can we have a heat stable version of oxytocin which will not get damaged over there, and can we improve that insolubility in those particular things. It's going to be much more stable, much more effective, much more cost effective actually. So that kind of discussion is already happening, and I think once again we're talking about climate change in healthcare, so that's going to be the program of it. Thank you.
So maybe just the last, I think the closing, what do you see kind of the next big thing, next 5 years, or where would you bet would lead us to more equitable healthcare that we've been talking? Open to anyone if anyone would like to take it.
I think one of the biggest things that we will see in some parts of the world, and I think more in low resource settings in LMIC countries, is a real addressing of partnerships. So activities like we see in the United States right now, other places where we have significant geopolitical conflict, I believe it will move us towards more true public-private partnerships, right? And I sit here representing industry. There's always a little bit of a doubt. Industry, you're in it for profit. Yes, we are. We're in it to make a business. But a sustainable business where multi-sectoral partnerships are absolutely critical. We partner with Cure AI, who we also compete with in other parts of the world, because we can solve global health challenges that way. That work is also done with the Global Fund, one of the biggest funders in the world for HIV, TB, and malaria. And it's also done with an NGO in the Philippines called the Philippines Organization for Business. So it's a business NGO where businesses are investing and improving different topics in the Philippines. And of course, the Philippine Ministry of Health is also involved in that, right? So I just named MGO. I named 2 industry players who are also competitors. I named the government. And there's obviously a number of patient advocacy groups that are important there as well. So for me, we've talked for a long time about partnerships, and there are definitely some good successes out there in partnerships. I can talk louder and talk right over it, it's fine. But there are some good successes out there, but I think when you have the complexity that we have and this so-called VUCA world and all of the challenges in geopolitics, mindset and leadership and people coming together to really solve challenges, I hope that, and I really see potential for that in the next 5 years to be a game changer. And those that don't want to cooperate, I mean, yes, understand, strong naturalism, but those that don't want to cooperate will be left behind. That's really how you're going to leverage innovation.
Thank you so much, Disha. Really fits the need of the hour. And Morning also use. Go ahead, Bhushan.
I was just going to say that what I said earlier also, I think AI today is advancing at a very rapid pace, and I really believe that next 5 years AI will make a significant change to how we deliver healthcare around the world, especially in the low and middle income countries where we don't have enough resources. And we will see that acceleration. Again, I'm optimistic. I'm an optimistic person by nature, but I think we are going to see that happen in the next 5 years for sure. That will change now.
Whether we replace the doctor or augment. We won't have the
There's not enough doctors. Actually, I don't say that. I mean, there's not enough doctors. It's not replaced. It's replaced an absent doctor.
Yes. So there's one thing in addition to what both of you all said. I think it's also very important that we move, especially the LMIC country leadership, move from a following mindset to an aggressive leadership mindset. And that is because usually the Global North organizations wants to call the shots, which is great, but they also want to capitalize money to invest in LMICs, and the grassroots realities are very different. So having representation of LMIC leaders where decisions are being made is important, where community leaders are being made are given that kind of a platform to make decisions are also very important, and not just following the instructions, but also influencing them is something that I feel is very important, especially coming from low and middle income countries.
Thank you. So 3 very different perspectives so far: partnerships, AI tech, and seat at the table. Hari, over to you.
Yeah, I think it's not just India. Half the world doesn't have access to good quality healthcare, and it's just not India. I think like Ashwini, said, we can't scale the physical infrastructure to meet these demands. So I would probably put it wider than AI. It's more about digital, and I think that will make a big difference, and that will happen. And that's the moonshot, I would say, in terms of how we deliver healthcare. It's going to be physical and digital, and the whole idea is to make it precise and non-invasive. So, and I think digital will play a larger role. And it's not just India. And India is the best place to make it happen because of the talent what we have. So that's the way I would say.
Want to close with a clinician?
See, I think 5 years is a long period actually. You never know what's going to happen, not going to happen in the 5 years. But I do hope, like for example, when we meet in 2030, the digital AI or a health tech would have solved the problems of the healthcare accessibility and affordability to a large extent. Then I think we're going to have a discussion on the healthcare that we have. Is it acceptable or not? Are you going to be comfortable with the idea of having a Neuralink chip in your brain or not? Are you going to be comfortable with the idea of having a chip in your arm which can detect your spend patterns, your pizza patterns, and detect, like, for example, can you order the next pizza or not? Is it going to be, like, for example, you're going to have a debate if the healthcare is more accountable or not? Like, for example, you go to a doctor, you spend $10, are you getting the right form of the care or not? Is the public health system accountable or not? I think that's the debate we're going to have in the next 5 years. But again, that's a dream actually we much yet is to be seen. Thank you.
Thank you very much. So wonderful, all different perspectives. Thank you for all your time. I think we have maybe 10 minutes. Is there any question from the audience? Oh, there are lots of questions. I thought that people were more quiet.
Actually, the guy standing in the back was first.
Okay, okay. So we have 15 minutes. Yes, please.
Thank you so much. So, yeah, my question particularly for Resham, like in like one of the points that you made about, like, you know, how ASHA or A&M workers, like, they collect data on the ground. And you mentioned that they resort to notebooks and it's like a hierarchical process where a data typist like finally enters what they do. It's a bit appalling considering the government push for DPI, Ayushman Bharat, and I think there is a larger push at the national level. So considering that notebooks are the primary, well, it's something very appalling because there's a lot of potential for data loss, right? And duplication as well. So is it just the government failure, or in your experience, have you also seen that there are some roadblocks as to collecting data, like maybe A&M workers are not trained well, or the software is not designed well for them to collect data efficiently? Where do you think the pitfalls are?
Very good question. So I'm not the one who blames the government for a lot of failures. I think it's the citizens, it's communities. Because if I blame the government, then what's my responsibility as a person? So it's not just about rights, it's also about responsibilities that we have for our own countries. I think it's a systemic issue, right? I feel, how do I answer this? So when we are talking about collecting data and we're talking about digitizing, not digitalizing also, let's forget digitalizing. When you're talking about just digitizing systems, it's not just about having desktops set up and then we tell ASHA workers, now you come and now you go to the field and collect data. It doesn't happen in just that way, in one way, right? There is a lot of other processes that are involved, and in order to have a good outcome, we need to invest in processes and in setting up systems that work for us and for the government, for the communities. So it then comes capacity building. So even though ASHA workers are trained, and I have spoken to them, and they are trained 4 times a year. The problem is, like Tisha had highlighted, sometimes tablets are not working. You know, sometimes computers are not working. There is load shading. There's no internet. There's no Wi-Fi. The desktops are not working. It's not serviced. So even if some donors have come and set up 10 desktops at a particular health center, you go after 1 year, it wouldn't be working because there's no sustainability plan. There's no government ownership eventually if that's their sustainability plan. So in order for having these things work through, I don't think it's only the government responsibility. I think there is private-public partnerships that can come in. There can be a lot of CSR institutions that can come in. There can be people like you and me who can come and work on such aspects together with the government, because government is a whole new beast altogether. There's a lot of scalability that can be done through governments, but implementation agencies like PATH come in, where we support the government to scale services, to sustain different services. So I think that could be one of the ways we can achieve better things.
I'm a fan of Resham. She loves to down to the things. Sometimes it doesn't work. Sometimes.
See, I have to use this language, you see.
Okay, maybe gentlemen here. We'll try to take as many as we can.
Yeah, my question was, I think there's a lot of optimism about AI. I wanted to understand the panel's view on the barriers to leapfrogging. I think that's an important debate as well. I also wanted to share a comment. I think it's the positioning of doctors versus AI team probably not appropriate, because there's a lot more to a doctor than just diagnosis, treatment, there's empathy, there's compassion, there's counseling. So I think we
We don't believe it will replace. We work with the community together so that the doctors have much more time to exactly do what you said, right? Spend time with the patient. So our view is different. just making it clear.
The question was really on barriers, right? I mean, we've hit a few of them, right? There's the serviceability, the availability of internet, the serviceability of the equipment, and having, you know, things. We also have topics around bias. We also have, you know, topics around some of the most critical diseases where AI could benefit. Are very low volume diseases, right? So we think of digital technologies as like scalable, but are people really working on AI for, you know, very rare and where it could be most useful, right? Where a doctor, even, I mean, as an example, just a desmoid tumor is a benign tumor that occurs in certain cases. Unfortunately, I've had one of those as well. And there's one doctor in all of Singapore. So we're talking a very, very, but it took them 8 months to figure out what this was because I bounced from every doctor you could find until one said, I think you need to see the desmoid guy. And there's one guy, right? So, but, you know, there are some of these topics of rare disease where AI would be most beneficial. I'm not sure that's attracting very much funding, right? The beauty of breast cancer is it does attract a lot of funding. So those would be some of the barriers I can think of. Others?
What Resham said earlier, right? I mean, in response to my comment about AI being so powerful, is that same thing. Adoption is very, very hard. And if you especially look at healthcare delivery in LMICs, most of it is funded by the government, right? Private sectors will obviously adopt AI, they will start using this, but that is a very small portion of the population, wealthy population, right? Not the whole country. And getting governments to adopt AI is a challenge, and it's exactly the question that you asked also right now. It is going to be a challenge, and that is a challenge that we have to solve, and that is where the community, I mean, has to come together to help the government adopt these kinds of technologies. Yeah. But I think that's the biggest barrier right now.
I think another barrier which is probably building up, I would say, is there's also so much of AI. The AI is supposed to simplify, and if there is so much of AI and it becomes a burden to navigate, the whole idea, like you said, is to empower clinicians to do what they want to do, spend time with the patients. But if the AI complexity increases, there are too many applications, too many to navigate, then it's again a challenge. But I guess we'll find a solution.
If you ask me, there are three main challenges. One is, do we have the right compute capacity? Now, India is part of that Tier 2 embargo, and US has said that we cannot import more than a specified number of GPUs in a country going forward. So is that number going to be sufficient for the compute capacity that 1.4 billion people want or don't want? So that's the infrastructure, the capacity constraint. The second is the lack of data sets. I mean, India is such a diverse country, so many regions, so many ethnicities, so many traditional customs, things like that. We simply don't have the data set which can capture all of that. I mean, leave alone even the human genome, the genome project or the genome project, we have not been able to map the entire genome of the country as a whole, and leave alone the land records and those kind of things. We simply don't have that. And the third or the biggest barrier is how do we make it affordable actually? I mean, imagine if an AI app wants you a mobile phone with a Qualcomm Snapdragon 8th generation, 3 and 16 GB RAM and all that. It's simply not affordable. It's simply not manageable. And India, all of a sudden, we are still at a country where the per capita GDP is $3,000. So I think these are three biggest challenges. The good thing is that the way the country has evolved, we have managed to overcome quite few of them. The India mission, they plan to have these GPUs and then make the compute capacity available to all of them in a much more democratizable manner. The DG and all that, they have been all success stories. So I think learning from that and recognizing the challenges, we should be overcome the barriers like KK mentioned.
Maybe just one thing, I think I do want to add that as an organization, what we have an internal term, we didn't use it today, invisible AI. What our CEO uses, he says whatever we do, it should be invisible to the user. It shouldn't become like what Hari said, a headache, right? And it is not, for us, we don't see it as a replacement, we see pretty much as a co-pilot and augment, given the shortage that there is, right?
Maybe we have one answer for one question. So one of the sectors, the government sector. I come from healthcare industry, technology park. We are a HISE in my company for the last 3 decades. I see a lot of I think, adoption challenges in private sector also. So what's their so slow adoption in private sector? The big players also not using AI. You being one of the things, and also just want to know the costs involved into that. If you got one X-ray being done with AI, the difference between the actual.
So I think several things, right? I mean, I would say AI today is like internet in the 1995, 96 time frame, right? I mean, it has changed the world. And if you look at internet coming in, I mean, where commerce has done everything, right? Everything has changed. And I think AI is, we talk of AI as one thing, right? It's not, I mean, it's going to be like the internet boom. I mean, basically we'll see a lot of things change over time because of AI. And it's not replacing doctors. I mean, the idea is that it will provide support to everybody who needs that support, right? It could be like I said, a healthcare worker who wants support to help them make a decision, and AI is going to help them make that decision. Today, as a CEO of Cure, I mean, I make so many decisions. I take the support of ChatGPT. I ask it everything because it's really good, right? And so it is a great decision support tool. It's not, again, I just want to clarify that it's not. I mean, I'm not saying that we should replace doctors. I mean that doctors don't have a role.
Or replace CEOs.
You could replace CEOs for sure.
The cost ratio on that is interesting.
We are learning how to deploy scale. It's just so much happening. The technology is changing.
But to answer your question, I think the reality is all of this has come about in the last 3-4 years. Especially the LLMs have changed. I mean, what we were building was more imaging AI. We continue to do that. But language AI, text, all of that is changing in the last 2-3 years. It will take some time for that to be adopted, and that is what will happen in the next 5 years. But the technology is there, and we'll see when private sector start adopting it. It's a matter of time. I really feel that if AI is so good at decision making, I would say at Cure we have about 280 people. I don't think there is one person who would be operating without using AI today. All of our coders, the coding. So the first place that AI has affected is coding, where a lot of code can be written by AI, and almost all of our, not almost every coder uses AI now, and they have become 10x better coders because of AI, right? So I think that is what we have to think about. It's going to make all of us excellent at what we do and much better at what we do.
There's a lot of same for us. We're using coding services, but yeah, we are learning. It's very new. The lady there, please. Yes.
I'm so glad you covered women's health in great detail. I work in an area of women's health which is like not spoken about enough, and I'm so glad Vishal spoke about breast cancer. It's like sexual and reproductive health, right? And all of you majorly represent like industry or implementation partners. There's nobody from the government side here. But what happens if there is sort of a crackdown on something like SRH? If there is a lack of consensus from top down, I don't want to mention US, but I'm going to. So then how do other stakeholders innovate or find solutions if there is a shift to right-wing and conservatism, and if some areas of health are receiving less access and funding, and just like leaders are not giving it as much importance, then how do you like keep working in that area?
I mean, I'll make two comments there. I don't know that I can directly answer your question, just to be honest, but two things. One, there is a lot of truth to digital being a bit of an equalizer, right? There is no doubt that as we offer more services digitally, if you look at mental health, there's been a huge impact on being able to offer digital solutions, to use AI to have, phone support and things like that. I mean, the beauty of the digital world is you can deal with some of these more sensitive topics. People can get access to service, they can get access to information. So it has been something of an equalizer. And we saw that actually in COVID. In COVID, patients began testing themselves, and patients began opting into care for the first time really ever. And I do believe there's continued opportunity on the digital side. Now, this topic about governments and top down, and you kind of were going in that direction. We are at a very challenging period, right? And the human mind and the human condition and the ability to partner and kind of really take empathy and take leadership still wins, right? I mean, we as a company stand very much by our values, which is healthcare, breakthroughs in healthcare for everyone, everywhere, and we stand by that value. Yes, some of the situations going on are extremely difficult, but humans will win, right? A government is an entity, and I do believe that there's a lot of opportunity for people to come together and to be very serious and consequent about the decisions they personally make in their communities.
Thank you, Bhushan. Okay, will you hear?
Hi. So we have vital strategies to actually drive work and convince policymakers, decision makers to invest money in data structure, CRBS systems.
You try to convince me to buy your consulting energy.
Well, see, data is the currency of AI. And whatever data we have is unstructured, it's very dirty. We have more patients but no data, right? Okay. So I was wondering, because you need investments in improving your birth and death data capture systems, right? So we have government, we have WEF, we have UNGAs and CQS, but what does the industry think about funneling funding towards these kinds of very basic, very important vital registry systems?
Maybe take this offline because we do have a lot of partnerships here as well on the data front as well.
She's really talking about that fundamental, like baseline data systems. I mean, we wouldn't have much, as a healthcare company, we probably wouldn't be the one looking at that. But of course, you do have like the Microsofts and the Amazons of the world. Believe me, they'd be very happy for your end-to-end data. What they'll do with it is a whole nother, there's plenty of people that want that data, right, and are willing to support those programs and data. They're all going to try to make some kind of business out of it, right? And there's nothing wrong with sustainable business. Ethical, compliant, sustainable business is how the world grows and improves, right?
Maybe the last one, I'm just looking at the time. I don't know. Yeah, okay. The one standing at the back.
Thank you.
We are about time.
Hi, I'm Anushka. I have a question for everyone actually. So I wanted to ask about when we were talking about adoption. So adoption in the system is one thing, adoption within the community, I wanted to understand that because the healthcare system mostly works on, and I worked on in the implementation sector so, it works on fear and trust. So one, you trust the doctor and then you go, or you fear that you will die and then you go. So when you're talking about women's health and we were talking about women's, like we were talking about the gap in women's healthcare. So how are we planning to navigate those, and specifically people who are working in digital and speaking about telemedicines and AI. So if anyone can answer that, so that would be helpful. Thanks.
So you're asking how do we navigate the gap in women's health?
So my question is how do we navigate the gap in adoption?
How do you build trust is what like build trust in the technology or?
How will you build the trust in technology? Like how many of us will trust AI's answers? I understood your point. I understood where it was coming from. But even in telemedicine, I've seen that people don't adopt to telemedicine. So my question is that how do we navigate those challenges? Like if anyone has any thoughts on that.
See, what I feel is that the role of technology is going to be so widespread and it's going to be such an integral part of the life that adoption may not be a barrier per se. In many cases, it's going to be as intuitive as, like, for example, speaking on a white board, things like that. So it's going to be coming very naturally. If you look at the new generation, especially if I talk about my two daughters, they are much more comfortable navigating them by phone and tablet than I am actually right now. So I think the way technology is evolving, and especially with the new generation coming in, it's going to find an option. What we definitely want is, like, for example, right building blocks for it to happen. Things like, for example, technology needs to be taught in probably all the curriculums, whether at the graduate level, postgraduate level, those kind of things need to happen. Technology to be made equitable, that part to happen, and government has a role to play. Maybe easy financing option is one thing that we're talking about in service sectors, but those are certain building blocks that ought to be in place. But I think cumulatively this will happen. It will depend on the time, but this will happen.
Yeah. So I would want to re-question you. Let's leave aside AI and digital. What would make you trust me?
It's also a connection.
Right? And?
It's about the connect that I will form.
Okay. And?
So if I just for example, like in COVID, when we all tried telemedicine, when we all went to virtual doctors, I wasn't able to place that. That's what I'm saying.
So you, hypothetically, you could maybe trust me if I tell you, if I do what I tell you I would do.
Yeah, that is one thing. Right.
So it's exactly that, isn't it? It's what if people do exactly what they say they would do in a way to improve certain health outcomes at the grassroots levels, because that usually doesn't happen.
What's your experience? I'm very interested.
I was going to ask you, do you trust Google Maps? No, it's a very, I think it's an interesting analogy because I think AI is going to be like that, right? The reality is, I moved to Mumbai in 2011, I was in the US, and I have been using Google Maps since the time I moved to Mumbai. So I never learned any of the roads in Mumbai. Outside the small region that I live in, where I know the roads, I don't know anything. Outside of that, if you ask me to drive without Google Maps, I probably will not be able to, right? But you also see, I don't know, 2 days back, somebody drove a bridge in South Korea, I think, or South Korea, I think, which was an unfinished bridge, and they sort of crashed. They survived, but that is also one of the things that happens because you trust the technology too much, right? So you have to be very careful. I think again, you trust the technology because it's accurate 99.99% of the time, but it's probably not going to be accurate that 1 out of 10,000 times, and you have to be careful about that. And I think that is the real problem with adopting AI right now. To barrier question also, that we have to be very careful about how we adopt, because a healthcare worker who makes decisions purely based on AI and not being aware of what they should do could actually make a mistake for a patient. And they could give the wrong drug or maybe prescribe something where there is a comorbidity which can be impacted. So again, that's something which you have to be careful about.
Thank you. I think that was the bell for us to close. I'm happy to see that we had so many questions. Thank you so much. It was a very good conversation. Thanks to all the panelists. Thanks to the audience. We had a great conversation, a lot of optimism, skepticism, partnerships. So thank you for your time.
In front of the signs or?
Next time, change the
Hi Prashant, Abhishek this side. I am one of the founders for Lung Care Foundation. You probably met my father, Dr. Arvind Kumar, at Medanta. Yes, yes, actually. Yes, he had told me long back you were exploring pilots and stuff, and then your team had, I was talking to your team also. We were working on something through the foundation, but then that time we did not have the capacity to take on that. But we'd love to. The foundation mostly works on air pollution and health and also on asthma management, and then in between we had worked with Vidur on low-dose CT scans for lung cancer and stuff like that. Yes, but mostly on that. So, but would love to interact. Are you here for some time? All right. Are you in Delhi for some time? Or are you leaving tonight? Otherwise, would have loved to do a meeting with Dad, and like he's also keen to explore things for his lung cancer patients and screening. So, and then even Rajiv Sikka, I work with him, he was also talking. So, Vidur was also saying that meet Prashant. When I came, he's not here, but I was working with this company called Bright Insight in US and recently moved back, and then Vidur is the mentor. So he said you should meet Prashant first. I'm also building in lung health beyond the foundation. So, let's catch up. If you're in Mumbai, let me know. Otherwise, just send me an email. Yeah. We can do a virtual call. That time maybe next time. But definitely love to meet. Yeah, he was also keen because he couldn't explore those things, but he's keen to explore like potential collaborations for like lung cancer and anything of the NHS. Okay. So, lovely meeting you, Prashant.
बोलते हैं मोटर वाले
नहीं एक बार मैं दूसरे एमआर में कंफर्म कर देता हूँ अगर वैकेंट होगी मैं तो उसको करवा देता
ठीक ठीक देख लियो था ठीक 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 check, check.
Good evening, everyone. Good evening, everyone. Thank you so much for hanging on. This is the fag end of the day. We are about 10 minutes late, so we'll try to keep time here. My name is Tavvitesh Sethi. I'm delighted to welcome you all at this point of time for this very interesting panel that we are going to have, which is on building trust and safety in AI for primary healthcare. Without spending a lot of time, I would just like to acknowledge the World Health Summit as well as PATH team for collaborating on this event, and also the support that we received from the IIIT Delhi Incubation Center and the Center of Excellence in Healthcare. We have a responsibility here, since so many of us have joined here in the last session of the day. I think this is a responsibility for us to really brainstorm how can we safely transition AI into primary healthcare settings. But I think our task is made easier. My task is difficult because we have so many stellar panelists. It's a round table, but you don't see a table, but still it's going to be a brainstorming discussion. But I think our task is made easier by the expertise and the depth of experience each one of our speakers brings to the table. So without any further ado, I would like to invite all the panelists, speakers, esteemed experts to please join us on the stage, and we will start the roundtable discussion. So in no particular order, Dr. Karthika Dapa, Dr. Swati Mahajan, Dr. Mona Dugal, Dr. Shishendu Mukherjee, please, Gaurav Agarwal, Dr. Dhwani, Dr. Nico, Ms. Anaita Singh, you're here, thank you. Madhav Joshi, please join us on the stage. Dr. Kritika Rangarajan, and Professor Oleana Manish, and Dr. Varsha. So Dr. Dhwani is here. Oh, sorry, I think, okay, so no worries, yeah, no, perfect, okay. All right, so my bad. So thank you so much. Again, I would like to just reiterate that the purpose of this, the goal of this roundtable discussion is to actually co-build a strategy how we can build towards safe transition of AI in primary healthcare. AI in healthcare is not new. It has been reading radiology images, but primary healthcare offers a whole different set of challenges. It's deeply human in the first place. It's deeply hyper-local, right? The challenges around trust, resilience, capacity building is not something that are new to us. So that's where we would try to mold and basically come up with a white paper where all the participants are actually experts in their areas, and we would like to have this very lively discussion. The structure of the panel is, I would request every member to very briefly, just in 2 minutes, because as I said, I have a tough job. In 2 minutes, very briefly introduce who you are and your organization, and then we'll move to the specific questions that we would like to discuss. So maybe I'll just start with Dr. Dhwani.
First of all, thank you very much for involving me in this panel. I'm Dr. Dhwani Almola. I'm currently heading Public Health and Nutritional Portfolio at American India Foundation. Predominantly within the public health ecospace, we are working to reduce maternal mortality and under 5 mortality rate. Simultaneously, we are exploring a couple of programs to support adolescent and perinatal mental health as well. And very recently, as everyone wants to do something in AI, so very recently also we have started exploring how we can, basically augment and supplement the existing programs, and how we can, support the frontline workers, and how we can make their life easy by leveraging digital health and AI technologies. So I'm really looking forward to the discussion.
So thank you, Dr. Pradesh, for getting this together, and thanks for having me. I'm Kritika Rangarajan. I'm an associate professor of radiology in AIIMS Delhi, and I also lead the Center of Excellence for AI in Health in AIIMS, where essentially, a part of what we want to do, or the essential vision of what we want to do, is integrate AI into the public health system of India, specifically directed towards the healthcare national programs. So we're saying that we work with the existing system and try and augment its capacity with AI.
Hi, thanks for having all of us, Tav. I think it's going to be quite a task. But it's late evening, so hope we can keep you up and kicking. My name is Anaita Singh. I'm a part of the Gates Foundation's Digital and AI team. The work that we do on the AI and health space specifically, I think there are two parts to it. One is supporting the ecosystem at large and looking at the foundational building blocks around that as we think about it. Our focus always is looking at serving the last mile and making healthcare services more available. And from that perspective, whether it's innovations on upstream efforts around R&D or its downstream efforts around digital solutions or chatbots, you name it. The idea is how do we think about some of that more intentionally with different ecosystem players into the mix. The second part of all of this I think I'd want to focus on is where market failures happen, where money or catalytic funds are not put. For example, if you look at Bhushan or you look at any of these large language models where there are a lot of small, very few data sets available when it comes to languages, for colloquial languages, to actually make it accessible. How do we think about some of these problem statements from the perspective of what the country needs? That's the role we play.
Thank you, Tav, for having us. My name is Gaurav. I co-founded 1MG. What do? We use AI across the board in, what 1MG does, I hope most folks know, but we basically do healthcare at home in terms of medicines, diagnostics. We run one of the largest pharmacy companies in the country today and one of the largest diagnostics companies also. Our core focus in AI, especially when it comes to the health side of things, is in three specific areas. One is how do we build AI algorithms and tools to basically digitize the healthcare data that's being generated. Most of it is on paper, as we know in our country. So we've built over the years many state-of-the-art algorithms to actually digitize a lot of that data and bring it into the digital realm where it can be mined, analyzed, etc. So that's one. The second is once we digitize all this data, how do we actually build a life cycle view of a consumer? And the third is how do we give them a sense of where their journey is taking them and then suggest interventions, etc. as well. And the third area, which I'm personally very excited about, but we haven't made much progress, is can we start to create India-centric gold standard data sets, which basically put longitudinal health data in one place and provide access to researchers, etc., to start to come up with what they see from this data. So those are three areas that we work on.
Thank you very much for the organization. It's great to see so much enthusiasm at the end of a Friday. So I'll try not to disappoint you with my contributions. Thank you very much for having me in this amazing panel. My name is Nico Schietskatte. I'm the Counselor for Health, Welfare and Sport at the Embassy of the Netherlands here in Delhi. So my responsibility is to stimulate cooperation in the health domain between India and the Netherlands, and which is increasing. This topic of this evening is very close to my heart because it's about artificial intelligence in primary healthcare. In the Netherlands, we have a very developed system of general practitioners, GPs. It's really the basis of our entire healthcare system. And by coincidence, or maybe not, this week a major article was published in the British Journal of General Practice from researchers in Amsterdam, in our University Medical Center, our University of Amsterdam, about prediction of lung cancer. And I think this is something that we all relate very much to, I am sure. And we have seen that in fact the patient journey in relation to cancer starts in the GP in more than 80% of the cases. So it is therefore very, and 75% of them are already in a very advanced stage 3 or stage 4, right? Which means that more than 80% leads to mortality within 1 year. Now, what our medical specialists in Amsterdam have shown that by using the data from GPs, we can anticipate through AI models the diagnostics of lung cancer by 5 months. Can you imagine 5 months? How much lives can be saved by having an earlier diagnostics of 5 months in the case of lung cancer? The Netherlands, I'll close by this. The Netherlands is an aging society, so we have an increasing demand of care, therefore, but we have a decreasing availability of staff in our healthcare system, and we have an increasing cost in the healthcare system. And in fact, in the Netherlands, and I don't know how it is in India, but in the Netherlands, the healthcare professionals spend about 40% of their time on administrative tasks. And we see a major opportunity through artificial intelligence, and my Minister of Health has set the ambition of, by 2030, decrease this 40% by half, so 50% less of administrative work between now and 2030. And for this, we have seen quite some amazing developments that are taking place in India, and I'd be very happy to engage with you and to see how we can exchange best practices, co-develop solutions together, because this is a topic in which I think we have only shared interests for our patients in our respective countries. Thank you very much.
Thank you very much. Good evening, everyone. I'm Swati. I work with PATH and lead the Technology Innovations and Health Systems work for South Asia at PATH. And thank you for the opportunity and having me in this panel. I look forward to the insights from all the fellow panelists. So at PATH, we believe that AI has huge potential to transform health systems tremendously, be it in terms of enabling the health workforce on clinical decision making, thereby improving the patient health outcomes, or be it in terms of enhancing the health systems through supply chain optimization, enhancing disease surveillance, or diagnostic capacities. We've done some amazing work in AI, and quickly counting some examples. Last month, PATH launched its first landmark phase 3 randomized control trial in Nairobi on evaluating whether an LLM-based tool can enhance patient outcomes in clinical care settings in LMICs. So the idea is to look at that whether an AI-based tool can help reduce can help improve patient outcomes and the quality of care by reducing cases of misdiagnosis or wrong diagnosis, by looking at adherence to guideline-based treatment protocols, and also cutting down the unnecessary repeat visits. We also support a lot of deployment of AI-based point-of-care devices in Satara district of Maharashtra, wherein we are creating a district saturation model on primary health care. So a lot of these point-of-care devices integrate AI either to simplify the workflows or to simplify the interpretation of results and help in population-level screening of NCDs. We are also using AI in forecasting for supply chains, thereby enhancing the optimization and the need of drugs in primary healthcare settings. And it is being done jointly with Tata 1mg, and Gaurav is sitting here. And the tool that we've built is now being integrated on DVDMS, which is the Government of India's platform, in partnership with IIITD. Last year, IIITD, PATH, ICMR, and Tata 1mg, we together won the prestigious Trinity Challenge, and we are building AMR Sense, which is a socio-technological innovation that helps in identifying antibiotic resistance hotspots in the community and generates a visual tool that will rate the geographies which have more resistance and identifies the hotspots for better interventions. And last but not the least, we are also using, in partnership with partners like Art Park and again IIITD, we are building climate-informed AI-based early warning systems for vector-borne diseases and dengue, and are trying to implement these in states of UP and Odisha. So these are some examples. We are learning along the way, and we hope to share lessons as we have. Thank you.
Thank you, Daptesh, and for the invite today and Path. I am Shirchandu Mukherjee. I head the Vadhvani Innovation Network at the Vadhvani Foundation, where this is a new initiative within the foundation which has been created around 6 months back. What we are doing here is creating innovation hubs across the country, and one of are around 6 to 7 thematic areas, but one of the main focus thematic areas is AI and quantum. Now within AI, healthcare is one of the important elements. What we are planning to do is creating innovation hubs in AI in the academic settings, so that academic innovations gets connected to clinical researchers and gets validated in an ecosystem, and then a team gets created, and this team either gets converted into a startup, or it can be licensed out and validated into the ecosystem and get moved out into the field. So looking at innovations in the AI field for health and quantum, literally that can move from the bench to the bedside. We'll fund along the way, but we'll not only fund and strictly fund and follow, provide mentorship and see and handhold them so that the innovation literally gets validated in the ecosystem, in the primary healthcare setting if it is needed, and moves into the field where it can be integrated. We'll talk about it as we progress. Thank you.
Good evening. Thank you, Dr. Sethi, for having me here. My name is Dr. Karthik. I am the Regional Advisor for Digital Health and AI in the Southeast Asia Regional Office of the World Health Organization. WHO essentially leads the world in terms of laying the basic foundational work on AI. We have the Global Initiative on AI for Health, which the WHO leads along with ITU and WIPO. This is essentially a international program where all the member states of WHO essentially participate. And what we essentially do in that is lay down guidance documents, whether it is in terms of ethics and governance of large language models or AI in general. There are a variety of guidance documents which are of course open source tools and open source guidance documents which essentially are to help governments lead in terms of an ethical and a standard-based deployment of AI machine learning tools. The second thing that we also do is we have open source courses for both general population as well as for healthcare workers on what does it take to essentially deploy AI both at scale as well as in a responsible and an ethical way. I'll leave it for now, and over to Dr. Mona.
Thank you, Dr. Karthik, and thanks Dr. Dish and Path for inviting. I just joined as the new director for the new National Institute of Digital Health Research. The name is going to be finalized this month, probably early next month, or NEDR as we say it. It's a new or the repurposed institute. It was earlier as the Statistical Institute that has now expanded the vision to digital health research. I think the mandate has just got expanded given there has been a lot of ask, I think, at the top level, because that's where the health research needs to come in to support the evidence to scale. So that is one of the main areas that we will be looking up, and of course, as Karthik has mentioned, they do it at the WHO level. Similar is the concept that we take those guidelines and how we implement it at the field level. So these are the two main areas that we will be looking at as we talk.
Good evening. My name is Madhav Joshi. I lead India Health Fund, which is a catalytic fund that Tata Trust set up about 6 years ago. India Health Fund was set up to address an area of market failure, which was the absence of the capital and financing which was needed to support the development of innovation addressing public health challenges. So our priority is really climate-sensitive infectious diseases, tuberculosis and lung health, women's health now, as well as antimicrobial resistance, which are all conditions which are widespread in community. The science exists, but the science has never been enabled to take tools and technology to the people who need it the most, which is very different from what's been happening in non-communicable diseases. So in the words of the late Mr. Tata, India Health Fund is really intended to develop India for the world. We've taken 3 big bets. One is on screening and diagnostic solutions with the intention of enabling earlier detection and access to treatment. The second is using science and technology to improve the supply chain, particularly for samples, consumables, drugs and diagnostics. All of this is underpinned by digital technologies. We've made big investments in AI-based solutions which are addressing these areas. The work we do begins with identifying need gaps, identifying tools and technologies, particularly AI-based solutions which can help address these need gaps. We finance development, validation, and then create collaborative partnerships for the adoption and scale of these, not just in India but around the world. And collaboration is very central to what we do. Many of the stakeholders in this room have been very active partners and collaborators, and I certainly look forward to seeing how we can work together. Thank you.
Thank you, all the experts, for absolutely. Oh, yes, sorry.
Yeah, that time I was sitting there. So I'm Dr. Varsha Tanu, and I'm associate professor at IIHMR University, Jaipur. But I'm basically from development sector background, and before that, quickly I've just try and cover that with the Directorate of Health. I was working with government as a community process state lead, and especially with the 47,000 ashas in the state, and then we basically payment to so many workers were actually an issue, so we made a digital solution, AshaSoft, which was later selected as one of the best practices, and it is mostly sorted the solutions, I mean basic problems. And then with the Wish Foundation, sir is there, so he'll be probably Wish Foundation worked with the PPP mode and on innovative scale Rajasthan model to bring technology to field, and there had experience of AI and technology with the community and at a primary care model, and had the experience of installing medical ATM also, and closely seen the entire process working and not working both. So with all that, field experiences, I have specifically seen with community how it intermingles and adjusts with the community. So those experiences I gained during my all these experiences. Currently I'm engaged with the implementation research in tribal area also for food system transformation, and closely looking after community health. Thank you.
Thank you, Dr. Tanu, for joining us in the roundtable, and I think so much depth of experience that you have, and I will be looking forward to more in-depth discussions along this. Thank you so much again. Thank you all the experts for sticking to time. We are exactly at 5:30. It's perfect. So I think we would, in the same spirit, we would address the elephant in the room, which is we've all been talking about innovations and what needs to be done. We can start asking what should be done in the space of primary healthcare, which, as I started, is somewhat a different ball game, a different animal but I think the experience that you have is invaluable. And in that, I would like to first invite Dr. Karthik Adapa. He has introduced himself, but has also contributed not only in research but implementation, has led a lot of initiatives, policy frameworks. So my question to you, Dr. Adapa, is that you have been also a core member of many of these frameworks that are designed around how do we transition safely, effectively. The CHAI framework from WHO is one example. And there are many pillars. What, in your opinion, is the most important pillar if we have to start with, or do you think we need to start with all? How can we prioritize? How can we start thinking about a checklist framework that can help us with this transition?
Thank you. That's a great question. Firstly, the Coalition for Health AI is certainly not involved with connected with WHO, so I want to just clarify that. This has been an initiative in the United States about 40 years back, where a variety of researchers from all fields, practitioners came together and created themselves as a community and so Chai, in a way, has now last year come out with its first ever guidelines on responsible AI framework for health. This is an open source document which you can essentially check in, and this has been one of the first attempts to have for a federal government in the US in last year, where we talked about how should any government or anyone wants to deploy AI responsibly and at scale do that. So we kind of used a principled approach. In that, what I wanted to kind of talk about is the piece on governance, because essentially the governance piece is a key component. I know it's not the most exciting piece, but there's a lot of lessons that we can learn from how we've implemented digital health over the past 2 decades, and how are we actually implementing AI now. What we see is a huge fragmentation. We've seen a huge fragmentation in terms of AI, in terms of digital health, and we are already seeing signs of fragmentation in the way we are implementing AI, and that's something which we want to avoid. What we've seen in digital health is this vertical disease siloed methods, right? Again, we're seeing the same thing in AI to start with, where we're seeing that we'll do disease-wise AI machine learning applications. So when we do something for tuberculosis, we don't care whether it works in the larger public health ecosystem or not. So what we are seeing is, for donors and for public health practitioners, the fundamental steps are, can we get the governance piece right? Because essentially, in terms of getting the standards for digital health, we took about 2 decades. Now, how long are we going to get right in terms of standards implementation and interoperability standards for AI applications as well? Because none of the AI applications are going to sit as isolated systems in the larger public health space. And if you really want to scale, you have to ensure that they sit within the entire ecosystem, and they really have to be seamless, right? So for me, the most important pillar that, as we navigate through this AI in primary health, is going to be the governance piece. So I think in that, again, what we're now realizing is, do countries have a foundational document on how do you govern AI for health in general, and then primary health in specific, right? And now you can see, essentially, in Southeast Asia, we really don't have one nation, not even one country, which has come out with this foundational document on how should AI be for primary health or health in specific. So I think that's primarily the first attempt, because what we've done in digital health is come up with a global strategy on health, and then countries have started developing this foundational document. So for example, in India, what you see today as ABDM, the core of the document is the digital health blueprint. Now, do we have a core building block document which talks about the governance of AI in India? We certainly don't have that now. So what we have is an India AI vision, which is again as a programmatic approach, but we don't really, and that's been the mistake that we've done in digital health as well. We've done projects, we've done products, we've really not done them as a large scale implementation. And so I think there's a lot of lessons that we can learn from digital health implementation, and that is something which we want to replicate in AI. The other piece is around evidence, right? So a lot of digital health applications got implemented without evidence, and we suffered from what is pilotitis, not at just the national level, but also at continental level, right? One specific study in Africa shows that donors, developers, national governments have essentially invested in about thousands of applications, and only a fraction of them have truly scaled. And that is something that we want to avoid in the AI space as well. So I'll leave it for here for now. Thank you.
Thank you, Dr. Dappa. I recall your slide where you showed that governance is the one before all the zeros that makes all the difference. So absolutely, I think we look forward to your inputs on how can we create such shared contributions towards a framework like this, a document, and perhaps some way forward on this as well. Thank you so much for your valuable input. Next, I think somebody who's really connected to the implementation, Dr. Swati Mahajan. Your organization has been actually, as you said, piloting and scaling solutions, AI solutions, many of which are actually touching primary care. And one thing we keep notice, I come from an engineering institution, is, and I evaluate sometimes many of these solutions, essentially talking about ROC curves and accuracy, which is good. I was just asking ChatGPT to give me a joke. Before I started the session, it said an AI model walks into primary health clinic into ASHA workers. So have you just brought your rock curve, or have you brought your trust as well? So, so I think we need both. We need rock curves as well. But how do you really start building trust in your work? How do you evaluate these tools that you are building? Is it just the frameworks? Do you have the framework? I mean, do we, not you as an organization, but do we have the frameworks where we start understanding and assessing the safety and trust of these models in primary healthcare, to be very specific? We know responsible AI frameworks, for example, CHAI frameworks exist. So I'll just take a pause here and would be very keen to listen to your thoughts.
Thank you so much for the question. I think as we navigate the integration of AI in primary healthcare at PATH, we do realize that we've come to learn that it's not purely a technical challenge. It's a systems challenge as well. Technology can only help when there are systems or processes in place. So that's the first thing. While metrics like accuracy are very important, but accuracy is just one piece of the puzzle. To determine potential for scale and systems readiness, there are many other dimensions to look at. So first, most important dimension that we assess an AI technology on would be equity and inclusion. The AI tools must be assessed for bias and representativeness, because the tools that get trained on narrow data sets, they often tend to marginalize the very populations we are trying to reach. Those who are language diverse, those who are underserved, or multilingual. So it's very important to see whether does AI work equally well for all the populations? Second thing, of course, is acceptability and the ease of use for the end user. Most of the tools that we are developing are either for the frontline workers, for healthcare officials, or administrators. And most of them, as we know, they are not very tech savvy. They have limited digital literacy. So what is the ease of use? How easily can they interpret the outputs that AI produces, and how intuitive and actionable those outputs are? I think that's very important for us to look at. The third dimension that we look at is the fitment to the programs and contextual usability. Whether these tools align with the local context, are they the right programmatic fit? Are we just, is it like round glasses and square pegs? We are trying to fit solutions, or is it actually the solution, is there really a problem that these tools can address? That's very important. And also the tools are meant for low setting, remote settings, low resource settings. So looking at whether they can work on low bandwidth, they can work on low-end devices, are they addressing the local disease burden or local challenges? I think the fourth thing that we look at is workflow integration, whether they fit into the existing workflows rather than disrupting them, because we already know health systems and the workers are always overburdened. So rather than increasing their workflow, their burden, they should be seamlessly fitting into their existing workflows. I think, of course, ethics and ethical, data protection, alignment with data protection frameworks and ethical considerations are also some things. Whether these tools work, they ensure informed consent, whether they are avoiding any risks of surveillance or misuse of data is also something. And last but not the least, because we largely work with public health systems, sustainability and cost effectiveness are very, very important. Because even the best and smartest of tools cannot be scaled if they cannot be procured, maintained, or if they cannot be affordably scaled through the public health system in our country. There are some gaps, and I have touched upon a few, but maybe a couple of other gaps. First is the lack of last mile readiness. Most of the times we've seen some of these tools are designed for ideal environments. So when you start implementing them in outreach settings, in primary healthcare settings, they often do not function in these real-time settings as they were supposed to. So maybe figuring out things like offline usage, language diversity, or integration with the local context is something that should be figured in at the design stage itself. Second, I think Dr. Redappa already touched on it, there are no regulatory pathways. So who is accountable if something goes wrong? Third, of course, is also about asymmetry in digital capacities. All the end users do not have equal capacities, so there is a need for constant hand-holding, capacity building, which often we ignore. And last but not the least, sustainable financing. Most of the pilots are donor-funded or grant-funded. So, I mean, for long-term sustainability, either there have to be long-term business models, or they have to integrate into the public health financing systems. So these are some things that we take care of.
Thank you, Dr. Swati. I think these are really profound points. I would just like to ask one follow-up in 10 seconds. would you prioritize one or two? Which in the list of priority, which in your experience, where do most of these initiatives fall through, or would you like to address?
I think when we've done a lot of tools, I feel most importantly, these tools should enable the health workforce. I think acceptability by the end user is very, very important, and that's wherein I think the human-centered design element would come in. To me, that's most important in my experience.
Thank you so much, Dr. Swati. I'll move on to Dr. Mona Dugal. As you mentioned, Dr. Mona, I think with this new initiative, you are at the forefront of institutionalizing the digital health and data science in medical research. I think that's a huge, I would say, effort, responsibility, but I think kudos to ICMR for actually starting this much needed initiative. What is your viewpoint on integrating a robust research ecosystem for primary care? There's a lot of data sets that are existing. Some of them may be fragmented. Some of them are programmatic. So how's your initiative? How do you foresee the changes that will be brought in this initiative, which will enable some of that integration?
Thanks, Pratish. I think already a lot of work is already going on. I think the way ICMR has started to function, I think if we are looking at new calls, we have something called the implementation research. So a lot of those EHRP calls are going out, which are actually in collaboration with the ministry. So once those things, the system starts to move where researchers, implementators, and the policymakers start to talk to each other, that is the first step. And I've seen that change because I'm co-PI on a couple of those grants. It takes time, but at least that ecosystem has started to move. The needle is starting to move. People are starting to talk. It's a huge ask. Still, I think the thing that you said, the data sets and the data and how the evidence is built, that is one area which, again, needs a lot to think about. Because the entire policy is being built on those evidence that is based on the data. So that again, we really need to think through how we are going to be collecting the data, how we are going to putting them in, and how the implementation science research needs to look at it. And that point is generally left out when we are talking about it, but we really need to think through because data sciences, as we say, we all know India is like, we have a gold mine of data, but is it usable? So what we are talking about is the usability of the data, how we make the pipelines, and how we standardize the data. I just came off the session with where it was about NABH standards, like where the EMR systems need to be built in. I think parallelly everything is starting to move in those directions. It's just now kind of like coalescing and converging, where we start talking about the ethics, the consent, the data sciences, how we collect the data, where the patient has a hold on their own data, but at the same time, as a researcher, you have the quality of the data. As a developer, you have access to the correct data, probably de-identified, the privacy of the patient is there. So the consent to share data is there. So all those things I think have to start moving. While Foundation just said they are starting the innovation centers. I think that's a great initiative. It probably builds into where India AI mission is coming, where they are looking at the scalable models, where they will be looking at centers of where you can innovate, where you can scale. I think these things, when you start talking on these panels and we come to those panels, it's where you start coalescing. So that is my 2 cents. But the 2 areas which I feel at the national level, at the forefront, you really need is, of course, the gold standard data sets that we are all talking about. Second is again the centers where you can do the handholding and walk through the process and make sure the AI algorithms have the correct implementation model, right from the ground level to the scalability, and the states and the capacity is built across. So right now what is happening, health being a state subject, many of the states are having their own rules and regulations which probably they are doing at their level, but there has to be some guidelines at the national level, which has to come as most of the people look at ICMR when I talk about it for those guidelines. I think that is where we come in and where the WHO comes in. those are the standard guidelines which need to go out to the state, which we feel we can be the partners at. Thank you.
Thank you, Dr. Mona. I think if time permits, we'll come back and really would look forward to listening to what, for example, the work that you did in bridging that gap between research, policymakers, and implementation, and we need much more of that kind of work. And of course, evidence building and the quality of data is something which is, again, for primary care, gold standard. Shall we build gold standard? Is silver standard good enough? I think those are great questions for, if time permits, to come back to. Thank you so much for your inputs. I would request Dr. Shishendu Mukherjee, who has, I mean, you have so much depth of experience working with organizations like the Welcome DBT and then BIRAC and now Wadhwani Foundation. How do you think public-private partnerships need to be leveraged? Specifically, I try to keep bringing this question back to primary care because it's not a place where a lot of money can be made initially right away. There may be a long journey for the developers to so how does Wadhwani Foundation see this change that needs to be brought? Thank you.
Thank you, Taptish. I think I will pick up from where Dr. Duggal also said, and go a step backwards. Innovation plays a critical role in bringing out, as Swati also mentioned, affordable, accessible solutions for which can be implemented and then validated at scale, regulated, and brought into a public health use. Public-private partnership plays a critical role. As you rightly said, these innovations are not money-making ventures, and there where government funding agencies, philanthropic funding agencies play a very critical role to see how we can literally take innovations and at the academic institutions level, then validate, and these innovations which come out from the academic levels needs a strong validation. Now, as she also mentioned, narrow data sets will not be a good, so you have to have a very good strong data set, good algorithms to take it to the next level. So I think what we at the foundation, and not only we at the foundation, we will be working with many other like-minded foundations and the government and other people to see how we can look at these academic innovations. That is why we are creating these hubs. This year we plan to establish 10 hubs, and then slowly it increases as the year passes. And we look at good innovations of pick up or farm good innovations at the academic level, then connect and create teams. These academic innovation needs to be created to teams, whether, the ecosystem needs that innovation or not. So a clinical, setting needs to be validated, and then it will be further validated, creating a strong data sets. And as we move forward, when it takes, and here the public-private partnership plays a critical role. As I said in the beginning, we need to invest and then bring these partnerships to a level where I don't say a commercial exit is there, but see that these innovation literally validated and gets into the public health system. That is the critical element. For that, what we are trying to do is building teams for the academic researchers, a clinical partner, public health researchers, data scientists, and software people, a good ecosystem and team, help them to validate it, take it to a level where we call it at technology readiness level 7 or 8, where it gets strong validation, and then come back to, as Dr. Duggal also mentioned, to the policy makers, that this is what the innovation is, this is what the gap is. Now you decide whether you want to take it to the next level. So along this journey, we would like to, de-risk that innovation by putting our funds, getting like-minded philanthropic funders to join this initiative, and getting the other government agencies to fund it, to see that it goes to the level. Once it is validated, and there the job of these hubs will stop, and then the advocacy groups will take it within the system, will take it to the government, the policy makers, to see how it can be implemented. We can't push the system to implement it, but we can definitely bring out solutions to tell them this is the gap, this is the solution, whether you want to implement it, take it forward. So that is, as an innovation funder, our role will be to bring out solutions. But firstly, understand gap, look at the unmet needs, create these gap stories, develop solutions, build teams to develop solutions, take it to a level where it is a strong validation is done, and then come and put out publications, policy briefs and things like that to see how it should be implemented. So there you rightly said public-private partnership is critical. We would like to bring in our funds, we would like to create teams, and we'd like to see how this innovation moves to the next level. So that is what the model we are trying to see. And as I always say, these models, we are very iterative and iterative models. So we'll see how this model works when we move along. If it requires some tweaking, some changes, we will definitely try to do and take it to the next level. So I think this is what we are planning to do. And AI and quantum will be one of our critical hubs in the coming months and years. Thank you.
Thank you, Dr. Mukherjee. I think in both previous speakers, I think you've really emphasized validation and team building, which I think is probably a lot of us will resonate with, that it's not just developers or engineers. It's actually the implementation science goes along with development, and validation is a key component of it. Thank you for bringing home this point, and if time permits, we'll come back to this question again. But right now, I think we are very fortunate also that we have representation from the government, funders, from the international governments, agencies, but also industry. So would love to hear thoughts from you, Gaurav, about 1MG's unique position. It has a, I would like to call it, it has a pulse of the nation, right? And I don't know if you would agree, but there still may be some inroad to made into the primary healthcare with what you have. How do you envision, as you said, India for the world, data sets from India for the world, where it actually starts touching these lives at scale with primary healthcare? And being uniquely positioned, I think we would love to hear, how would you reimagine primary healthcare in the next 5 years with initiatives such as yours?
I think that's a really sort of hard and tall question to ask. I don't know if I'm even qualified to answer, but maybe I can share a little bit of the journey of what's our responsibility in this ecosystem. A few years back, we looked at basically the data that we were collecting. And as I'd mentioned earlier, there was a significant amount of AI and algorithm-led digitization that we were doing for healthcare data. And it was very clear for us, from the time we started 1MG, that while India is data rich, it's not really usable data. It's also been alluded, because a lot of the data is paper and documents and files. It's fragmented across different providers and players in the ecosystem. And fast forward a few years today, 1MG has for a large part, for the number of consumers we serve every year, for around 20 million odd consumers, we have their longitudinal data all digitized, standardized, on our platform in data systems with pipelines being built, etc. Right? When we talk about the kind of data we have, we went back and saw that we don't just have data on, let's say, the consumer, we have data on the families as well. Because once you start to use, let's say, an application like 1MG for yourself, you start to use it for your spouse, your kids, your parents. So we have we have sort of that lineage data as well. So we can infer what's going on in your family tree. We know what's happening with kids at an early age. And then we said, okay, what can we do with this data? Now, if we bring this in perspective and say, what is primary care? Primary care is basically access to, let's say, clinically valid information based on what you may be seeing symptomatically, etc. Once you've seen a doctor and you've gotten some tests done, maybe get some recommendations on what you need to get done. Once you get those tests, understand and interpret what those reports mean. And once you get reports, etc., maybe get additional inputs. Once you get all of this, then you need to be put on a plan that manages this on a day-to-day basis rather than leaves you. And I think one of the biggest challenges in primary care that we have, or at least that we see, is the transactional nature of the whole thing, right? Finding, especially in an ecosystem like ours, finding a clinician, accessing India's larger challenges around access and affordability. So finding a clinician who's qualified to look at your condition, to give you advice, to actually spend time so that they don't build a disease-centric or a condition-centric assessment, but a holistic assessment, not just on your symptoms, but also on your environment, on your activity data, etc. These are all really, really important things. And we actually believe that this is something that that only AI or systems can do. So coming back to how we reimagining healthcare, we're saying that so far people don't have access to multiple data points for a consumer in one place, right? We have access to prescriptions and diagnostics. We are saying we are increasingly bringing in activity data from, let's say, your wearables also in one place, right? The moment we do that, we probably become the only, let's say, platform globally that for a consumer can give you not just activity data, which is steps, heart rate, etc., but also biomarker data, prescription data, not just prescription data for you, but we can also infer, okay, your, let's say, parents have these conditions, how do we bring it forward? And make it understandable for you from a risk stratification perspective that if you're in this, if your family is in this state, if you're, let's say, at a certain metabolic profile, then what is your risk stratification? And then again use AI to build tools on top of it. And I feel that we are barely scratching the surface, because if you look at what's happening with some of the voice AI agents, models, etc., that it's mind-blowing what's going to happen. And I imagine a future, at least at 1mg, where talking to a doctor is basically opening your phone and starting to chat with your symptoms, right? The core challenge there is going to be, how do you make sure that the AI gives you information that is clinically valid? Because it is going to give you something, right? And so our challenge that we are facing today is, how do we give you information that is simple but correct? And how do we keep the AI agent, one step away from making a recommendation and actually hand you over to a clinician who's much more equipped, at least today, to make the right calls for you. Right now, all of these things are actually, they sound easy, and to some extent, I think we've been fooled by, the amazingness of LLMs. But once you start to apply LLMs, I don't know how many of you have tried giving your reports, etc., to ChatGPT and getting an output. But it may do it right for you, but it may not do it right every time. It may not do it right as you give it more and more data, and that's where the challenge lies. So for us, even figuring out how to give, and I'll give you this example. So we have a clinical team. When I get, let's say, a diagnostic test done, I go to that clinician and say, hey, explain it to me, right? And that clinician is beautifully able to pick the 2 or 3 things I need to worry about and then lay it out for me. Just getting that to be done by an AI, it's taken us over 6 months, and we are not even close to where we want to be. Because somewhere it's giving you this jargon of information, and it's leaving for the consumer to process. And if you reduce that jargon, it basically starts to become inaccurate. Right? So I feel that there are significant challenges, but I imagine primary healthcare to be driven by voice agents, where you can walk in and you don't need to walk around with your file. When a doctor says, okay, describe yourself to me from a condition standpoint, he already has a snapshot view of who you are in terms of your activity, in terms of biomarkers, in terms of your parents' history, etc., and you don't have to do anything. And that's really where we are trying to get to.
Thank you, Gaurav. I think risk stratification, which is clinically validated, if we can achieve that, I think that's a huge step for NCDs in India. And I think, as you said, it's a unique positioning which you have, and as you said, voice agents, and then of course building interfaces on top of it is something. This is amazing, I think, viewpoint in terms of taking it forward. I would really encourage, as we move, to think about these things, because we don't have risk stratification frameworks which are clinically validated on such data sets for public and primary health. I think that's a clear direction out there, which I believe we could brainstorm more in focused meetings, which should be one of these outputs. Thank you so much, Gaurav, again. I'll move to Dr. Dhwani. You have worked with underserved communities, and I think trust building there is probably one of the biggest challenges. Any personal experiences and anecdotes that you would like to share, and how did you navigate this in your work?
Thank you very much. So I would say, to build a trust within the community, underserved community, we should start where the trust of this community already exists. which is with the frontline workers, right? Because of any of the AI tools that we are going to eventually create, the end users are always going to be the frontline workers, whether they are ASHA workers, A&M, community health workers, local healthcare providers, right? So to me, if they are the one who is going to use this solution, let's build their trust so that ultimately we can, try to build the trust of the community itself. Because essentially they are the bridge between the health system and the population in question, right? So if we want to, in my opinion, integrate the AI within the primary healthcare ecosystem, first we have to, build the trust among these end users, right? Showcase the usefulness of this AI tool, and simultaneously build the capacity of these frontline workers so that the adoption and acceptance of such tools are, seamless. To my opinion, there are three ways to do this, right? First and foremost thing is start involving these end users at the time of ideation and conceptualization of such AI technology itself. We should be focusing on a people-centric design and think about how we can always keep human in the loop at the time of when actual intervention has to be done, right? Because this is the only way to showcase the trust, right? We can invest in user research, usability studies, involving FLWs, right? How comfortable they are in using this technology. Is the front end that they are going to use, is it user friendly enough, or it is very complicated, right? And the problem that we are trying to solve for them should be relevant to them, right? They might not be interested in a X-ray screening tool, right? But they definitely will be interested in some AI technology where we can seamlessly automate or digitize some manual reporting for them. And again, we have to be very transparent with them in terms of getting consent, data security, data privacy. So these are the ways to do this. Second most important thing to me is to invest strategically in digital literacy and AI readiness. In my experience, even in my past tenure, what usually happens is that, let's say a screening tool, AI-powered screening tool is functioning with the 90% of sensitivity, right? Even in this instant, out of 100, 10 times it is going to flag false positive, right? And there might be a real possibility that this 10 false positive might happen in sequential manner, right? So end user will be like, hey, what is happening? Like your solution is not functioning well. So we have to heavily invest in creating such AI readiness and digital literacy among these end users, because that is the only way, right? Again, there is another misconception in end user is that if it is artificial intelligence, it should be functioning better than the human intelligence, right? But that is not always the case. And even if the people, like a general people, the literate people, this is the misconception in their mind as well, right? So the only way to counter this is to ensure the digital literacy to the end users who actually are going to use this solution in terms of AI readiness as well, right? As Dr. Swati was mentioning about, like we have to think around how easy the tools is for the frontline workers to use, right? Third thing is that we have to demonstrate the usefulness of this AI technology. If I can give an example of quick commerce and UPI, even the semi-literate people are very comfortable using these things, right? We don't have to do a lot of capacity building around this, right? They have seen the usefulness of it and they automatically start using those technology by themselves, right? So it is very important to demonstrate the usefulness of such technology. So many a time what happens whenever we are doing the pilot demonstration of such tools, we are more, thinking in terms of whether the solution is scalable or not, sustainable or not, etc., etc. But demonstrating the usefulness while, focusing on the end user is actually going to help them. Imagine an ASHA worker, we can demonstrate that how quickly it's going to help them screen for the disease. It can help detect the disease early, right? It can automate various tasks for them. So trust is going to build automatically. So in conclusion, AI literacy, transparency, and continuous engagement with the end users are the key to, gain trust of the community and end user likewise.
Thank you, Dr. Dhwani. Thank you for reiterating the points on literacy, transparency and continuous evaluation, but also to bring in the point about the example about UPI, where just having institutionalization of involvement of government just brings in trust by itself. I think it's a huge point which Dr. Karthik Adapa started with, having governance as the key foundation layer, and we're coming back to where we can build trust. Thank you again for that. You've heard a lot of Indian perspectives, and we would love to hear from Dr. Nico about the Netherlands AI framework and trust frameworks. You've mentioned a few examples as well where lung cancer can be detected early, but I think how do you see this, where both India and Netherlands can benefit from each other's learnings, and some learnings that you can bring from Netherlands that we can co-build towards?
Thank you very much for this question. I think that one of the topics that was very much highlighted now is to have the right framework. For us also as a Netherlands, the framework for safe and also trustworthy, as I think various panelists have underscored, the importance of trustworthy AI. For us, as a Netherlands, it's not only what we do as the Netherlands, but the framework for safe and trustworthy AI is laid down by the Medical Device Regulation and the new Artificial Intelligence Act, the AI Act, which came into force on the 1st of August 2024, so not even 1 year ago. We see that it makes so much more sense to have these frameworks in a larger scope than only an individual member state like the Netherlands. We have been working very much as the Netherlands also to agree on this at the level of the European Union. And I think at that level it makes so much sense to then share experience with a country of the size like India, right? So the AI Act operates based on open norms, as was already highlighted by several of the panelists, among whom Dr. Karthik. That's very important, I think, and that's where I'd be happy to share further with panelists, but also with the audience, obviously. Now, the standards give substance to the requirements and are forming the foundation for safe AI. Now, these standards are currently being developed, so I think it's worthwhile to have this type of exchanges at this particular stage. The standards are currently being developed on an EU level, so European level, in collaboration with organizations like ISO and CEN CINELEC. In addition, and that's also where it's interesting between the Netherlands and India directly, in the Netherlands we are very active on working on a validation framework, as we also discussed now in the panel, for specifically the healthcare sector, which is being developed from within the sector itself, so both public and private partners. So I would say, I think we all agree that it's very important to have clear rules for both the development but also the use of AI systems, to have a safe system which also takes into consideration fundamental rights and values, right? And therefore it is also important to have clearly identified risks. At EU level, we have identified in this AI Act 4 distinguished specific risks. First of all, what we call unacceptable risks. Those are, for instance, you can think about manipulation through AI or social scoring. The second category is high risks. The third category is transparency risks. Think of chatbots, for instance. And the fourth category is low or minimal risks, like spam filters, for instance. So if you're, for instance, in the second category, the category of high risks, a set of requirements have been established and where we have agreed at EU level on what these are. Think of a risk management system that has to be implemented by the AI developers, but also ensuring the quality of input data. Besides human supervision and keeping technical documentation. So this will be implemented in a phased way. And obviously, as also Dr. Kartik told, we have set up an elaborate governance system to make sure that this is enforced in the right way. I will not go too much in detail about governance, as Dr. Kartik said as well, but if you are interested, I'd be happy to give you more information on how we set up this governance at EU level. So those are, I think, a couple of elements where I think both the concerns, but also the ambitions that I heard, it makes so much sense on where we stand in the development of AI and the wish to have it both developed and implemented in both a safe, but especially also trustworthy way, also at community level. That makes so much sense that we continue these exchanges together. Thank you very much for the opportunity.
Thank you, Nico. Thank you for reiterating the role of clear rules and frameworks, but also for risk stratification. For AI, Dr. Mona is, I think, may recall, we've been a part of these conversations so many times that we need to evaluate these. We cannot have a blanket term for AI. We have been talking AI as a blanket term last one and quarter hour, but essentially AI can have such nuanced meanings, and the risk stratification framework is something that I think we need to co-develop. Thank you for those inputs. I'll come to Ms. Anita Singh, being at the Bill and Melinda Gates Foundation. You have seen so much happen, I'm sure, in the primary health setup, with the last mile gap needs to be bridged, and specifically working on that. So how do you see the social readiness of AI? Not just a technical, again, it's a similar question that we asked before as well, but from your foundation's perspective, are we socially ready for AI?
Thank you for the question. I'm going to take a step back because you said we've been using AI at a very high level, and synonymously you said with LLMs all the time, right? I want to come back to the point Dr. Kartik made up front on the digitization journey. I work a lot at the state level as well as with the Ministry of Health, but if we unpack primary care, which is what we're talking about, right? We're talking about the comprehensive primary care, 12 service packages, right, from the frontline workers. And, you know, we keep talking about frontline workers, and I realized that, I mean, at least in UP, the ASHAs were just, 160,000 ASHAs were just given phones 3 years back. They're just, even if you go down across different age groups, they're still learning the digital literacy component that we talked about. They're still learning how to navigate using the phone itself, right? That getting then, you know, layered and layered with a lot of different applications which we love to roll out. That in addition to the manual registers that we have. And then we say, let's create an AI tool to assist them. I mean, the irony is not lost on anybody on what is it that we are really assisting. That's number one. The second point I wanted to make was that health system strengthening, we need to be cognizant of where the resources go, right? And here I'm going to specifically talk about financial resources. And a very good recent example I saw was with the Ministry of WCD, where, you know, there's a frontline worker AI assistant tool we are supporting. And Bhushan tracker, as many of you may have heard, is the Anganwadi worker, frontline worker tool as a job aid tool, which replaces 11 of the registers that they use. And, you know, they said, okay, let's test this out, but let's also do a cost-effective study of what is it that this is going to contribute if I were to put that money for the next 5 years for such a solution. So, I mean, that kind of thinking makes me really, it's promising that, you know, we're not going to make the same mistakes of digital that we did in the past. We're going to be intentional about where we are going to deploy AI and where we are not. Unpacking AI itself, we've been talking about data sets more broadly from an AI perspective, but states have huge amount of data already lying around, right? Can we just help them with basic ML analytics to first start using that data, layer that with a conversational chatbot so that where a block officer goes into the field and does a random check, it's conversational for him or her to like look at the data, use it for their work, use voice to text as we've been talking about, or voice to discrete data, however you want to call it, to play back so that it becomes something useful for them when they go into the field. Otherwise, these reviews that keep happening, they just become burdensome. But can we make it a little more easier for them? So I think the first point that I wanted to make it, let's keep it simple. Primary care itself is so complicated. We need it to be an enabler, and in the true sense, make it an enabler, right? The last point on this is, I think the digitization on the care continuum is still not done, right? The PHC guidelines and the primary healthcare guidelines that had come in was supposed to talk about backward-forward referral. We're still not done on that, right? So when we want to use AI, we need to be, am I on time?
No, I think we have time.
Okay. It's like, did it get too real?
Proportionate time.
I can then wrap up in a minute?
Oh, no, you have time.
Okay.
This was not, I think this is 15 minutes to go. We officially have 15 minutes, so we'll try to. Thank you.
Yeah. The second point I was going to make, it got too real, I think. The second point I was going to make was more on responsible AI. And, it's been really amazing to learn about the different frameworks that exist, the work that's being done. I think the role we see ourselves playing in the ecosystem is the how, right? A lot of times we're working with grantees and we'll be like, please validate this effectively, work with the respective stakeholders. They're like, how? What is good enough? What is it that will lead me to, get that, get through the HTA or get procurement guidelines in place? So how am I going to reach there? And I think breaking that down and simplifying and working with the different stakeholders, even today on the panel, will make it useful and much more seamless to actually build this and, maintain it and then make it a part of the primary healthcare setup. Otherwise, we'll keep testing out products which we think are useful, but then they'll never reach scale. The third part I wanted to quickly come in on within responsible AI was gender bias. Bias broadly while we're annotating Indian languages, but also gender bias, right? I was talking to somebody and we did this study on gender bias across LLMs, across the entire value chain. And I was talking to one of these founders and they were like, so simple. We realized when we rolled out our solution that we didn't have any woman on our prompt testing team. So when a woman asked a question, of course, there was like such a big hidden bias because I didn't have a woman who was actually preparing the questions. Very simple, very straightforward, but gets missed, right? So can we start talking about these best practices and working with academic institutes and the government to actually make this principle much more useful and much more easier to be able to do? Within that, we're talking about large language getting collected, data sets getting collected, etc., right? Organizations like Karya, and these are the investments which I think hopefully can develop models to actually pay for such language getting collected, right? When women are actually given so many hours, how do you actually benefit them from a livelihood perspective and not just be extractionary when you're thinking about some of these data sets? I think that is also a role that I think we can play. Lastly, I'll just talk about making it a little more tangible. And I think Dr. Mona had alluded about some of this a little bit, that we need to decentralize some of this so that while we have the right kind of frameworks in place, but can we set up sandboxes, validation techniques, tools, so that this can actually be taken to scale so that there are no siloed and non-standardized ways of actually approaching this problem statement when we are actually scaling AI solutions. But we're thinking about it much more holistically, keeping in mind the standard treatment guidelines, clinical guidelines, and protocols. I'll pause here. I hope I'm on time.
Thank you, Anita. Absolutely. Thank you so much for those very valuable points. We will try to come back on some of these, but for now, I think I'll request Madhav on your viewpoint on what are the again, repeating what I asked Dr. Mukherjee as well. Primary care is not money making at the outset. What are the novel investment strategies India Health Fund has been thinking of where you're supporting some of these to be rolled out at the primary care? How do you assess these models, tools, and what's your viewpoint on building such solutions for impact?
Thank you. So our approach starts with identifying need gaps in primary care, where solutions are needed and not available or inadequate. We use those need gaps to then identify use cases, and we do that in collaboration with many of the people in this room, as well as medical professionals. Because the use case where AI also have a very clear view on the long term, and this is a filter we put in before we start funding. Our funding is to the private sector. So does the organization either have the intent to price for sustainability for public health, and that is one of the conditions we have for our fund. Does that that's an access condition. Does that pricing ensure long-term viability of the organization? And do they have other revenue streams? We also encourage these organizations to valorize the work that we are supporting through the private sector. Because that's where differential pricing can have a role to play. So financial viability is very central to it, but also the long-term sustainability of the organization. That's why we also then work with venture funds. With the hypothetical question, would you invest in this case? And if we de-risk this development and amortize the development, would it make it more investable? So that sort of defines our investment thesis, but that's not where we stop. I think many of these speakers have already mentioned this. Data access is a challenge. And market access becomes a challenge. So we've learned from experience, and we now insist on having an anchor user for any, not just digital, but AI, especially AI-enabled solution. And that anchor user is typically a state government or a municipal corporation with no commitment to start using it. The commitment we seek from them is to co-create, provide data access, and provide market access, particularly for validation, user training, implementation research, everything that many of the speakers have spoken about. And this is where it starts getting interesting. For many of the areas that we work in, science is well established. Tuberculosis, vector-borne diseases. The state health officer, the NHM, the district health officer know exactly what is needed, and they can tell you about it in their sleep. And there have been great guides to the developers on that, particularly from the point of view of ensuring diversity as well as data access. Where it's equally unclear is in emerging areas. We're now very active on the adaptation of health systems to the impact of climate change. This climate science is evolving. The understanding of the impact of climate change on human health is even more nascent. And how that's manifesting in primary care is very, very new. There is no accurate, reliable data in this country for many of these areas. And this is where we've seen, even though we have very willing partners in a few state governments who are working with us to develop a climate and health vulnerability index, their understanding and knowledge just doesn't go far enough. So we're now also working with leading research institutes in the country as well as outside the country wherever we see the knowledge evolving, to make sure that in areas where the science is still evolving, we're able to build that in particularly to the kind of data that is being used to train models, as well as the diversity. And this is still an evolving area. Antimicrobial resistance is also something where we're seeing some similar experiences in primary care. Data access is just not there. The understanding is limited. Lastly, it's not just enough to support development, validation, and have something fantastic. I think Anita mentioned the 12 programs that primary care centers work on. They're constrained by that. AI doesn't necessarily fall within the very rigid boundaries. And AI-based solutions don't fall into these boundaries. So it's equally important then to have regulatory pathways. And software as a medical device does not have a clear process for regulatory approval yet, which makes it incredibly challenging, particularly for the public sector to start adopting AI-based solutions at scale. The private sector has more flexibility, and this is now what we're trying to enable. Evidence-based approaches are necessary, but there also has to be a clear regulatory pathway that allows the public sector to adopt, along with an effective business case. And that's where health economics starts playing a role, because that's what the finance ministries start looking at in every state. How does this compare with the current standard of care? And is there a strong enough case? And it's pretty variable across states right now. So I think these are the many things that we are doing with learning along the way. And we really welcome, I think, as many partners as we can bring into this, because it's not just about funding. Funding is needed and multiple sources of funding are needed, but there are many other areas that are equally important to make the funding effective.
Thank you, Madhav. That's an extremely lucid, I think, a landscape of canvas of what you present, what you just presented as a thesis of how you approach this. And I think certainly a lot of conversations should happen along these lines outside this room, in this room later. And we hope to come out with the follow-up of this in a much deeper. I think we can co-create some of these things together. Dr. Kritika. Leading the Center of Excellence in Healthcare, huge responsibility. Your solutions that are you've been building as aims and your expertise, which is top-notch in the country, building for mammography. What do you see as, how do you transition this into the primary healthcare? I know you've been doing a lot of work at the interface of what's been talked about, but very personal anecdotes about your experiences in building and transitioning this into primary healthcare settings.
So I won't talk so much about mammography because that's never going to really be a primary healthcare solution ever. But a little bit about our approaches as far as the Center of Excellence itself is so I think that's the second bell. We should definitely be very brief. Okay. So yeah, but I'll be brief in the interest of time. But a little bit about the approach to a lot of the things that have already been highlighted by all the panelists, and how are we thinking of it as far as the Center of Excellence is concerned. Firstly, what is it that we want to build, I think, is often a question which we don't really answer correctly. I mean, in the sense that often what we want to build is driven by what kind of data we already have, which often does not actually address the problem on ground. I mean, when an academic researcher actually starts today, they look at, okay, I have a ton of data on this, so let me build a product. And then later you end up with a product and you're looking for a use case and you're looking for a problem that it solves, which is why it dies its natural death. So one of the first filters we put is that, try and align yourself to the national healthcare programs of the country, because the health system already kind of tries to address a certain set of problems. So if you address those, you're probably doing well as far as the health system is concerned. Second thing that we said was, you really can't change systems. So you can't come up with a new device and expect a system to actually adopt this new device. You really have to stay within the system. So who are you targeting? Who is your end user? Are you building something out for an ASHA worker? Is it for an A&M? Is it for a doctor who's in a district medical hospital? Is it for a tertiary care center? This is something that you need to think through right at the beginning. This thinking cannot happen at the end. So we said that you have to necessarily align to the systems that exist within the country today. And another point that was already highlighted very well by Anita was, really, does it need AI? I think, just because we're a Center of Excellence for AI, it really doesn't mean that you keep building out AI for things that, you don't want to use a machine gun to shoot a mosquito. So you really need to first question whether AI is required at all. But even on the other side, when you look at the entire problem holistically, there are some problems that can be solved in it by technology and some which are completely non-technological solutions. And if you don't solve the non-technological parts of this problem, you will fail by default. So you have to look at the problem holistically and solve every part of the solution. For example, since you mentioned, personal sort of anecdotes, so when we start building out, solutions for ultrasound, for example, the most common reason why you would miss a lesion on ultrasound is if you didn't cover it when you're doing the ultrasound. And ultrasound is something that a doctor does. So if you want to scale this down to a primary healthcare solution, you have to find a way of guiding the person doing the ultrasound. So, so what we came up with is completely non-technological. We said, let's color the ultrasound jelly and let's make it blue in color and ask the user to actually paint the breast, in this case, blue. So simple solutions which are actually very cheap, very sustainable, can come from a completely non-AI and a completely non-technology space. And we have to sort of broaden our thought process to allow us to think of solutions which are not at all AI and not at all technology at all in the first place. Another thing that was again highlighted was the acceptability on ground of the user, the end user. So I was just recently reading about this example from Karnataka where an ASHA worker app was built. And everybody expected this to be very useful because it kind of makes, in controlled studies at least, made the ASHA worker more confident about what she's saying. But then when they went on ground, they suddenly saw that the ASHA worker just didn't want to use this. And when they went into the why, the app was speaking back to the ASHA worker, which made the user think of the ASHA worker as somebody who is not knowledgeable. So she's just getting some information from a phone which she's passing on, and that took away her sense of control or the pedestal that people would put the ASHA worker on. So very important to keep our ears constantly to the ground, because you might think you've built out something really good, but due to completely non-technological reasons which you just didn't foresee, it really may not work. Another example from the NCD portal, where you thought you've digitized everything, now everything is on the app, so you just have to fill in your CBAC forms or whatever you want to fill on your phone on an app, which makes it so convenient because you can make so many copies of it, you can send it, you can share it with people. And suddenly what we found is that when this was imposed on ground, the ASHA worker continued with filling it out on her paper, and she would get it back, and you had to employ data entry operators who would then copy this onto the portal. So questions like this, are complete, not everything is something that you can anticipate right at the beginning, but while you deploy, it's something that you need to constantly kind of keep your ears to the ground and keep evolving as you go forward. So it's not one solution, you need to keep sort of working on the solutions. Data was another thing that's been constantly highlighted. It's not like we, have a solution to it, but just a little bit of effort that we're putting in towards the data is there are some very nice government-owned databases that have come up recently. The IBIA by the Department of Biotechnology, MIDAS by ICMR, the AI Kosh by the India AI Mission. So we're trying to contribute to all of these, and we look at all the data that is collected, at least most of the data that's collected as a part of the Center of Excellence, as a digital public good, which can be potentially released on all of this for the sake of the larger good. I'll stop here.
Amazing. I think that's amazing work that you are spearheading. Would look forward to wonderful outcomes. But thank you for emphasizing the value of workflows and keeping the ears on the ground. Last but not the least, Dr. Varshatanu, I think you have worked extensively, as you mentioned, with Rajasthan on the ground and worked with essential design principles that are important at the PhD level for inclusive, gender responsive, reflective of local realities. Again, how did you approach this, and are there some learnings that you would bring to this conversation that we can take forward?
Okay, so at the beginning of every speaker, there's a music. So let's take it as a music. Yeah, so thank you for this, for this final, this kind of experience sharing. So I'm not at all, don't mistake, as if I'm a pessimistic person, but I'm not at all a pessimistic person. But then, I mean, since you have asked me to share my experiences, and as I told in the, my introduction, that we've already tried this innovative, innovation-based Scale Rajasthan project on PPP basis. So 22 PSCs were given on, remote PSCs were given to private partners, and initially they were spending the entire money, and after that government was supposed to share 50-50 of the resources. Then we just tested with the health ATM, and health ATM to for testing the device, we installed the health ATM in the medical directorate at the capital Jaipur, this thing. And then there all the everybody was encouraged to come to visit the smart dispensary, and we named it Smart Dispensary. And all the devices like HemoCheck, non-invasive, this iris-based hemoglobin meter, and then other devices also. But the thing is, here we have observed two approaches, though we could not sustain it in spite of government's partnership. But as Swati said, and Kritika, Anaita, because problem was basically of the mindset, not the technology, because definitely Rajasthan is a vast state, and many of its areas are hard to reach. Desert, then hilly area, tribal area, dung area, and those things like that. But it has, I mean, it is one state known